Parliament, I, Dr. Manpreet Kaur, warmly welcome you to PHTS 2026. Over the course of the day, we will explore not just about the public health has been, but what it has must become for the 21st century. Recognized by MITI as the official pre-summit event of the AI Impact Summit 2026, today's summit is not designed as one-off conference. It is intended to be the beginning of a continuous dialogue on the future of public health, a space where we acknowledge what is not working, re-examine what we are still building on, and start shaping what public health should look like in our time. Before we move into the sessions, it is important to speak about the institution convening us today, Health Parliament. Health Parliament is defined by a motto, real work, great leaders, right policies. This is not just a tagline, it's a sequence. Real work, when Health Parliament identifies a gap in the system, it does not wait for others to act. It convenes the stakeholders who matter, does the groundwork of building consensus, and deliberately moves outcome along a clear pathway, from discussions to ideas, from ideas to projects, and from projects to policy. Great leaders, over the past few years, the systemic nurturing of public health leadership has been insufficient. The summit is in many ways a response to that gap. Today, we lack a strong pipeline of future leaders we can rely on to shape the public health system we need. One of Health Parliament's core priorities is to make next generation of public health leaders. Right policies, once we do real work and nurture great leaders, result will be the right policies. Policies that are fit for 21st century, rooted in evidence, and oriented towards population-level impact rather than incremental fixes. When Health Parliament finds that something crucial is missing in global or national health discourse, it does not sit still. It convenes, it collaborates, and it creates. The summit is a continuation of that approach. Whatever you say, share, or question here today will feed into an action report and into Health Parliament's broader global mission. Before we jump into the sessions, let's quickly go over a few house rules to ensure everyone has a smooth and engaged experience today. For engagement throughout the meeting, please use Mentimeter to participate in polls and submit your questions. There is no need to download any app. Networking opportunities are available during the tea, coffee breaks, and lunchtime. When posting about the conference, don't forget to use the hashtag PHTS2026. If you misplace your entry pass, just show the email with your QR code at the registration desk to get the duplicate badge. Speakers are requested to stick to the allocated time. No session may exceed 5 additional minutes, as 10 to 50 minutes are reserved for audience Q&A. For all our panelists, you are welcome to use the mic placed at our seats on the stage or come up to the podium while speaking, whichever you are more comfortable with. Certificates will be emailed within 15 days of the event. Nursing professionals will receive 5 CNERs or 1 CNA credit. Lastly, we request everyone to keep their phones on silent mode. Please use them only for participating in Mentimeter or essential use during the sessions. For assistance, reach out to the organizing committee. The Health Parliament team is here to help. So the meeting here today has been making for years, and the trigger for many of us was the experience of COVID-19, which acted as a kind of a great reset for healthcare. Historically, we have tended to respond to crisis episodically. A pandemic arises, we address the pandemic. Outbreak occurs, we address the outbreak. But the public health organizations that are supposed to protect populations before, during, and after such events have been left old and outdated. The definition, direction, and design of public health are changing, but our system, curricula, and institutions are still tied to an older paradigm. We know that public health has made enormous contributions, yet we see mounting evidence from local outbreaks to large-scale crises that something fundamental needs to be changed. Throughout the day, we will not only listen to some of India's and world's most respected public health leaders, but we will also invite you to speak in our open mic session. We are honored to be joined today by a distinguished line of speakers and panelists. Leading the summit as a chair, we have Professor K. Srinath Reddy sir, founding president, Public Health Foundation of India, a globally respected public health leader and preventive cardiologist, former head of cardiology at AIIMS, New Delhi, health advisor to two state governments with cabinet rank, physician to two prime ministers of India, and recipient of Padma Bhushan and WHO Director General's Award. And as Summit co-chair, Dr. Rajendra Pratap Gupta sir, founder and chairman of Health Parliament, is a key architect of India's National Health Policy 2017 and National Education Policy 2020, a former advisor to the Union Health Minister and a global leader in digital health. He has shaped major national initiatives, including the Viksit Bharat Abhiyan, and has been engaged by leading multilateral bodies such as UN, WHO, World Bank, and the Commonwealth, and leads UN-aligned coalitions, serves on international boards, and is a widely published author and speaker. So moving on to the first session, Public Health from Evolution to Revolution. So to create the future, we must first understand the past. So our first session, Public Health from Evolution to Revolution, takes us back to the history of public health, to the milestones, ideas, and revolutions that have shaped societies protect health at population level. Public health is not new. What is new is the complexity of our challenges and the pace at which they evolve. The conversation will explore what public health has already achieved, what revolutionary shifts have taken place over the time, and what lessons we must carry forward if we are serious about redefining public health for the 21st century. I request our summit chair, Professor K. Srinath Reddy sir, and co-chair, Dr. Rajendra Pratap Gupta sir, to please join us on stage. Ladies and gentlemen, please join me in welcoming them with a round of applause. So to begin this session, I invite Professor K. Srinath Reddy sir to share his opening reflections on the evolution of public health. Over to you, sir.
Good morning. When Dr. Gupta told me this morning that he has a PowerPoint presentation to make, I was hoping he would precede me in speaking. Then I would be able to say, I agree with everything that he has said, and because I know that he is going to be very, very comprehensive. But he has asked me to start, and so I shall, but I'll await his wisdom to enlighten us on areas that I am sure to miss out. As far as public health is concerned, firstly, there is a certain amount of confusion as to what public health means in the minds of people. There are many, many people who think that it is merely something to do with some sanitation services, occasionally vector control, when people come to check whether there are malaria breeding sites in your home or not. And in fact, one of the former chief ministers of Delhi, when we went to meet her, when the Public Health Foundation of India was being started, so she asked the chief secretary, a senior IAS officer sitting by her side, what is public health? And he said, wo jo sanitation water wala hota hai na, wahi hai. So we had to sort of explain to her that public health is certainly involving water and sanitation, but means much more than that. But then there is also a certain amount of confusion in people's mind as to how different and distinct are clinical medicine and public health. And since I've traversed both the fields, it is incumbent upon me to try and explain that they are not two different worlds, that they are a continuum, and hopefully a coherent and congenial continuum. If clinical medicine delivers health in retail, then public health delivers health in wholesale. The definitions of public health have been very many, but The definition I prefer to use and the Public Health Foundation of India has adopted at its inception is that public health is the cumulative science which draws upon multiple disciplines to identify and influence the many determinants of health at the population level to impact upon and improve health at the individual level. So, population becomes the unit of observation and intervention in public health. But this again, as I said, is a continuum. If a clinical doctor sees, or a nurse sees, or a community health worker sees a person with a medical problem or a health problem in a healthcare facility or even in a community setting, that interaction is limited at that point in time to identify what is ailing the person and what can be done about it. But what are the antecedent causes which actually made the person ill? What were the barriers that prevented that person from coming earlier for observation and care? And what are the barriers that are preventing early referral to a different level of care? These are things that are also very important. And similarly, even after the consultation is over, when the person is advised treatment and leaves the place, are the medicines available, affordable, adequate quality, safe to take, and is there supportive nutrition available in order to help recuperation and recovery? Are there facilities for isolation of somebody who might be infecting others? And is there an opportunity for rehabilitation and palliation when needed? These are all important issues that flow out even after the person leaves that clinical care facility. And to tie up all of this together, we need a very competent health system which is effective, empathetic, economically efficient, and likely to provide all the nature of services that are required. Now, that is where public health comes in. In order to try and create that overall system in which we can deliver all the services that are needed by the population so that the individuals in that population can benefit. Now, therefore, the public health would have to be defined with the population in mind, but ultimately strongly keep the individual as the beneficiary. But the determinants of health are very many. We know that health is determined not just by what's done within the health system or the healthcare system, but there are so many other determinants which are social, economic, environmental, commercial, and now increasingly additional elements are coming in terms of new technologies, which are also influencing the way health is actually determined. So, trying to tie up all of this requires a broader public health architecture. It is believed that public health commenced in the modern origins of public health commenced when John Snow pulled out the handle of a water pump in Broad Street in London when there was an outbreak of cholera, and people at that time were attributing all the illnesses, including that outbreak, to miasma or bad air. Certainly bad air was a major problem in London, and however, he decided that he was going to investigate and found that the infection was spreading in concentric circles in areas around that pump. And therefore, he thought that the pump must have something to do with it. And then he went and took off the handle of the pump and the outbreak stopped. Now, the origins of modern public health, as it were, started with an act of vandalism, of breaking public property, not to be encouraged by other practitioners of public health, but certainly shows the importance of water and sanitation. But this is not something that is totally new in terms of public health. Even in other parts of the world, whether it was ancient Rome or Greece or India, we have seen that city planning took into account waterways, sanitation, food systems, all of these, and we have been told that health is not determined only by what the wife does, but by our environmental factors, our nutrition. So the integration of all of these determinants was always there in the experiential wisdom over the ages. But to codify it into a science, to bring multidisciplinarity into it for multisectoral application is what public health has now done as a modern discipline. As far as India is concerned, I think the history is going to be traced by Dr. Gupta. But we have had tradition of public health in terms of institution building, in terms of our own health systems, and trying to bring together multiple disciplines in order to implement public health measures, whether it's malaria and vector control programs or whether it is vaccination programs. We have seen public health in action over the years. However, public health has not received the kind of attention and funding that it needs in terms of other programs, and certainly not in terms of institution building and capacity building. And that is a price that we will be paying if we continue to neglect it, that we will have the kind of problems that we see in terms of even poorly functioning healthcare systems, as well as outbreaks which are not recognized early and not effectively contained. So these are some of the things that we do need to address. But equally importantly, there are other areas that we need to look at when we talk about public health. Universal health coverage, for example, is a very important element, that where we think that every single person residing in this country, whatever be the age, gender, or geographical location, must receive all the health services that he or she needs at any time in the life course. And that means these services must be provided in time, must be of adequate quality, and must not cause financial hardship to the person who is actually trying to access them. Now, we know that this requires focus on two particular measures. One is service coverage and other is financial coverage. And there, public health has to make sure that whatever the governments are doing and whatever the rest of society is doing is also going to be geared towards ensuring that these two measures are effectively met. But there's also the misconception that public health is entirely a governmental affair. It's not. The government is one of the key players, but public health has to become an all of society effort. There has to be a citizen engagement all through. And unless we make sure that there is that kind of people's participation, we are not going to see public health in its true measure. And that's where a parliament like this is absolutely important, because multiple stakeholders will have to be engaged at all stages, right from the design and delivery of policies and programs to their evaluation, monitoring, and rectification. So that is where it has to become a much larger affair with everybody being engaged. What we need is people-partnered public health and digitally enabled, decentralized decision-making at the district level. And for this to happen, we need a people's parliament in which there is active engagement and ensuring that the policies are made in the right manner. There we have examples elsewhere. Indian experience is going to be narrated by Dr. Gupta. In Thailand, for example, there is a national health assembly every year where delegates are drawn from the government, from the civil society, which includes the private sector, and from the academia. They call this the triangle that moves the mountain with these three stakeholders. And the progress or the lack of progress in programs the previous year are fully evaluated, the roadblocks are identified, and they're rectified in the following year. But the new programs envisaged for the next year also are designed there. So there is ownership of all the key stakeholders in society. And we need to bring that kind of a parliament into function if we have to move public health along. And that becomes a very important element of ensuring that there is a Jan Andolan, as the Prime Minister calls for. So I believe that as far as the Parliament is concerned, it has to reflect different sectors of society, different viewpoints, but ultimately we'll have to be committed to the common goal of ensuring that India's health advances in a manner that we can feel proud when Viksit Bharat is announced as a fully developed country in due course. We will have attained our goals, and every citizen has the opportunity to lead a healthy and productive life. And we have set those goals. We said by 2047 we must attain a health expectancy of life expectancy of 85 years and a healthy life expectancy of 75 years. Appears a bit of an ambitious goal, but entirely attainable. But it cannot be attained if we only depend upon clinical services and disease-related care. We have to ensure that we are promoting a healthy society, that we have adequate surveillance systems to detect risk factors and disease-causing agents. We have the ability for early detection of disorders and effective initiation of effective care in primary care settings and referral to other settings only when absolutely necessary. So again, to build a very strong primary care-led universal health coverage is going to be absolutely important. And here public sector has to be strengthened as well. We need a public sector-led integrated healthcare system where all the other partners come in, but the public sector has to take the lead in determining the terms of engagement of different partners and actors. For all of this to happen, we need active citizen engagement, and the citizen parliament has to articulate our ambitions for the future, but also remain on alert to track the progress as we move along. And I believe this particular assembly that Dr. Gupta has brought together is going to be very important. And since the assembly is mainly geared towards participation of youth, who are actually going to be the people leading our march into the future, and whose future is integrally related to how healthy their generation is going to be, I think it's important that we discuss these issues in an open manner so that they can actually identify where the fault lines are and what corrective measures need to be taken. And when we are discussing the fault lines, we need not be shy of discussing unpleasant facts. There'll be some numbers we'll not be proud of when we discuss India's health status. There's been a remarkable improvement in India's health status in recent decades, but still there are several shortfalls. We are still falling behind our neighbors in South Asia, and there are very many ways in which we are falling behind even in our march towards SDG targets. But if there are some areas where we are going to feeling a little depressed about, we need still to take action to correct them so that we can get back onto track. And that's where the People's Parliament will help in bringing us together. As I said, if there are data points that do not appear very appealing or pleasant, we have to accept them and then take corrective measures. India's national bird is the peacock, not the ostrich. Thank you.
Thank you, sir, for setting the context and for your insights for the public journey of public health. Now invite Dr. Rajendra Pratap Gupta sir to share his perspectives on how this evolution must translate into public health revolution. Over to you, sir.
Good morning to you all. Sometimes leaders like Dr. Srinath Reddy, to whom I am wholeheartedly indebted, not just in influencing the shape and the direction of public health, but also helping shaping the summit, make my job difficult rather than easy. The way he speaks, after that, I don't have much to speak, even if I have a PowerPoint. And that's exactly the reason I needed to have a PowerPoint. But I must thank him for first, sir, putting public health to spotlight in India, which you did during your decades of work. To the people who joined us, supported Ministry of IT for designating it as a pre-AI summit. Your Excellencies who have joined, we are overwhelmed with the support. We have 13 countries who have joined us, diplomats. I think the challenge of speaking is that while public health is needed, and he very rightly, succinctly, which is trademark style of Dr. Reddy, that clinical care is retail, public health is wholesale. But also we need a holistic approach to that. How do we do that? And that is where I think his role comes paramount. How many of you here are formally trained in public health? Can you raise your hands? Which is very interesting. And I guess all are working in health. Good. So this is our history. One thing you will notice that in public health, if you look at, we always have to look into history to chart our course for the future. These are the pandemics, and you can see how things have changed over the centuries, decades, and now years. We haven't learned from the past, looks like so. So what used to happen in centuries earlier came down to decades, now is happening every year. We still face it. We are a resilient race, so we always try to find solutions. Well, they may be short-lived, but they are solutions we find. But one thing is becoming increasingly clear, though science is advancing, political science is not. So we always have this dilemma. But that's where this history is. But beyond that, what happens? Of course, it is interesting to see what has happened. And I'm covering some of the reports that had a profound impact on public health. And it's important for us to understand. So first time in 2014, we bought Swachh Bharat mission. I don't know if it's very, very clear, but I pulled out the page 24, 25. I was the author of this document. And in health, we put Swachh Bharat. We talked about sanitary, we talked about sewage, we talked about potable drinking water, air, mosquito control mission, many things. So while health budgets on particular with health is looked upon for the clinical side, but here if you looked at the health section of the election manifesto of BJP, it talked about public health under health and not giving it on various ministries. So the first pick was, I felt that the political leadership was committed to public health of this country. That was the first big change. Of course, that time many people told that these are paper documents, no one bothers to look at them. But I think substantial things have got into, putting piped water. Of course, there is challenges remain because it's a huge country of 1.45 billion. But the direction is clear, the funds are being allocated. Of course, execution could be a problem, but there is a difference between government and administration. I still would say, since it's a public health summit and we are all supposed to speak the truth, no matter how harsh it appears, bureaucracy is still bureaucracy. That's the big impediment. The next thing was that came out was the National Health Policy again, which again clearly articulated the goals, putting public health in focus. And this is an important report. If you talk of this century, this report played a key role in putting spotlight on public health. We all drew inspiration from this report. And how many people know who was the chairperson of this committee? Can any of those who study public health, can you answer it? Dr. Srinath Reddy. A big round of applause for him. So he is the one who chaired the high-level expert group on universal health coverage for India, which actually put the spotlight on universal health coverage. No matter how much credit you give me for authoring those first two documents, without that document, this would not have come. I would encourage you all to read that, the way he has looked at healthcare, way he has looked at public health, preventive health. And he still remains an inspiration not just for India but for the world. For those who want to do things in public health, his work is actually a template to look at. Sir, I cannot have words to convey my gratitude, but it is the work that you have done. So for this century, the way you have put the spotlight on public health, rest of the policies, whatever we could understand, whatever we could understand and write, and then bureaucracy understands still less of that, they're implementing. But hopefully, we are in the right direction. The speed and scale may not be as what you would have envisioned, but certainly with the constraints that the country has, things have positively moved, because we still have the world's largest insurance scheme. We also, despite odds, so those who are in public health making a career, at some stage you will be on such stage speaking, you will understand that in a big country, resources remain a challenge, but that should not constrain our thinking for sure, because thinking has no constraints on resources. When we were drafting the digital health mission, a lot of people told us, in this country there is no electricity, you're talking of digital health. See, it went off. So, but still, we ended up doing our stuff. We didn't stop. And I'm going to share with you what happens after you do all that. So we still created, Sunil is going to deliver the next keynote, the CEO of the PMJY, and we have 840 million ABA IDs. We have 440 million digital consultations. We have 2.2 billion vaccinations coming out of COVID. We have UPI, and look at the number of transactions, 752 million a month. I mean, I can keep giving you the scope this country has achieved, and I'm now tying it to a particular government. Look at Aadhaar, 138 crores. People have a health ID. So I think we should not get bogged down by the challenges, but able to deliver that is what is called leadership. He had the vision much earlier to say we need a high-level committee on universal health coverage. Whatever it was, today 550 million people enjoy PMJY scheme, they're covered. If you add the senior citizen scheme that was launched, we add another probably 150 million. So just imagine what first vision can do. And that's where I think all people who are in public health, it is very important to look at what have been our constraints, still what we have delivered. So many countries, it is still an elusive thing to talk about public health. And of course, how many of you think that Bhor committee report was the reference point for India to look at as the first comprehensive report on public health? I was in my earlier avatar an activist, because my family had all health problems and I got into health. Later looks like I became an historian, because I ended up writing a book, Healthcare Reforms in India. I was shocked to learn we had 45 committees and commissions on health. Bhor committee was not the first for public health. It was in fact this one, the Royal Commission for Sanitary Conditions of Military in India in 1859 something. And that was because Britishers felt the soldiers were dying, they were not getting the health, so public health was a challenge. That was actually the first report, if you look at. And when I looked at it, I was shocked that before Bhor committee, way back in 1859, we had looked at the sanitary conditions in the cantonments across India. So public health, actually, if you look for students of public health, you got to look at how early we have looked at. And I think Dr. Srinath Reddy talked about this John Snow, the cholera. And as he said, vandalism, he gave you a very interesting way to look at. I mean, vandalism, yes, for sure you have to, but then we are diplomatic to use the word transformation. So you should not accept the status quo. I will talk in the subsequent slide of what public health means to all of us today. For those who come from outside, you are very lucky people. We envy you. But then we stay in Delhi. We have done some good deeds. Air, water, food, all are. There's a song in Hindi for those who understand, Jeena yahan, marna yahan, iske bina jana kahan. So we live in Delhi with that hope, and we have over time, I have not been able to convince my family to move to Delhi, because say you live in Delhi, it's your choice. Why do you want to pull us into this? So, even families get divided for public health. That's what happens. But I'm happy here, I must say. Otherwise, I won't be here in the cold winter morning here today. But history of public health is very old. So all of us stop at Bhor Committee, the Royal Commission. And this is not some what they call ideology or narrative. This is documented archaeology of Mohenjo-daro. 5,000 years old. And this is where you see a drainage system. They had public bath, they had toilets. It was a part of the civilization 5,000 years ago. I'm sure something would have gone wrong, they vanished. We all don't know the reasons. I hope it was not ignoring public health. But it has been very, very old. Only thing is that we have stopped understanding of what it meant for the people. And this you can see in the discovery. This is actually quoted from that. I have quoted this from the book. And I'm sure that you don't have to get evidence for Mohenjo-daro and Harappa. You can visit the parts of the ruins that are still a part of this country to look at what kind of importance we gave to public health systems in society at that time. Over the years, we are trying to now relook at what we are doing. Now, reimagining public health. At Health Parliament, we have the, I would say, rare fortune of having leaders like him with us. Studied the works of many people sitting here. We all keep bashing individuals. How many of you believe that individuals are responsible for their health? Can you raise hands? Good. You know how untrue it is, despite everyone agreeing that we are responsible for our health. We are not. And I'll give you the reasons why we are not. We have done studies, we have mapped the literature data. So this reimagining public health came from this data that we looked. You can download that at public health, at this Health Parliament's paper. This is there, the blog is there. So look at the numbers. Now, how am I responsible for my health? I'll give you an example. I have diabetes. Well, I didn't do anything. My parents didn't live well, but a rich man's disease. So 20% is genetics, 24% is environment. You have all come in Delhi, not able to see anything, not able to breathe anything, inhaling all the periodic table elements while you come here. No reason we should be doing that. But look at what impacts our health. 24% is environment and pollution. We actually have individuals that do not much role. That's probably the role of other things. Inheritance, food systems. Rajat Punhani will be here today to speak, the CEO of FSAI. Clinical care, 10 to 20%. As you said, clinical care is retail, and 10 to 15% is individual behavior. Why everyone says as individual you are responsible for health? I mean, my role is only 1/5 or less probably. So why? This tells us that we have to reimagine public health. We cannot be doing public health without focusing on the broader ecosystem. All of us have a role to play, but as they say, is my problem but not my fault. Public health still our problem, probably not our fault. But to shy away from our responsibility would be our fault. We have to question all the things that you are saying here. These are reports that you all know. So today, all the three things that you interface or consume every day, whether it is water, food and air, you drink it at your own risk and expense. In Delhi, people keep saying my hairs are becoming thin. We look at external things only, where there is a bigger expense. My skin is becoming this. My stomach is bad, I have a stomach bug. But the fact remains that what are we consuming? These are all red flags. Essentially, largely a public health challenge and a half-baked job that people have done in this field. So if you have to reimagine public health, and if you have to say that I am responsible, I should be getting things as they should be consumed. They are not. That's one of our big challenge. And of course, one of the things that I always get very disheartened with my very good friends in the government, we dissociate science whenever it comes to serious challenges. And we have bizarre findings that sometimes shake our belief that did we really study science? Do we really believe in that? So when we had long COVID, we said no, I think vaccination didn't do any harm. We had a good panel. I think Dr. Arora was also there in one of our panels. And professors from AIMS actually is accepted. Now we are getting more cases in cardiology, in neurology after COVID, which was never the case before. But we had studies, I don't know, that said that vaccinations of COVID have nothing to do with long COVID. We heard a very interesting finding now that pollution and bronchial problems have no relation. So that's why I said political science trumps science, sadly. And that's why I don't know why they put suffix of science to political science. Political itself would have been good. Because science gets questions when you prefix politics before that. And that has been a big challenge now. Who does research on which topics, present them in which journals, now newspapers are the new journals. You can publish and you can still authenticate, but the sad part is none of us will believe that pollution has nothing to do with asthmatic, bronchial problems, even other issues. But the papers are telling. Someday we will also say that water doesn't cause diarrhea. It was that cap that Dr. Srinath Reddy said, that we have to break that, diarrhea will go. No wonder, because they will interpret science in a very different fashion. Interpretation is more important. What are these for those into public health? What do we call these things? Social determinants of health, right? And now we added technology, and I think how many of you scroll reels? Please don't get shy. I also do that. Yes. So there are now technological determinants of health, in that we have sub domains, specifically the reel based domains, which have a vast impact on our health, even beliefs. In the last conference we have on patients, everyone accepted that they are influenced to decide on health matters after watching reels. Consuming weird things as medicines, going to weird people, believing water can cure your incurable disease. So there are determinants of health, and I think these are now commercial determinants of health. They are not social determinants of health anymore. So the more fancy things you can have, more followers you can have, you can determine people's acceptance, understanding, applications of public health, which is shocking. That is why all the more reason that when these kind of things come in, the so-called journals and genuine publications and leaders like Reddy and those who are sitting here would matter more, so that we don't get carried away with the 90-second reels. We actually believe in bona fide journals. They will never go away. They will be the most relevant things to have. That what is real public health? Yes, when we were doing the summit, we planned the summit for 2 years trying to do. I'll tell you our serious challenge. We got the best leaders to be here, but we have a crisis, and this is for those who are still students of public health. We have no leaderships in the 30s, 40s, 50s, in public health that we could bring to stage to speak with authority. We have a huge crisis of the public health leadership pipeline. So it's upon you. This summit is not, we are not a conference people. We don't believe in conference summit. We believe that there is a whole lot of things that has to be shared to inspire people, to create a generation of leaders that will take care of the challenges we have created in our generation. Thankfully, unintentionally though. But this is one of the biggest challenge. The biggest challenge of public health is leadership crisis. You don't have right leadership, you have the science problem. So this we have to solve, and I think this is our big motive here. We need young public health leaders. So those of you are here, we couldn't accommodate everyone. We had a 230 seating, we went to 281 registration. We are hopeful cold will prevent some will network outside. But I hope we are also doing it live on YouTube so that people can join outside Delhi. But this is our big focus area. We don't have the leadership in public health, and we are not going to change with few people. We are trying our bit. 19th of May, I assembled global leaders in Geneva and got Dr. Tedros to address, because one of the things we do at Health Parliament is find there's a huge gap and try to solve it with addressing that heads on. it takes time for people to address, but thankfully people at the top not only understand, they support and participate. So we launched Digital Health Sans Borders and Geneva Declaration of Responsibility. The whole idea is, let's not appreciate problems, let's not just keep talking about technology on big forums, let it save lives. 10 million die with preventable illness, half of the world doesn't get health. We are very lucky to be talking about public health here. The other thing we have done is, in such meetings we ideate, and Dr. Reddy has been a strong supporter. So we created a global commission for 21st century healthcare. We were launched on 15 December on the sidelines of the World Health Assembly, UN General Assembly, and the Vices Plus 20 review in United Nations headquarters. We had this 2-hour session which is available publicly. What we are doing is, we are creating a 21st century healthcare system. We have taken a 2-year plan to create a health system, because you cannot treat 21st century people with 18th century systems. We got to redo them. Rather than tinkering some parts of it somewhere, let's redo it in entirety. So that's what we are doing through this. You can see the people who are a part of this 12-member commission from diverse field. But our goal would be that in the next 2 years, create a health system that works for all of us. Because one thing is clear, that when you keep investing in a broken health system, you build a bigger broken health system, nothing else. And that is what the world is exactly doing. So for those young leaders who have joined us today, we'll have to do one thing, is build it together. Let's do it well. Thank you so much for joining us today. Thank you.
Thank you to our speakers for a wonderful start, reminding us that revolutions in public health are rooted in ideas, courage, and evidence. May I now request our speakers to join us for a brief group photograph before we move on. Thank you, sir. Well, moving on, we are delighted to have a keynote address from a leader who is at the forefront of India's digital health transformation. It is my privilege to invite Dr. Sunil Kumar Barnwal, IAS Chief Executive Officer of the National Health Authority, Government of India, a 1997 batch IAS officer of the Jharkhand cadre. Dr. Barnwal brings over 2 decades of experience across governance, public policy, education, IT, and digital systems. He has served in several key leadership roles, including as Secretary to the Chief Minister of Jharkhand and as Additional Secretary in the Ministry of Education, Government of India. In his current role, he leads the National Health Authority, the implementing body for Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, and the Ayushman Bharat Digital Mission. Please join me in welcoming him with a big round of applause, everyone.
Good morning, everyone. Indeed, a great privilege to be here at a very important summit, Public Health Transformation Summit. And indeed, I am very grateful to the organizers to have invited me to address the gathering, which composed of all stakeholders which Indian healthcare sector requires. And in this, speaking from National Health Authority, which runs 2 biggest flagship program of Government of India, which actually is a public health transformation scheme, and therefore it's very important when we are talking of public health transformation to understand what really the Government of India Ministry of Health and Family Welfare or the National Health Authority looks at it, and we all know Indian conditions are quite different from many of the countries. We are struggling with so many challenges in public health care delivery. To start with, if we see, whenever we talk of public health, we need to always see from the lived experience of a citizen. When he thinks of a health, what comes in the mind of a citizen? Normally, anybody gets sick, he or she is always worried of two things. One, getting timely and quality health care. And second, can he afford it? Will the treatment push him back to the financial dates? So these two are the biggest concern anybody in this country, and more so from the vulnerable sections of the society. And therefore, we need to think whether our public health transformation actually addresses these two basic concerns of the citizen. I must tell you, to actually address these issues, Government of India in 2018 launched world's largest government funded public health assurance program. Many of you may be knowing Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is the world's largest government funded health assurance program, which caters to bottom 40% population of the country. Over and above this, state governments in India have added further, and probably we have reached to the level of 65% of the bottom population, bottom 65% of the Indian population, to get some kind of health coverage. PMJ schemes provides for 5 lakhs per family health coverage. Many of the states have added it further. Some states have gone far to make it even 25 lakhs rupees per family per year coverage. If we look at some of the figures, actually since 2018, government has spent 1.65 lakhs crore on the treatment of these beneficiaries. So indirectly, actually it has savings to the people to the extent of 1.65 lakhs crore, but through which almost 11 crore people have got some kind of treatment in both public as well as private hospitals. This scheme is implemented through around 32,000 hospitals, and around 50% of that are private hospitals. So for the first time, government funded programs has leveraged the strength and the capacity of the private hospital to deliver health care for the poorer sections of the society. This is the country where private healthcare providers play a very big role in the healthcare delivery, and therefore this schemes uses both public and private sector to deliver healthcare, which is a very aptly suited. In fact, many countries can vouch for only public sector like UK, Canada. Some countries like US can vouch for only private sector. Ours is the case where both public and private sectors almost equally plays the equal role, and therefore we need to leverage both the capacity. And this is where the public health transformation is happening, because we have ensured this through this program access to the poorest of the population, and this will actually build the capacity not only for the healthcare, also the productivity of the people. Going beyond, actually, as I said, the one challenge was whether the person can afford healthcare. And so that concern has been to a large extent addressed through this scheme, where the catastrophic healthcare expenditure has been reduced substantially for the vulnerable section of the society. The second important concern, as I said, any citizen has is whether he or she will be able to get timely quality health care. And that is where the bigger challenge lies, because in India, most of the healthcare provision is not just fragmented, also it creates the data in silos and mostly unstructured. And therefore, the whole integrated healthcare to the citizen is still a big challenge, and that is what we are addressing through another very important flagship program of Government of India, which is Ayushman Bharat Digital Mission. Through the Ayushman Bharat Digital Mission, actually we are creating national digital health ecosystem, which is one of the unique in the world. Actually, many of the developed countries also don't have such open interoperable platform on which every citizen, every health facilities, every healthcare professionals are onboarded. In a country like US also, this is now getting mandated because it still had a regional integration. Ours is the country, though we didn't have that kind of integration even in the regional basis, we decided to build the digital infrastructure on which every health system can ride on. And that is the beauty of this digital mission, which actually has created digital public infrastructure where every patient is uniquely identified, every health facility is identified through a verified credentials, every health professional, including doctors, nurses, paramedics, allied professionals, are all onboarded through verified credentials. This makes the life much easier when a patient travels from one health facility to another facility over a period of time. The most of the time, the point of care becomes a isolated interaction with the doctor or the hospitals, which actually doesn't build any longitudinal health record for the citizen unless he gets all the health record created across the hospitals on his own mobile or a PHR application. So this is what, through this Ayushman Bharat Digital Mission, by creating 3 registries of ABHA IDs, Health Professional Registry, Health Facility Registry, and through the gateways of National Health Information Exchange, National Health Claim Exchange, and Unified Health Interface, we are able to make a provision by which every health system, irrespective of it is private, public, a small health clinic, big corporate hospitals, all can talk to each other because they are uniquely identified. It can talk to each other keeping patient in the center, which is identified through the ABHA ID. And let me give you some of the figures that through this system, till date, we have created almost 84 crore ABHA IDs for the citizens. More than 4 lakh health facilities are registered. More than 7 lakh health professionals are registered. And when I talk of health facility, it's not just hospital. It's also the laboratories and the pharmacies. So you have end-to-end care integrated, keeping patient in the center. So this makes the patient journey actually seamless, and also empowers the patient, because over a period of time he or she gets a longitudinal health record which he can share across the facility whenever he gets the next treatment. This not only builds the huge health record of the patient which lies with the patient, and also this sharing of the records are only through the express consent. And let me tell you, this consent is managed by the system, through a express consent given by the patient through his mobile app. So this kind of arrangements have been made. Now with this, what is happening? When we talk of digital health, the biggest advantage we are going to get is the huge data we create. And the data which gets created across the hospitals. One very important thing about this system is that there is no central repository of data. So we don't get any data of any patient. The data is created at the hospital and it is linked to the Aadhaar ID of the patient. So the patient has its data on mobile app and the data is with the facility or which creates that data. So what we have, actually we have is the address of the data, some kind of impression we create. So once we don't have the central repository, the concern of privacy or the security of data is completely taken care of by the design itself. And whenever we wish to develop some kind of a solution, more so with the advent of artificial intelligence, the advantage is we can run any AI solution only with the consent of the patient or the hospital. And that can be tested across several facilities across the country. What is happening today in the digital health is we get integrated healthcare, we get intelligent healthcare, but the only challenge which we are facing is we need to develop AI solutions for predictive health, for taking decisions on disease prediction, to create heat map of disease of the country so that we deploy our resources in much more focused way. And this can happen only if we have the data on which AI solutions are tested. Today, we are getting several AI solutions developed by big companies, and we are finding many of the solutions have been designed, created, and actually tested on Western or European data. Many times those solutions are not only not good for our kind of population, also sometimes misleading. And therefore, these AI solutions need to be tested on Indian data sets, and more so varied Indian data sets which are across the country. And fortunately, with the help of Ayushman Bharat PMJ schemes, which has got 110 million treatment data of the patient through their anonymization, actually we can test data which will be much more diverse data on which the solutions can be extremely relevant for the Indian context. With these, I believe we are able to create a system from fragmented healthcare to an intelligent and integrated healthcare. And this is what we are aiming at. Through these organizations, we want to actually address that the DPI, digital public infrastructure, which has been created through ABDM, are facing the challenge of adoption, which we need to actually address. How the hospitals, health professionals will get will understand the value of it and start using it. See, most of the challenges with the technology are not of technology, it is mostly of change management. And this is what we need to address. And through these gatherings, we want to convey that all technology are useful only when it is adopted by its stakeholder and are willing to change or migrate from the legacy to the new systems. We are taking several steps to make healthcare professionals and healthcare providers to be aware of the new system, and that is how we will be able to address health problem at population scale. We have always been thinking of health as a personal or the more about the treatment. I think the time has come when we have to think health more as a public problem or the challenge which has to be solved at population scale. And in fact, for a country like India with billion plus population, we know we can actually save more if we invest more on preventive health. And that can happen only if we have right technological solutions to tell us what kind of problems in which geography exists, and also to tell the individual with their longitudinal health records that what kind of problem they are likely to get in future, so they can be better prepared, they take preventive steps, and they unnecessarily don't end up getting sick. So if we really want to build Viksit Bharat by 2047, we need to be a healthy Bharat, and the healthy Bharat will exist if we really promote integrated healthcare with many more technological solutions to better to prepare the population better for preventive and promotive healthcare. With these words, I thank once again the organizers for organizing this event on public health transformation, which is extremely useful in our context, and all the stakeholders who are present here. Is a request from my side and the National Health Authority to promote such digital public infrastructure which has got created in this country for creating a national digital health ecosystem. We have some arrangements to make people aware about how they can create Abha ID, what makes them empowered by having Abha ID and using it whenever they visit the health facilities, and better be more empowered to ask the health facilities to provide them digital records. And I think if there is a pressure from the patient side, the hospitals and the facilities will also come forward to go for more digital system than the legacy manual systems. With these words, once again, I thank you all and wish this summit a big success. Thank you.
Thank you so much, sir, for that forward-looking keynote. In recognition of your invaluable contribution and for honoring us with your presence today, may I now request Professor Srinath Reddy, Founding President PHFI, Summit Chair, to kindly come on stage and present a memento to sir. Big round of applause, everybody. Thank you, sir. Well, our next session, The State of Public Health in India, asks us to look unflinchingly at the reality of where we stand today. Evidence is mounting, from outbreaks to environmental crisis to health system stresses, that many of the challenges we are facing now are a direct fallout of how we have approached public health over the few years. Accepting the problem is the starting point for finding solutions. This session will examine the current state of public health in India. What is working, what is not working, what is missing, and what urgently needs to change. A quick reminder to engage with the live Mentimeter questions for this session. Your responses will directly inform the summit outcomes, and the consolidated poll results will be shared on Health Parliament's social media channels. I now invite our distinguished panelists to join us on the stage. For this important conversation, we have Dr. Narendra Kumar Arora, Executive Director, the Inclin Trust International, Mr. Matthew Cherian, Chairperson, Care India, Global Ambassador, HelpAge International, former CEO, HelpAge India, Dr. Harish Iyer, Director, Health R&D, Digital Innovations and AI, Gates Foundation, Dr. Girish N. Rao, Professor of Epidemiology, Center for Public Health, NIMHANS, Principal Investigator, National Mental Health Survey, Ms. Mevish P. Vaishnav, the President of Health Parliament. Ladies and gentlemen, let us all welcome them all on the stage, warmly with a round of applause. All right, everyone, to take this important conversation forward, it is my pleasure to hand the session over to Ms. Mevish P. Vaishnav, who will moderate the discussion and guide us through this session. Over to you, Mevish.
Thank you. Good morning, everyone. I'm blessed to moderate this session, The State of Public Health in India. And before we begin, I actually genuinely sympathize with people who stay in Delhi. I don't stay in Delhi, but when I landed from Bangalore to Delhi, I actually inhaled, I felt I'm inhaling the entire periodic table. The air, the water, I really sympathize with people staying in Delhi. And I don't know if food is also that good, because I can't say if paneer is safe over here. So jokes apart, public health is not about just hospitals and diseases. It is the condition in which people live. The air, water, food, mental well-being, aging, and the systems that protect us or fail to protect us. So when we designed this session, we wanted it to cover the realities that must define the next phase of reform: research and evidence, aging and geriatric care, digital systems, data and AI, mental health and well-being. I would like to move directly to our first speaker, and we are very lucky to have Dr. N.K. Arora, the Executive Director of INCLIN and one of India's most respected researcher and leaders in public health. Many of your students are here, sir, and your colleagues in this room. So we wanted to understand the state of public health in India from a research standpoint. Have we invested enough in public health research in India? Where do you see the most critical gaps in evidence generation? And what should be the key takeaways for the government and the stakeholders so that research translates into better policy and better outcomes? Over to you, sir.
Thank you very much. Good morning, and thank you, organizers, for making me part of this very illustrious group. So we heard three very distinguished individuals during last 1.5 hours about where is public health and the politics of that, and the challenges we are still facing, and some of the innovations, particularly what Sunil Barwal said from the National Health Authority. So we must realize that during last 2 to 3 decades, a lot of miles have been covered, and many of these steps have made quite transformative changes on the ground also. And people are thinking how to move forward, because we have set up ourselves a target of 2047, and also aiming to have one of the best health systems globally. What I see, if I divide the whole issue, where better evidence is required, and we need to move forward in a way which is evidence-based, and just not, and with good experience, contextual experience, but not on assumptions. One of the first thing is the issue of this whole issue of governance. I will not go over to very high level of governance, but coming to one of the important components which we have been discussing, that if public health cadre comes into our system, how good it will be. We have some examples, be it Tamil Nadu, and recently I think Odisha also has, and some of the other states. We need to have real good evidence, because getting a new cadre itself would be important, and how actually to make the best use of that. The second point, which I think is this issue of functionalizing the existing institutional frameworks. And the most important, and which was just talked about also, was health and wellness centers, or Ayushman Arogya Mandirs. We have over 186,000 Ayushman Arogya Mandirs. They are expected to provide 12 services. The question arises, recently we have done a review in 15 states. Mostly it is 3 to 4 or 5 services which are being provided. How to make them functional? Because particularly important is that these health and wellness centers are almost within the walking distance of 2.5 kilometers from every individual. So they are very strategically located. But if we make them functional, I think this will be transformative. This needs real research of various kinds. The third dimension, which is important, is we just heard the very ambitious digitalization of public health, ABDM and ABHA ID, 84 crores. The question is, just like Aadhaar has become essential, you have to carry a Aadhaar card. Are we using ABHA ID also? 84 crores is not it's almost 65% of our population, which currently people get ABHA ID, but they forget about it. So we need to do something of that. So digital health truly requires a kind of a re-engineering and relook. We have taken the first step, but I think that when a community health officer in the sub-center or AAM, Ayushman Arogya Mandir, when the person is looking at the patients, examining, data is collected, then investigation, what happens to that? It is expected to be there in some digital portal, but we know there are huge gaps. So we need to relook at this whole issue. And issues of equity will come in when we see that these become functional. And finally, I think, I'll just take another 10 seconds, that research methodology has to change. This means I have to have complexity science. Health is just not one sector. It is interacting with human beings on one side, health sector on the other side, but non-health sector on the third side. The second is that when we are talking about modeling, then agent-based modeling and newer methods have to be brought in. And finally, what we are talking about, learning health systems. That means whatever data is there, we are not talking about 84 crore data points for individual health, how we can use that. I think new methods in research are required. Thank you very much.
Thank you so much, Dr. Arora. A powerful lens on evidence, investment, and digital public health. Now, moving on, if I look at 20 years from now, I genuinely hope I survive to be sitting somewhere in this audience from where what discussion we are doing today would help me living healthy. As the next big challenge is what happens when you live longer. I now come to Mr. Matthew Cherian. Anyone who has spoken on geriatric care in India or researched seriously about this topic has relied on your work, sir. Thank you for being here. Mr. Cherian, we would like to know what is the status of geriatric care in India, and are we prepared the way we are aging as a public health reality? Given your exhaustive research, has India done enough, and what next? From a public standpoint of view, what initiatives and actions should we take across through these areas, policies, infrastructure, and capacity? Over to you, sir.
Thank you, Rajendra Gupta and Dr. Srinath Reddy for inviting me for this health parliament. To begin with, I would like to give the good news that all of us in this room will live to be 80 years because we have a longevity revolution at the edge of it. And second, the women in this room will live 4 more years because as is research, the genetic profile of women are stronger than men. Though, of course, men may not admit it, but that is what. So that is the good news. The bad news is that we are 146 million elderly, out of which 60% are below the poverty line. And because we have a pension structure which does not reach the poorest of the people in this country. That is a topic. Mr. Gupta asked me to restrict myself to healthcare. So I will outline how the healthcare has progressed in this country. In 2007, we passed a bill called the Maintenance of Parents and Children's Act, Welfare Act, which said that you will have to look after your parents in very, very simple terms. But actually, Clause 19 and Clause 20 of the maintenance bill said, Clause 19 said there should be one old age home in every district. This was the year 2007. And Clause 20 said there should be at least one geriatric health center in each of the districts, and which will have 10 beds minimum. And come 2016, there was a public interest litigation filed by Dr. Ashwini Kumar in the Supreme Court that Article 14 was being compromised, that is the right to life, for the bulk of the senior citizens in this country, which includes me as well, because I am also a senior citizen. So what happened is, the court appointed me as the amicus curiae to the court. And we tried to provide data to the court on the state of the elderly in this country. And of course, our research showed that we have 747 districts. Out of 747 districts, 301 districts only had some form of health care. Forget geriatric care, had some form of public health infrastructure which was available in those districts. And there were many districts where the National Program for Healthcare of Elderly, NPCHE, had not reached. And then coming to old age homes, it was more miserable. Only 500 districts of this country had at least one old age home. Even now, the Ministry of Social Justice and Empowerment, where I am quite involved with, has identified there are 104 districts where it exists no healthcare, no old age home. So that is the state of the nation. And so what has happened is the court said right to health for senior citizens is a right. And Madan Lokur, the justice who passed the judgment, said that the government of India should provide at least in the next few years 700 in all the 747 districts there should be one community health care system for geriatrics. And those of you who are old will realize that we run a help desk in All India Institute of Medical Sciences, where there's a National Center for Aging. And people come there, it is not just the old person coming. They are accompanied by somebody, and they are accompanied sometimes by two people. And the old people don't know in All India Institute of which doctor to meet, where to get your ABA card or your OPD card. So that is how it is when you're old. And in rural areas, of course, 2.5 kilometers to 5 kilometers is very difficult to traverse for an old person. And so that is the reality. So as HelpAge India, we ran 115 mobile medical units, which were going and treating people at the doorstep. So what is happening is, I would recommend that, of course, digital health is all fine for young people, but for old people, they forget, they won't know where their ABA ID is, they won't know where their OPD card is. Is there some way you can do it? So our system was, you reach the doorstep and treat them. So one of my first recommendations, if you want healthcare to be universal, you forget your digital health for older people. You start reaching out and meeting older people. My experience is older people, when they come to the doctor, they want touch and feel. If the doctor touches them or talks to them, they're more important for them rather than trying to give a lot of medicine, because that is what they require in old age. Because today children have migrated, children are not there. So what they require is these kind of touch and feel factors, which as HelpAge we were able to provide in a large extent, but we cannot be in all parts of the country. And 746 districts is a huge amount. So you need to provide this care, and just health and wellness center is not enough. It is okay for a public face of health, but it is not enough health care. So these are my recommendations. And the last but not least is, in Kerala, where I've been on the committee for health care, we have promoted age-friendly Kerala, which is actually the primary health center has to be age-friendly. And we want such facilities across the country, not only in Kerala, but in all states. We have to have age-friendly public health centers, which of course the WHO is also promoting, and you can read it on the website of the WHO, what are the facilities which is required for age-friendly. So this is what we need to do. And if we provide age-friendly health care, then all of us in this room can live to be 100 years, if not only 80 years. Ayushman Baba. Thank you.
Thank you so much, sir. Aging, dignity, long-term care, and yes, elderly care where socializing is very important. Maybe a child who's suffering from a mental disease or who's not able to speak that way can actually open up and interact with elderly people. So we need a center where they can interact with each other. Thank you, sir. Now, while much of what we discussed in public health is conventional, the future is being written by technology, data, and AI. India is now talking about digital public goods. The real question is, are we using them to strengthen public health delivery and surveillance? I now move to Dr. Harish Iyer, who brings a phenomenal perspective on what technology and data can do when connected to outcomes. So, sir, we would like to know, how do you see public health in India from the technology standpoint? And are we doing enough? What more we can do? How we can cover the policy gaps and the infrastructure?
Thank you so much. I'd like to first thank Professor Rajendra Pratap for inviting me to the session. And for it's actually an interesting and complex topic, as we just heard, right? Dr. Cherian talked about older people. Can older people use technology well? How do we handle the entire healthcare system? How can it be helpful to older people, young people, and of course the foundation, a little bit of the perspective we focus on neonates, infants, maternal, young mothers, and of course people with infectious disease. That's the basic area we focus on. If you look at being able to access a healthcare center, mobile health, e-Sanjeevani, for example, is one idea that the government has pushed through, which is very much around mobile and digital. And can you improve care? Can we get reasonably good care through something like an e-Sanjeevani? How would that work? Not simply a quota-based, but actually, can you deliver healthcare well, reasonably well, primary health at least, through that approach is one thought. Of course, when you talk about pregnancy and pregnant women, many of them interact with the frontline workers. Can frontline workers learn more through digital tools? And given that this is in the context of the AI summit, can they use AI to educate themselves and quickly inform themselves? Somebody comes into a clinic with pregnancy, they've got anemia, they've got maybe some sugar issues or thyroid issues. How do we refer them? Are there things we would refer them to? Are there tools that we can intelligently create which will help them rather quickly? Is that a possibility, and refer them? And in particular, in areas where maybe it is a bit farther away to access high quality healthcare. So pregnancy, education of frontline workers, perhaps some task shifting, these are all ideas that one could imagine one could do better. What about diagnostics? Are there additional signals one can get from diagnostics that can be interpreted differently by looking at AI tools, by looking at digital tools? Are there options here? We heard earlier this morning about surveillance, disease surveillance as a key problem. COVID arose partly, as an example, COVID arose partly because of transmission from animals to humans. This risk of transmissibility is a significant problem. How do you connect these different databases? How do state authorities, how do central authorities get to understand what is happening from a disease surveillance perspective is an important question as well. And again, I think the most important one, of course, in my mind is continuum of care. So you come into a facility, one day you find out that you've got anemia. You want to understand, is your anemia under control? How do we monitor how your anemia has progressed, for example, during pregnancy, but more generally? India, NCDs are going to be a big burden. How do we know that, how does the health system understand if people are more under control, sampling, large data? This is all very standard stuff. Can technology such as digital be used to do this better? I would say some of the gaps that still remain is that much of this data is not yet fully interoperable, so one doesn't get a full composite picture. I know there are challenges in making things interoperable, but certainly we heard this morning about ABDM and the desire to make things more interoperable. Can we get a more holistic picture of a citizen, health of a citizen? Is that desirable? I am arguing that it's probably desirable, so that people can be given what they need more appropriately and not wrongly medicated. I think planning for the health system to plan, could tools such as AI be used to plan better? Where should we assign resources? This is a classic question of how can we use technology to help manage things better. Dashboards. And we all use this technology on an everyday basis, right? If you want to travel from one place to another, now we suddenly look at Google Maps. It's not like you absolutely need Google Maps, but suddenly it's a significantly important and useful way to figure out how to navigate. No, not everybody needs UPI, but UPI has suddenly made it so much simpler for all of us in this room, I'm guessing, to pay somebody, including whether it's a chaiwala or something in a hotel when you go for a lunch or dinner. So technology can be deeply enabling. How do you make this enabling in the public health system is the challenge, and figuring out how to make it interoperable, how to use AI in the context of the AI summit. And I think there are many examples, and I'll stop here because I think my time's up. But thank you very much.
Thank you so much, Dr. Harish. Yes, we use technology to manage how dashboards can be used in hospitals, and we should see how we can manage our health as well through using technology. Now, moving on with the pressure, well-being is one thing and mental well-being is another. And after COVID, we realized how deep this is getting into. During COVID in 2020, Health Parliament conducted a survey on mental well-being, and 99% of students found some or the other mental issues. I hope, as our next speaker, Dr. Girish Rao, who is one of India's leading authorities and among the key researchers leading National Mental Health Survey, and like me, sir, you also come from Bangalore, and I too empathize with you, but I see you're smiling more than me, so I hope you're doing good. My question to you, sir, is how do you see mental health as a public health challenge in India? And what we can do practically across the same areas, policy, how we can see it into infrastructure and capacity. Over to you, sir.
Okay. Thank you, Mavish. I think we share all the trials and tribulations for living in Bangalore and traveling around. A very good morning to all of you, and I think we can still wish all of you a very happy new year. I am expected to talk about the National Mental Health Survey. National Mental Health Survey 2015-16 was the second largest survey done. It overcame the limitations of all the earlier studies which had got small sample sizes, selective areas of work. The burden was about 10.6% current prevalence, 13.7% lifetime prevalence. But more importantly, the two things which stood out was the huge treatment gap which varied between 70 to 94% across different disorders. Second, among those who reported disorders, nearly 75%, roughly about 2/3 to 3/4, had one or more disability in the area of personal life, social, or work-related. Now, that's alarming. Now we are in the process of doing the second National Mental Health Survey. Quite happy to share that we are doing this across all 36 states and union territories. As of yesterday, I think nearly 15 states have already completed the survey. It set a global record of, we have almost completed 2,12,000 interviews approximately. First time globally, we are using the WHO instrument called as FLY, Flexible Interview for ICD-11. And first time globally, India is doing in ICD-11. That's the latest one. So in that sense, a history of sorts is being set. We hope to release the report on 10th October 2026 as part of the World Mental Health Day. To answer Mavish's question, I thought I should write it down lest I make some blunders when I'm talking. So I just quickly read it out. I thought my thoughts were the parable of public health, the neglected child, and the public mental health, the forgotten child. Encompassing health issues and beyond medical practice in a facility, public health is universal care. Interventions are inclusive and area-wide. The strategy is convergence of healthcare and services with a goal of equity. Being systems-driven, it is thus no wonder that public health practice is both an art and science. Amidst the overwhelming aura of clinical medicine, public health makes itself heard even in the incessant chatter, albeit in fits and starts. It must be recognized that public health is action, and also acknowledge that much of the action is in the non-medical and health-related spheres. The categorization of interventions into water-based, waterborne, water-related, water-washed for mitigating diarrheal disorders are practical, pragmatic, and in sync with ground reality. As we witness today, classifying air pollution as indoor and outdoor was arbitrary and at best convenient. Ironically, it is said that the air purifier sales is approximately rupees 2,000 crore per year. This is roughly 2024 data as on X, which I could find out yesterday, and is expected to grow at the rate of 18% year on year. This arbitrariness pertaining to decision making in public health arena is once again reflected in the recognition that mental health is distinct from physical health. We albeit conveniently forget that there is no health without mental health. Yes, there is no health without mental health, and this is not just an adage or a mere slogan. Mental health is everybody's business. The stress and the distress in the different disorders are now more evident than ever. The labels of chronic diseases, lifestyle-related ill health, and communicative disorders feebly inform action. Chronic stress indicates the challenges out there to address the cry for help. I think yesterday the Supreme Court has given okay to the National Task Force on Suicide Prevention in higher educational institutions. I think the report is available. Quite an interesting read in terms of what campuses should do to look at preventing suicide. I've deliberately avoided using the word suicide because even in the Mental Health Care Act, we talk about chronic stress and not refer just to the end point of what is referred to as suicide. That's the cry for help. Yet another pill for the new ill, as a structured response is bound to give the same results and cannot be declared as miraculous. We tend to go for trying to find a pill for depression, a pill for anxiety, and something more. I'm not putting it down, but again, let's understand the larger context in which it is there. The determinant for neglect of public health and the paradigms which exclude public mental health can at best be ignorance. Lest it be forgotten, leadership matters. It is not surprising that the practitioner of public health in the Indian context is a witness to the mortifying disappointments and, of course, the fatiguing delays of the system. The health parliament's attempt to foster a dialogue can be the hope of winds for change. I'm reminded of the INS Kaundinya, which docked, I think, last week in Oman. Reconfiguring a catch-up growth for public mental health concerns is the right agenda for the day and definitely the harbinger of truth for societal well-being. The quest should be to map the spots, to count the vitals, and critically identify the handle of the pump. Srinath Reddy sir, just a small correction to the John Snow anecdote which you said. Sir John Snow did his research in 1820s and 30s, but the pump of the handle was removed only in the 1840s and 50s. It took almost a decade for them to remove the handle of that pump. So, the fatiguing delays and the mortifying disappointments continue to pervade us. The interventions need to be epidemiological, designed not as a cascading waterfall, but more of a spiral of improvement, leveraging the tenet of public health, that is, organizing community efforts. People need to recognize that it is their felt need. The Charter for Public Mental Health should recognize that stress is necessary, but distress is avoidable and importantly preventable. We tend to use this word stress very callously. Stress is needed, otherwise I won't be sitting here to do this talk. What is not needed is distress. I need to know how to handle my stress. Stress cannot be conflated with mental illness. Counseling is therapeutic and needs to be a way of life. It is both dharmic and also karmic. Fostering public health, or for that matter, public mental health, is definitely resource intensive. We can't afford to say that just let's put some money. The overall mental health budget across the countries is less than 0.1%. This is the 2019-2020 World Health Report. It's not enabling. Ennobling perspective plans are urgently needed. We tend to neglect. Sir was talking about the CHOs. How many of us are able to support them when there is an issue? Giving them that position in the society is equally important rather than give lip service to saying primary health care is important. Systems improve over time. Public mental health schemes need to be nurtured. That's the critical thing. The specialist of the day is the generalist. A very good morning, sir. The specialist of the day is the generalist who has a bird's eye view, or what is referred to as the balloonist view. A systems approach is the wholesome strategy. For this August audience, I propose a 2x3 move-on plan, not an action plan. 2 for public health and 3 for public mental health. Strengthening district level capabilities for public health, both trained and qualified personnel. I think earlier effort was made to look at a public health cadre. That's the second point. Reinvigorate the public health cadre and energize. I'm sure all of us who are public health students have heard about this reorientation of medical education program sometime during 1975s. But now that became ROAM, R-O-A-M instead of R-O-M-E. Now we need to look at re-strategizing these medical education so that this generalist cadre or family medicine or community physician concept gets included. Monitor inclusion and integration of mental health packages into ARM. I think sir was mentioning about only 5 services which are being given. I think the second set of services, which is mental health, needs to be urgently integrated and functionalized. We have a recent paper, Screening for Depressive Disorders and Harmful Alcohol Use is Cost Effective, again done at arm level. Leverage digital mental health care and supportive services. Sir is here, Telemanas was inaugurated. Telemanas, the digital arm of district mental health program, has revolutionized accessibility to community mental health. Let us strategize AI, not just artificial intelligence applications, but also applications acquiring intelligence. What is the indicator for mental health? What are the indicators whether the program is functioning or not? What is that which we are collecting as data so that that could be made meaningful? I think there is a plenty of shortfall or gap in that. The last point, situate a public mental health commission. I think these were the few things. Last word, I would request all of you to repeat with me. Please repeat this number 14416. 14416. 14416. This is the universal number across the country. 53 Telemanas centers are operational, working 24/7. By just a phone call, people will be able to access mental health care any part of the country in the language of their choice. I think that's the revolution which we are working on. Let's build on that. Thank you very much.
Thank you, sir. I would like to also let you know the Telemanas was our recommendation from the study that we had done through Health Parliament. So if we connect the dots, research tells what works, aging tells us the care systems, digital tools can multiply impact, and mental well-being defines resilience. But across all this, one factor that describes success or failure is the leadership and capacity building. And from the Academy of Digital Health Sciences perspective, the biggest accelerator is still people. We have been contributing through path-breaking learning pathways that strengthen digital health, data, and leadership skills, because policy strengthens and becomes impacted only when the workforce has the capacity to deliver. We are running short of time, so we would not be able to take any questions this time. You can interact with the speakers at the breaks, and looking forward to interacting with you all. Thank you so much.
Thank you so much to our esteemed panelists. I request you all to come forward for the group photo. And to all the ones who wanted to engage in the Q&A, there's an open mic session at the end of the sessions. So please stay here and engage with the speakers that time as well. Well, before we have our special keynote address, we are going to first have our session on the building a public health monitor for India. So, having discussed the evolution of public health and the current state in India, the natural next question is what's next? So, our third session, Building a Public Health Monitor for India, explores a powerful idea that if public health has such a large impact on overall health outcomes, why are we not measuring it systematically? Today, there is no comprehensive index or monitor that tells us which states or which systems are doing well, where the best practices are, and how can we foster healthy competition and collaboration in public health. We know from past experience that this is all possible. So this session asks, is it time to build a public health monitor for India? If so, what would it take and who must be involved? So for this discussion, we are joined by our chair, Professor K. Srinath Reddy, and co-chair, Dr. Rajendra Pratap Gupta, along with Dr. K. Madan Gopal, advisor and head Public Health Administration, National Health Systems Resource Center. Please give them a big round of applause, everyone. So, to take this session forward, it is my pleasure to hand the session over formally to Dr. Rajendra Pratap Gupta, who will moderate the conversation. Over to you, sir.
Thank you and good morning, and I would give you a context of why we flipped the two sessions. You know, this government has got some real legends, and the key one is Dr. Vinod Paul. And what I tell you, for those who are still studying or students of public health who wish to be from the room to the stage one day, this is one quality I would say that Dr. Paul has that all of us should learn. Last year when we were hosting a patient summit, said, Rajanji, can I come early? I want to listen. This is a quality that makes you a leader. If you're going to be contributing to policies and programs, listen, absorb, and then react. We have very less, I think, bandwidth now left within the age of 140 characters, 240 characters, and 90-second reels to listen and absorb. That's one of the biggest challenge and the crisis that we have in public health. Today also when he came, he said, can you flip the session? I want to hear this. And this is one quality that I wish we take away from this great leadership. And we know under his leadership what India has achieved, which is phenomenal. I think we need a round of applause for him. But when we get to this public health monitor, you know, this is something that came from my work from 2016 to 19 when I developed the digital health, global digital health index. So 12 of us from across the world got together. In 3 years, we built the global digital health index. In 2020, we put it to World Health Organization, and this has now become the global digital health monitor. So it ranks the entire world on where the digital health maturity is. You can look up, when you search the Global Digital Health Monitor, you will find the report of 2019 we delivered, then 2021 and so on. So there was one thought, you know, the complexities of public health as a domain where it is, we should create a public health monitor. The reason is that once you create that monitor, as you know, this is old saying that what you measure is what you manage. And we should start looking at, and I'm a very big fan of dashboards. So one of the things that we have looked at to do is to monitor and improve public health, and that's one of our objective. Track progress towards comprehensive and integrated public health system. That's another challenge that we have to. As I told you in the morning, that first time, I mean, in the manifesto, Swachh Bharat was under health, not under water resources department. All the things that you look on page 24, 25 were put under health, and no wonder we are seeing what step in the direction. And also that we are not talking of DPIs and DPGs, and a monitor would be very important to rank. I mean, the vision is, I've been talking to a few state governments, that we could start with the state, drill it down to districts. At the end of the day, it is the districts that are the implementers of the program. So with this, I would want to put it to two leaders who are with me, and Dr. Reddy, who's made a major contribution to policies and public health, universal health coverage, and Dr. Madan Gopal, if you know Asha workers program, Metanin program that he was a part of in Chhattisgarh was the precursor to what we did at Asha. So one on the ground level, on the policy and a practitioner level. So I'll come to Dr. Reddy first. Dr. Reddy, what are your views? Sorry. Okay. So Dr. Madan Gopal, what are your views on this program of setting up a public health monitor? And what are the things that we should be keeping in mind from the ground realities, because we have to still get back data from them. There can be no monitor without data coming from the field level. So what are the views on the monitor, and what do you think we should be taking care of as ground realities?
One of the important things, Rajanji, is data. Because we have all been talking, nowadays the discourse is around data-driven governance. But the governance element is more or less missing. We are only collecting data. Name a program, you are having a portal for that program, and you collect the data. But data, if you are collecting and if it's not translating into any improvement in the performance, it's just a decoration purpose. That means so many dashboards are there, and you have the dashboard, and it's for a decoration purpose. It's not that some improvement or some action is happening. That's one thing. Second thing, we are collecting data and we are drawing inferences from the data which is coming from the field. One of the important challenges, which, because as you have mentioned about the indexes, when I was working with my previous assignment with Niti Aayog, to instill a sense of competition among the states as a part of cooperative federalism, so 5 state health indexes were designed and they were rolled out. We had 5 rounds of this, and it started having a discourse and dialogue with the states and other people. But as we were discussing offline, that means the data, it's very difficult to digest the data if we are able to show that you are not doing good. The data is not for inspection purpose. It is for bringing in some accountability, transparency, so that we can work towards improvement. Having said this, I will come back to the ground level thing from where the data is being originated. Then why the importance of monitors lies. The data is originating from the ground level. That means if you talk about the system in the country, we do have a million of health ASHA workers. Then we are having around 40,000 A&M workers, and then you are having a plethora of around 210,000 health institutions. That number is there. The information is coming, but one of the important challenges, understanding the data, what to collect, what is the importance of the data, that sort of capacities are missing currently now. That means we have to see that if we want to have a data-driven governance, we have to build capacities for bringing out good quality data to us into the system. Whatever dashboards which we are having, that is based on the data which is collected from the ground, and we all know that what is the capacity of the people at the ground level, and that's an area. But nevertheless, we do require monitors, because when the Mitanin program started, it started as a public health movement. That means the induction of the health worker, it usually took 6 months for us to at least mobilize the community, say that what is the importance of having a worker who would be helping hands of the community. The monitors are the helping hands, and to begin with, that was the thing which was created, and as a result, it's become a movement. As the Professor Reddy has mentioned, that it has to become a Jan Andolan during that time. But it has become a movement. We started with 16 blocks, then it was upscaled to around 80 blocks in Chhattisgarh. Then whole of the state, looking at the value it is adding, whole of the state was rolled out, and subsequently the model was also studied, and it was rolled out as a ASHA program at the national level. That's another thing. But one of the important challenges is having people who can do a monitoring work for us. Okay, what is working, what is not working. We are collecting data, the worker is working at the field level, doing rounds. Previously, we used to have a mechanism of having a support supervision in the form of the sector level meeting. If you talk about the structure which is there in the country, that means you are having sections. The section headquarters is your arm center or your sub center, and the sector is a PSC, that the headquarters is there. Every week they used to look at this, and that monitoring process was there. But if you talk about monitoring and the monitors at that level, so that it can result in improvement as well as bring in some accountability, you have to see that how a institutional level monitoring mechanism is there to begin with, the facility level monitoring. After the facility level monitoring, we should see that how a district leadership sees that monitoring and takes clue from that monitoring and bring in accountability, and so that work can happen towards improvement of that activities. The third is the community level monitoring, because we have tried to communitize, because NRHM has resulted in communitization of the health services. Before NRHM, that is 2005, we all used to talk about community participation, community engagement after the Alma-Ata declaration, but the serious efforts were made in when the NRHM was launched, when communitization of health services happened, the participation of the communities started happening in the form of village health and sanitation committees, the Rogi Kalyan Samitis, and the other samitis which are there. So they also started acting as monitors. So that, but the status, how they are doing, the other thing, that's another thing, other discussion point. But these monitoring mechanisms were established during that time. The other form of monitoring, which was also built in when this flagship program was launched, was the third-party monitoring. So we have found ways of just skipping that third-party monitoring. Instead of having a third-party monitoring, we have an internal monitoring mechanism. We call it as a third-party monitoring. Niti Aayog usually does that third-party monitoring in the form when the finance cycle usually changes. Importance is that we should be having mechanisms, the monitors which are there. When the state health index was rolled out, when we were rolling out from Niti Aayog, at that time it resulted in a lot of discussion among all the states. It was covered widely by the media. They used to talk, the states used to talk that we are also spending the same money as other states which are doing good, and we are not doing good. A discussion usually centered around this, what are the things which needs to be done for improvement of the health indicators, and that kind of discussion has started. This has resulted in many of the states having their own indicators now. Some of them, but in some form they have started this, but it's all internal. We require more district level leaders who can be acting as health monitors. We require more community level leaders who can be monitoring. If you look at the examples from the Latin American countries, where the communities, they are the monitors for the institution which is serving that population. That kind of monitoring mechanism we have envisaged, but we need to work towards strengthening that monitoring mechanism which already exists in the system. So that we can say work is in progress. But apart from building the institutional level monitoring mechanism, we have to focus on building the support supervision mechanism for our frontline workers who are at the cutting edge of the system. As been mentioned by the previous speaker, saying that the Ayushman Arogya Mandir may not be able to serve the purpose. We can have to go beyond that and see that how the workers who are the cutting edge providing services, they all be properly supervised. A monitoring mechanism should be there, a monitor should be there. Essentially, so that the improvement can happen. And apart from that, one more important thing, if you look at the data which we have compiled and collected, we have to generate a thought process saying that somebody should be able to look at the data very closely and see that if the gaps are there, they should be ready to accept the gaps. And then after seeing that the gaps are there, then they are ready to take the actions on that. So these are a few of my thoughts. I think there are many other areas. Recently, I was involved in the Indian Public Health Standards evaluation and other things where we could able to assess around 210,000 facilities. But if a gap is coming from any of the things, we have to at least see that sit together, see that what can be done to improve the things. Otherwise, it would just become an ornament for decoration, as we are seeing. I stop here. Thank you.
Thank you so much, Dr. Madhumar, bringing the ground realities. And turning to you, Dr. Reddy, you have been an institution builder. When you saw there was a gap, you created Public Health Foundation of India. You institutionalized the process of creating leadership. And now we are in the age of digital public infrastructure and digital public goods. That requires the digital infrastructure of today. Do you think that the digital public health monitor will be able to, like, public health monitor will be able to tell the states, the leadership, where are the gaps, how to act on it, what kind of role it could play, what we could measure, to bring the change and focus on public health?
Well, as far as having a digital public health monitor is concerned, its use is very obvious. The fact that you can collect data in a timely, representative, and fairly accurate manner across a wide range of Indian states and districts is a very important element, because previously data collection used to take a long time. That's why we had our surveys dispersed over years, whereas now we can do it much more accurately and extensively in a relatively short time frame. Data integration becomes very easy also with this. But even more important, the range of data points that we can gather are also much larger, because we can now bring in the very many social and environmental determinants of health, the data points linked with that, also into the measurement and analysis of health indicators, and try and identify where the response lies. There are other areas that we ought to be looking at in terms of how the data can be extended beyond what is conventionally now measured. In many of the cases, we are measuring only mortality rates. We are not measuring non-fatal outcomes, important as they are. They contribute a lot to disability, they contribute a lot to healthcare costs, and they have economic consequences for the families and the country. The reason why we are not measuring non-fatal outcomes, including mental health issues, is in an accurate manner in terms of the disabilities caused and the economic effects thereof, is because they're not always easy to measure and we have not framed the right questions. And you have started by saying that what gets measured gets done, but what is easy to measure is what gets measured. What is not easy to measure doesn't get measured, even if it's important. And therefore, what gets measured gets repetitively incorporated. That gets into policies, that gets into programs, but what is important to measure but could not easily be measured gets omitted from the policies and programs. So I think it's important for us to start measuring even the non-fatal outcomes in very many conditions, especially in chronic diseases, which are going to be going over a much longer period of time of a person's life course. The second element is, are some of the measurement instruments that have been developed elsewhere relevant to us, applicable to us? In universal health coverage, for example, the two key measures that have been advocated by the WHO and the World Bank and the United Nations, and which we are asked now to adopt internationally, are the financial coverage index, and second is the service coverage index. The financial coverage index, of course, is fairly clear that you are talking about out-of-pocket expenditure, catastrophic health expenditure, and healthcare-related impoverishment. In terms of the service coverage index, 4 major domains have been identified, out of which several indicators have been selected, and a service coverage index has been constructed. But my own colleagues sitting here from the Indian School of Public Policy, from the Center for Universal Health Assurance, have actually analyzed this service coverage index and found there are several elements which are not relevant to the Indian health system. And therefore, we need a revision of that service coverage index to make it much more relevant to the Indian health system. And that index has been developed now. It will be submitted for peer review and discussion in a consultation soon to be convened by the Indian School of Public Policy, in which we hope many of the experts here will participate. But the idea of trying to develop some of the international indices to become much more relevant to the Indian context is going to be an important element that we ought to be looking at. But our next question is, what happens to the data from the monitor when it's actually generated and widely disseminated? How actionable is it going to be, and will it elicit action? There's been some concern expressed by Dr. Madan Gopal that the monitor may be perfectly constructed and widely utilized in order to gather the data, but then what happens after that if there is lack of response from the agencies that ought to be taking action on that basis? I think there it's very important for us, A, to keep engaging people from the agencies and the departments right from the very inception of planning the data gathering and to the various times in which the data are being analyzed even in the interim, so that they feel engaged in the process and ready to receive. There, even while planning what kind of data are going to be gathered, it is best to involve the stakeholders from the implementing agencies at the district level, at the state level, and of course at the central level, wherever possible, in order to see how relevant and actionable the data are going to be, so that ultimately they are going to be the recipients of the data. At the same time, it's important to engage the citizenry and the community-based organizations, because they are aware of the ground level realities, both in terms of what data are relevant and how the data can be gathered efficiently and comprehensively. And unless those stakeholders come into the process, they are divorced from the data gathering systems. Now that the 15th Finance Commission has ordained that the local bodies, the urban local bodies and the panchayats are responsible for primary care, a lot of resources will be directed at them. The question is, unless we engage those agencies as well very effectively at the various steps of planning, how the public health monitor is going to be developed in a digital fashion, we'll not know, A, what their perceptions of relevance are and what their potential utilization of those results are going to be. Even if they are not fully familiar with the technical aspects of it, this gives an opportunity for engaging them in the conversation and sensitizing them there. Therefore, it's absolutely important that we do that. Then, of course, what Dr. Madan Gopal referred to as the Latin American experience of having municipal councils in Brazil or elsewhere doing a monthly review of what's going on and then finding out where the fault lines are, the lack of performance is, or the lack of implementation is, and then taking corrective measures. I think if we can actually engage our own local bodies and panchayats in a much more effective manner, and then get the citizenry also to have the data available, that will be excellent, so that they can put pressure. Response comes both from top down and from bottom up. Top down, the Niti Aayog, the Prime Minister's office, if they become sensitized to the data and what actions are required, fine. But the demand for action, the monitoring of whether actions are being done well or not, has to come from the citizenry. And therefore, it has to be both a bottom-up and a top-down, a fusion of the process. And I think that's where I think we'll find not only instruments can be created, but they can enable people to work much better. Then, of course, the very important element is to ensure that the people in the health system themselves become adept at utilizing this data as it's being generated for online evaluation. quite often programs are evaluated at the end of the program, and usually by academics and consultants hired by whoever is the donor partner. And there, the governments, I can fully sympathize with them. The bureaucrats and the technocrats in the government say, what's the point of coming and telling us at the end of the program what went wrong with the program? We should have been told somewhere along the line of the program so that we could have taken corrective measures. So, embedded evaluation during the course of any program implementation so that you can spot where the fault lines are and correct them is important. And that need not be only an external evaluation agency. That capacity for embedded evaluation continually through the process has to be developed within the health system itself so that they take ownership. They're not going to be finger pointed by somebody else and tell this is wrong, this is right, but they have to develop the capacity for the monitoring and correction, and a digital public health monitor which gives them timely data on a regular basis and tells them what the results of the correction are is going to be a great boon rather than the kind of evaluation processes that we periodically, sporadically carry out now. I think therefore, both in terms of refining the content and quality of data, making the database much more extensive to cover the social and environmental determinants of health apart from the health indicators themselves, as well as ensuring that the data are program and policy relevant, and not only at the inception and the end of the program, but throughout the program. These are areas where the digital health monitor can actually come in a very impactful fashion.
Thank you, Dr. Reddy. And I think very pointed that integration is important, and also community-based monitoring, which I think is part of the national health policy that lays down these fundamentals there. But I think our Prime Minister gave a very good word, Jan Bhagidari, that people's participation is important. So we should take at least 3 views from you. I mean, in the interest of time, I'll not be able to take more, but certainly, yes. Just be brief and succinct to relevance of this topic. Yeah. Can someone pass in the? Yeah.
I'm a rehabilitation medicine specialist, Dr. Ganesh Joshi from Arogya Bharati. So you said that we talk of morbidity, we talk of mortality indicators only. Morbidity was not there, and that was so because rehab medicine was not there in MBBS. Now since 21, it is there. So we hope that morbidity indicators also will be known to the medical staff. That was my suggestions.
Thank you. Dr. Narendra.
I thought I'll just remind Narendra.
Yeah. Give that to Rajiv.
I'm Narendra Arora from England. I thought I'll just remind about this monitoring system which already exists and which has transformed the national immunization program. Concurrent monitoring of immunization takes place, and there is an externality on that. UNICEF, WHO plus local people are involved, community is also involved, and today in 2014 our immunization coverage was 63, and today it is 93-94%. So I think it will be very good, and I think a lot of lessons can come up from immunization program.
Thank you, sir. Rajiv.
Thank you, Rajiv Tandon. Great inputs, Dr. Srinath Reddy and Madan Gopal. The census is right around the corner. It may be really worthwhile to categorically send a recommendation through the Health Parliament for inclusion within the census questionnaire. And otherwise, we'll miss the boat again. We can keep talking about all that we've been talking of. Nothing will eventually get and hit the ground. That's the recommendation.
Just be brief, yeah. Last.
Dr. Kansapara, thank you, both of you. Madan Lalji, I like what you said. My humble request is to implement and try to gather data with Asawadi worker for mental health, which start by age 14. And we are not paying attention, there's no awareness. And now, as everybody said, mental health is precursor for all NCDs. So if you want to decrease the cost, awareness is important. Whatever indexes, Rajendra, you can develop, it will be great service, not only for India, for entire world. Thank you.
Girish and then Dr. D will end. Yeah, Girish.
I'd like to thank, I'm Dr. Girish from Nimhans, Bangalore. Thank Professor Srinath Reddy and Madan Gopal sir for bringing out the need for simplification. Just wanted to say, one of my MPH students is currently looking at the health management system at a district level. Filling up 16 to 24 portals data is complex, and then technology needs to come in. There is a requirement for simplification so that analysis also happens in a much more systematic manner.
Well, one of the challenges that we've always had is to get multi-sectoral coordination. Everybody talks about it, but it seldom happens really operationally. But to build it into the program, you need data to be generated simultaneously and people to actually sit and discuss the data and see how the different sectors actually can contribute to the solutions. And here, by getting a good digital public health monitor, you can really get the data real time and get that discussion going on. And I must congratulate the Niti Aayog for getting portion 2, actually to get that kind of a system in place where they do have a very good software, common application software, which they can actually, all the sectors involved can utilize it and all the departments can utilize it, and then that enables much better coordination and reporting back from the block to the district and central level. So I think getting that kind of a digital monitor is going to be one of the solutions for the lack of multi-sectoral coordination, both at the ground level and at the policy level.
Thank you so much to our esteemed panelists. Now I request you all to please come forward for a group photograph before we move to the special keynote address. We can give them all a big round of applause. Thank you, sir. Now it's time to have a special keynote address by Dr. Vinod Paul, Member Health Niti Aayog. Dr. Paul is a leading public health expert and policymaker, former head of pediatrics at AIIMS, New Delhi. He has been instrumental in shaping India's health policies, including Ayushman Bharat and Poshan Abhiyan. At Niti Aayog, he drives key health, nutrition, and education reforms. He also led India's COVID-19 response and played a crucial role in medical education reforms. With over 400 scientific publications and global recognition, Dr. Paul's contributions to healthcare are unparalleled. Let's all welcome him.
Thank you very much. Good morning. Respected Professor Srinath Reddy ji, Rajendra ji, my very distinguished colleagues, friends, leaders in public health, delegates. I'm truly honored to be here. And the last session, I'm very happy that I could make it to the last section and learn new ideas to, in my own humble way, take them forward. 15 minutes is a very valuable time. I'll try to cover a few points, but let the first statement that was made by Rajendra ji, that we have seen strengthening and transformation of public health system in a very big way in the last 10, 11 years in particular, building on what was done over the last, the long period of time since our independence, and also particularly acceleration after the National Health Mission came up in the country. I like to, in the immediate context, I like to highlight two strands which are also on your agenda, which must be recognized as very extremely transformative. These must have been stated in the morning. The first one is where we need support is the comprehensive primary health care through Ayushman Arogya Mandirs, the erstwhile health and wellness centers. I think if our nation is doing the most important thing in the health system and health sector that India is doing currently is strengthening, transforming primary healthcare system of India. This has been the wish of so many of us. The leaders are here who crafted this vision. It got embraced into the National Health Policy 2017, and then very able people developed a task force of very able people, created the vision and action plan, and we in our own humble way are taking it forward. However, we are still in the process of achieving what we have committed. The mission was announced in 2018, and the last 5-6 years in particular were devoted to creating the additional infrastructure and the additional manpower in the form of a mid-level provider, the community health officer, of which today 130,000 are in place approximately. We have taken the erstwhile sub-centers and primary health centers to the early compliance level of health and wellness centers, Ayushman Arogya Mandirs, to the extent of 177,000 units. Now, this has been done. What still needs to be done is optimum operationalization. All the 12 packages that comprise comprehensive primary healthcare is work in progress. Later, isko baad mein work in progress, quality, and population coverage, population level coverage of the services, and confidence of the people, utilization of these services. And the research community should demonstrate how we can create pathways to make all that happen. Please, I urge you that please make the best of this opportunity. Because having done the early progress, glass half full stage, there is a sense of complacence कि हो गया, लेकिन बहुत कुछ मेंटल हेल्थ की अभी बात हुई है, बहुत कुछ होना. हमने एनसीडी की स्क्रीनिंग करते हैं, उसका फुल पाथवे अभी नहीं बना. किसने करके दिखाना, सिखाना किसने? I urge that our academic, research, public health community please join hands at the state level, center, district to make this primary health care mission a success. Tell us how it is to be done. This is the single most important thing that in the specific health sector the nation is doing. This is the biggest effort on this planet ever in strengthening primary healthcare services. If we don't do a good job, at the least it will be a delay, but at the worst we may have to face serious consequences, because non-communicable disease, which is an elderly care and the mental care, where do you enter? Through the primary health care. I just set my case here, and I do not see enough discourse, humbly speaking, on the new ideas, on learning from what we are doing, new models of delivery, implementation research, people joining hands with the district administrations to make it happen in different states. That effort must be mounted, and this community, please, that message I'd like you to share. Second, very briefly, you're going to have a discussion on One Health mission, another dimension of public health, particularly in the wake of possibilities of outbreaks and the recent pandemic and future pandemic preparedness and biosecurity and so on, and the rogue elements, climate change, changing ecology and affecting and bringing in very difficult to manage outbreaks and viruses and so on, antimicrobial resistance. For this, as you would be told, One Health mission, which brings together 14 ministries and state governments and the entire system beyond that, is a very salutary, unusual mission. And that I would urge is a very stellar achievement of the system today. But going forward, again, we need that kind of a support from us. The elements of the One Health mission, as you'll be told, is surveillance, digital surveillance, joint outbreak investigation, breaking silos, making sure that the response happens in time, containments happen in time, and so on and so forth. You'll be hearing more about it, but I like to highlight 2 points. There are other aspects to what is being done in the public health space, and let's also not forget what we have achieved in Swachh Bharat and through the Har Ghar Nal Jal the Jal Jeevan mission, where all the rural households will have potable water maybe in the next 2-3 years, moving from 17% coverage to 100% coverage in rural households. And when we would have done this mission, we would have given over, let's say, 7-8 years, potable water supply to the 2 individuals numbering equal to the population of US, UK, and Brazil in 7-8 years. So just that part. I want to be specific on 2 or 3 areas. One, on the data, taking Q, and I think it's a very important part, and also because AI is looming large, invisible elephant here in the room. Let me state the following. The point was made that we collect a lot of data. It is true that we collect a lot of data. Do we need more data? Indeed, in some areas, Dr. Srinath Reddy highlighted, we need more information, more accurate information, more information that can be acted upon. But today, one of the major problems is too many portals. Duplication. Same individual is visible in multiple portals. They don't talk to each other. One principal secretary of a particular state, I asked him to count how many such portals you have. 51. And 30 I can count myself, 30 in the primary care space. In the national program space itself, there are 30 plus portals. The Honorable Prime Minister in the Chief Secretary's Conference, 5th Chief Secretary's Conference just a month ago, also brought this to the attention of the larger fraternity of the government, that we are creating these portals and we come up with a new portal all the time, but we must be rational in this approach. उन्होंने कुछ कहा कि इसको सोचना चाहिए कि कोई कानूनी होना चाहिए, कि हंस के कह रहे थे. लेकिन more important point that he made was that data lying out there not being used is a serious matter. One of my colleagues in the Niti Aayog says that we often hear the data is oil, but then she says no, there's a difference. Oil is useful when you store it. Data is only useful when you use it. When you store, it has no value. And the Prime Minister said, if you keep all the data shelf पे रखा है, उसको साफ करे जा रहे, उसका कोई इस्तेमाल नहीं हो रहा, तो मैसेज हम सब के लिए अब ये है कि नया डेटा भी कलेक्ट करो, कंकरेंट भी करो, जो फालतू है उसको मत करो, लेकिन जो है उसको इस्तेमाल करो. प्रोग्राम है उस टाइम पे, प्रोग्राम की फ्यूचर प्लानिंग के लिए, एंड देन ऑफ कोर्स टू क्रिएट AI solutions. So this is my submission with regard to the way forward, and we should take concerted effort in that regard. That takes me to the theme, the sub-theme of related to the data and AI in health. Here, a brief submission. NITI has a frontier technology hub for about a year and a half, and we have been debating as to where NITI's role as a think tank should be, could be, and you may be hearing a few reports that we are coming up. One of the estimates is that by 2035, if we do a good job, AI-related economic activity would lead to additional $1.4 trillion for India, if we get it right in all the sectors. The sectors on which NITI is focusing, or let's say government in particular is focusing through the AI missions and all, AI for health comes up on top, agriculture, education, and for NITI it is also security and space, etc. So AI for health comes up as a very, very important sector and very important potential in our endeavor for AI. Our Viksit Bharat journey would become difficult, if not very difficult, if we do not master AI as a technology. We have the potential, according to one of the surveys, in terms of readiness to use, absorb AI, we are on top. So we have the potential, but we have to move toward using AI, creating solutions in a very big way. Two parts to this. One, to create AI. So India must create hell of a lot of AI. We should be a big creator. We have the potential. We have STEM. We have IT industry with us. We have startup culture. We have policy which doing a lot to facilitate, and so on. But the other part is we must adopt it. Whatever tools, and there may not be many tools today, say in AI for health, but whatever has passed muster must get adopted, because then only the impact would come. If we are late adopters, we would suffer. And it is actually said that the nations which will adopt faster will actually gain out of AI more. So once a product is ready, use it. The problem with readiness of the products is that we have several ideas, a lot of hype, but the ones that are proven in terms of their clinical validation, there's a technical validation, X-ray, AI, okay. Clinical, is it pneumonia, is it something else? It's a huge problem. Validations don't occur in a systematic way. The creator of AI solutions often do not talk to the users. There's never a co-creation, almost never, I must humbly say. We have no concept of what we mean by sensitivity, specificity. For example, if somebody claims, give me an extra minute, sir, on this. If somebody claims it detects cancer, and I ask them, in the current time, in terms of diagnostic accuracy, we ask for one metric, at least today. Tomorrow, AI may have new matrices. Sensitivity. Sir, 90% is very high. Okay, 90% against the gold standard. Is it very high? Because that tool, beyond human sense, is going to miss 1 out of 10. I go to Anganwadi, I go to my Ayushman Arogya Mandir, get my breast examined. I am told, you don't have the cancer. I am that 1 out of 10. Next time, Patanji is going to call me after 3 years. I missed it. So what looks like good to a specialist of this area may be so critical. So the fusion of public health science imperatives with the people who are creating these tools and joining hands is extremely important, and therefore when we have AI solutions, they have to pass muster of its own in technical validity, then clinical validity, and then we say real life validity equal to effectiveness, the middle one being efficacy. The tools that have gone through this all the way, and then you end up not having too many of them. But the ones that are ready must be adopted. So we must move in this direction. A lot can happen. What I'm showing here is, in the slide, to make a point that when we are creating AI tools, I just picked up from the discussion, so pushing this one slide for you, for kind consideration, is that use case scenarios for AI in health are not only in the space of disease. And can you show the slide now? Coming? Okay. So we visualize that the AI for health has at least 5 dimensions. Most of the time you hear about AI use in the second dimension, detection and possibly management of disorders. So clinical decision support. So detection of retinopathy, detection of whatever else. That's where 97% of the noise is. And it must happen. True. It must happen. We must be leader in this. But I wish to point out areas where less efforts are being made. Prevention. On prevention and health promotion, using AI tools for better lifestyle, better diet, yoga, Ayush systems. These are unique. Some efforts are there with all these variables and so on, but unique to India. But more difficulty and more gap is there in the third and the fourth bucket, health systems. Health system and public health are unique to a nation. Tools that are prepared elsewhere will not be necessarily useful and ready to be used by us. What is health system? In the health system, let me just pick on some aspects which I could not send. So we have this primary healthcare system. What are the tools that can fit there? We only have to make. What about using, say, AI tools for health financing, supply chain through our kind of system, outreach activities in schools, AI for detecting vision problems, refractive errors in schools. 225 crore children are in school. 10% of them need spectacles. All of them need eye check every year. Our problem. It may not be problem of another country. We have to do it. Insurance and so on. So health system, in terms of systems, where are our AI tools specific to India? And it becomes even more specific when you move to public health. There it is our own genome or genetic distribution is different. Precision public health, pandemic preparedness, One Health related surveillance, outbreak prediction, outbreak modeling, all this is unique to our own epidemiological underpinnings, genetic, environmental, commercial, and what have you. The point that I'm making is that these two are the areas which must be brought to the attention of our own ecosystem to develop AI solutions. The fifth one is using AI for drug discovery, for research, and so on. Perhaps scientists and researchers would do it. But I'm very concerned that much of the discussion happens here, and we think a lot of progress is happening. It's a lot of hype, a lot of resonance. But the critical areas where our own unique solutions will come handy would be the health system and the public health itself that I want to bring to your kind attention. Now here, when you have portals and they don't talk to each other, how do I create new knowledge? How do we do it? We have to break these silos. The silos are at the moment colliding. We have to create a health data exchange, a health data commons, which is available and can be systematically and legitimately, and rules on basis of rules and trust systems, use them to create solution. Just maybe about 2 months ago, President of US has launched a Genesis mission in which he has given a decree that all the data that's available in federally supported research systems be made available for AI solution. I dictate, trying to break silos in another country in a different context. We need to work to bring it all together so that all this is available for solutions. I'll give you an example. A tool has been now introduced into TB detection, a digital AI enabled tool. It needed to be tested. The ICMR offered more than 1 lakh digital x-rays from the TB survey for this to be validated. The vendor was claiming that it was already valid, but obviously not to the comfort of the epidemiology and scientist community, health research community. Once that became available, now you have confidence that it does the job what it does. Well, imagine that if that access wasn't there or was delayed, we would not have had that solution. So we have to bring data to be able to use, and for future, our data quality has to improve. The data has to be truth. Machine readable, a lot is happening for airing data to be read by machine. It has to be unique. It cannot have 10 duplications. It should be able to be cleaned up and so on. So currently, make the best use of what we have in various silos and bring it together for creating AI solutions, for us to be in the leadership role, and then concurrently improve the data systems in such a way that over a period of time, we have even more accurate algorithms coming through out of our effort. 2 brief points, taking cognizance of what was being discussed as I entered. Public health cadre. It has been a strong recommendation for a very long time. HLEG, High Level Expert Group in particular, highlighted this. It became part of the national health policy. We have difficulty in making progress in this regard because the states feel that to reorganize their workforce, the public sector workforce, is not easy. What we envision is that there's a specialist cadre, there's a teaching cadre, there's a public health cadre, and then there is a health system support cadre, which is procurement and so on and so forth. Specialist cadres have now been instituted with the effort of NHSRC and the ministry in, I would say, a few states, 5, 6 states, maybe 7 states, maybe more. But to bring public health cadre, there are difficulties because it would mean, seniority, etc. We need your help in helping states to realize how important it is and help them do it. Hold their hands. And this is something which needs, advocacy at the state level. From the center, there is a push. There are tools are available. The visits are being made. Niti also got into the picture, and we reviewed it and working together. I took it up also in the Council of the Central Council for Health and Family Welfare, which is chaired by the Honorable Minister, Union Minister, but all the other ministers are also member. We flagged it there. So there is a intrinsic issue with regard to the uncertainty and the difficulties in states. Can you please help? You all are there in different states in your own ways. Help. Last, I wish to make a pitch for family health and family medicine, please. And please debate on this one. In an ideal world, there must be general practitioners, competent, and who refer patients to specialists. That's what I think the basic assumption in this room would be amongst public health fraternity. WHO visualizes 0.3 per thousand out of that 1 per thousand to be general practitioners. In OECD countries, exactly the same. About 30% are general doctors and 70% are specialists. That's one. What is happening now? That means you cannot do away with family medicine in terms of an academic vision for public health globally and in our own country. I hope I'm saying a consensus out here. What is happening is that our MBBS curriculum today, with all the best effort, the way it moves, science-based, globally acceptable, cannot compress all the competencies that are required to be a good family medicine practitioner. It may have happened in the past because the diseases were acute. The doctor, my training student could see treatment given, pneumonia improves, I get a sense. In chronic disease, long observations don't happen. I go to Department of Medicine for, let's say, 4 weeks for my posting, a month of, how much of chronic disease will I see? I'm only seeing snapshot. Continuity of care is not visualized. We are therefore not in a position, generally speaking, to be able to give the level of competencies particularly in the non-communicable disease space or mental health, through sufficient clinical experience. It cannot be compressed. That's my submission, and I have been part of trying to make curricula with AIMS, and then you look at the curriculum, the student is busy, but वो हो ही नहीं पाता, and that is why in UK you have 4 more years to 5 more years to become a general practitioner. Family medicine in Americas is another 3 to 4 years. So you need to bring those additional competencies and experience, and also contextual learning in a general care setting. The point I'm making is that there's a problem. I asked this, जो कहते हैं कि यही होना चाहिए, तो did you send your sister to MBBS doctor for evaluation? आप तो सीधा ही practitioner स्पेशलिस्ट के पास जाते हो. तो मैं सबमिट करना चाह रहा हूँ कि MBBS के लेवल पे अब हम उस लेवल पे नहीं पूरा कर पाते. We have to have more experience, 3 years experience to be family medicine loaded, to be able to do a good job as a family medicine in practice, or let's say at a PHC. Having said that, what is happening now? We are increasing our MBBS seats, hell of a lot, 1,28,000 from 52,000 in 2014. Some people say it is too fast. We are also increasing specialist seat. But the traction for family medicine is negligible. You will be surprised that perhaps we have only 40 to 50 seats in the NMC system. Let's say less than 100 seats for sure, maybe 50, maybe 39 in the NMC system. DNB has risen to the occasion, and they have brought in diploma in family medicine and DNB in family medicine. So together, we have 500 family medicine seats out of the 72,000 PG seats today. 1,28,000 MBBS, 500 family physicians, 72,000 minus 500 are the postgraduate seats. Please think whether we are missing something very important. National health policy states we will promote this. National Medical Council Act has a specific clause, facilitate and promote family medicine. Only single clause for a specific aspect. But then I'm giving you the status today. NMC system, DNB system together less than 500 seats. Please, can we be the voice if you all feel that family medicine is important for India? Imagine 2047, very few MBBS because PG programs will be superb, nothing family medicine practically, and all specialists. Is this a situation which is imminent by the already happening? So many people ask me, you कोई अच्छा जनरल practitioner है जो यार इनको देख ले. Care of the elderly cannot be fragmented, at least at the start, and our elderly population will be 23%, 35 crore, and so on. So my humble submission is sabha mein ye कहना चाहूँगा, when we are transforming the public health system and the care of people, please add your voice to how to have a space for family medicine, general practice at a level which today happens to my mind at the level of a specialist among other specialists, but serving the newborn to the elderly care needs in a holistic way. It's a specialty by itself. It is prevention, it is therapy, it is rehabilitation, it's palliation. I urge you that you have a voice for this tenet, which is already enshrined in the National Health Policy, as I said, and also being a recommendation of global recommendation, as I mentioned. Grateful to you for this opportunity. Thank you very much. I hope my points are useful. Jai Hind.
Thank you so much for your insightful keynote. As a small token of our appreciation for your invaluable contribution and for honoring us with your presence today, may I now request Professor K. Srinath Reddy, the Summit Chair, to please come forward and present a memento to Dr. Vinod Paul. Please give them a warm round of applause, everybody. Thank you so much, sir. Well, we will now break for tea. A gentle reminder that we will resume at 12:10 p.m. sharp with our keynote session by Shri Bharatlal. So please be back in your seats on time, everybody.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead, You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
नहीं नहीं अभी एक ही है बाबा भरतलाल सर स्विच हो गया
journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users, disease-specific communities, and a unified discussion feed. Access to authentic resources, welfare schemes, and multilingual/voice-enabled support. Patient-reported outcomes, PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes. Ability to post anonymously, edit or hide posts, block users, and connect with healthcare professionals vetted for credibility. Fast forward to April 2024, IPU held its annual conference focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to Niti Aayog and the Prime Minister's Office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first timed IPU Fellowship, designed to transform patient experiences into actionable policy recommendations, published by IIM Raipur and submitted to Niti Aayog. At the 2025 conference held at the India International Center, New Delhi IPU unveiled enhanced versions of the app, the Fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and systemic reforms.
Which doctor to go to? You may need a specialist. In today's fast-paced world, healthcare can feel confusing, overwhelming, even out of reach. For bridging the gap between patients and healthcare systems, here's the Patients Union app, your one-stop solution to make healthcare more transparent, accessible, affordable, accountable, and outcome-driven. Here are the main features of the app. D are easy. A chatbot for health guidance. List of disease conditions. List of medicine. Specialty advisor based on your symptoms. It guides you to a specialist. Authentic resources. Patient-reported outcomes by rating your hospital, healthcare providers, and health services. Events such as Dr. Hour to connect you with a specialist. List of government schemes. Drug-drug interaction. Lab report summary. Multilingual support with Bashini. For now, no more confusion. Just the right care when you need it most. Download the Patients Union app, helping you find the solutions.
कॉफी ली है जैसे तुमने इस सेशन में किया तो तुमने इस सेशन में तो किसी को कप नहीं दिया जिसमें सुनने की मैंने लिए तुम भूल ही गए
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
I would request everyone to be please seated. We're about to begin. Welcome back, ladies and gentlemen. I assume a few of you are on your way to be here in the hall after this short little tea break that we had. As we begin this next segment, we turn to a perspective that anchors public health firmly in the principles of rights, dignity, and justice. It is therefore a privilege to welcome Shri Bharat Lal, Secretary General, National Human Rights Commission of India, to deliver a keynote address. A distinguished civil servant, Shri Bharat Lal, has served in several pivotal national roles, including as Secretary to the Lokpal of India and as the founder mission director of the National Jal Jeevan Mission, a transformative initiative aimed at providing clean tap water to every household. His work across water, sanitation, governance reform, and public service delivery reflects a deep commitment to improving quality of life through inclusive and rights-based approaches. We are honored to have him share his insights with us today. Please join me in welcoming Shri Bharat Lal for his keynote address with a warm round of applause.
More than sufficient. Right? Good afternoon, everyone. Dr. Rajan Prasad Gupta, my esteemed colleague, Mr. Rajit Punani, CEO FSSI, Sunita ji, Dr. Srinath Reddy, and other esteemed colleagues, friends, ladies and gentlemen. Well, first and foremost, I think it's my privilege to be here. And thank you, Dr. Gupta, for organizing this kind of meet. Very seldom, actually, this kind of discussion takes place, where basically health, I mean, we have been talking about One Health. Here we are connecting with Planetary Health, and I think this very holistic approach is taken. So in this sense, I think this is very meaningful meet. And let me just dwell for a couple of minutes actually about the National Human Rights Commission, where I work presently. As we all know that fundamental rights are guaranteed in our Constitution. And this fundamental right to life, is one of the most basic right. And we also know that Supreme Court is custodian of fundamental rights. But when it comes to right to life, right to health is very inherent. And you must have observed that Honorable Supreme Court of India, while interpreting the Constitution and evolving further, so right to life, right to health, and right to environment, right to clean air, right to water,
I think these are the basic livable conditions where you can enjoy, right to life. And National Human Rights Commission is an apex level institution in India, basically created in 1993. And basic is that anybody who's affected, or his or her rights are violated, National Human Rights Commission is look into those issues, and both proactively as well as if there are grievances. And most of the people understand that National Human Rights Commission, when it comes to human right, it is more about socio-political, those kind of issues. There's a right to free speech, or right to assembly, or or police atrocities, or custodial, deaths. So most of the people understanding is that human right is all about this thing. But you must have observed that in recent years, not only in India, worldwide, human rights has evolved. And today human right is not only socio-economic and cultural rights, but I think health, climate, or even go to business actually, you will find that rights of workers, working conditions. So I think this is the latest development in last couple of decades, where harmonizing climate issues, business, issues, workers' rights, environmental and climate, issues. I think harmonizing all these things with your human right has become very, very important. And I'll dwell about what National Human Rights Commission is doing about these things. I'll come in a minute. But as we all know that when it comes to healthcare, I think somehow common people, common understanding is health means hospital, health means medicine. Most of the time, people, think about, But in last, let's say, couple of decades, and especially recently, I think a lot of awareness has come. That these external factors, especially environment, climate, and most important during COVID-19 pandemic, I think people realize the value of environment, your surrounding, and So I think let's see that the health, basically the way National Human Rights Commission looks at it, that health begins before a person enters into a kind of clinic or hospital. For us, it begins with the air we breathe, the water we drink, the food we grow, and cities we design, basically, and the climate we inherited. The National Human Rights Commission focus is on these issues, basically, so that each and every individual is able to enjoy their full human rights and what we call right to life. Well, as we know that our public health system, yes, for a huge country like ours, there are huge challenges. 1.46 billion people, 650,000 or 55,000 villages and towns, 4,300 plus towns and cities. So I think this expanse is too huge, and we have to see that there cannot be, there cannot be only one system and only basically treatment so that each and every individual is able to enjoy, But most importantly, what we have been seeing, and we all are basically experiencing, is basically when it comes to air pollution, or let's say safe or potable water, very, 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 very basic, or antimicrobial resistance. I think these are heat waves, cold waves. Nowadays you are seeing that, I think it is connected with your right to life. It is, but most importantly, I think we all have here, this crowd, this audience is most enlightened. We don't think about only ourselves. We are here because we think about society, and that's why we are here. But if you will see very carefully, all these environmental issues, who is the worst affected? Yes, somebody can say when it comes to polluted air, we all are affected, our children are affected, everybody is affected. But invariably it has been seen that all these, environmental, degradation, poorest, are weak, are vulnerable, are marginalized people, they are the worst affected, Even children are more affected vis-a-vis we. we grown up in when it comes to facing air pollution. Or say, imagine that today also we are seeing that situations where in Indore it happened, recently water issue, in some part of other countries, is happening. I mean, if you look at data, a lot of work is being done, has been done, and will be done. But just look at data here. Sunita ji is sitting here. In last 20-25 years, you have seen that, no doubt, a lot of things have happened in Delhi city. I mean, take CNG buses, phasing out of old, diesel-operated buses. So many things are happening, but lot need things to be done. Same take water. If you look at the water, in fact, I had the privilege of working actually for almost 25-30 years. I have been working in one way or the other. Look at very carefully. I think there is some kind of alignment. What people at the ground are saying, what civil society NGOs are saying, what academic and research institutions are saying, what government is basically policy programs are being designed. But if you see, water has taken a center stage in the sense that yes, river need to be cleaned. It started with Ganga river, but I think now 15-16 rivers are being rejuvenated. I think just imagine that a couple of years back, actually, in every district, 75 water bodies to be created, what he called Amrit Sarovar. That had to be done, actually. Just imagine the importance of this planetary health is for public health, our individuals' health, actually. See that a country like us, when we have number of rainy days limited to 15, 20, 30 days, 60% of our peninsular and central India basically is rain-fed. Our rivers are, except glacier, fed northern India and northwest India or eastern India. Most of the river are basically, fed by forest and this. If we don't clean our surface, if we don't make Mother Earth open defecation free, how we can collect clean water, how we can store clean water, how we can keep on treating and then drink it. Just imagine that if you are given water, even after treatment, but it's passing through fecal matter, why we are blaming anybody else actually, that why we are having this kind of waterborne diseases or different issue. I think as a citizen, it is not the policy maker or government who come and just spread, all these solid waste or liquid waste or, this thing. I think we are equally responsible. The limited point is that it is your money, taxpayers' money, which is spent, utilized in all these activities, whether we are in position to prevent it or not. If we don't play our role, if you take air pollution, National Human Rights Commission since last couple of years had taken up that air pollution monitoring, and since recently High Court has again seized the matter, so we stopped that hearing actually. But it is not the government who's going to and burning the parali, or it is not the government who is creating these particulate matters actually. We are saying that almost 1.7 million people every year are affected by this particulate matter. The question is, who is responsible? I think we all are responsible, and we all have to get into that. So coming back, this kind of concerted action, whether it's Amrit scheme or Jal Jeevan Mission. Jal Jeevan Mission is what? It's a very holistic program. There is a water source, it has to be kept clean. That's why government launched Jal Jeevan Mission and Swachh Bharat Mission, basically Jal Shakti Abhiyan. It means collect water, keep it clean, and then this water is supplied throughout the year to every family, every individual. Same is with air, with same heat waves and cold waves actually. So my request would be that I think this kind of conference is very helpful, basically bringing out issues on forefront. But more importantly, how we can contribute in basically very tangible, very tangible. It might be very small, but very tangible action. And here basically we have today, this conference to me is very useful. That if we have to ensure a country like ours, 1.46 billion people, is not possible that for everybody's treatment you create infrastructure, human resources, and So preventive health care through this approach, that planetary health is very important. I think that is the only way forward to me actually. Two things I would like to say. Planetary health, basically ensuring that surroundings, environmental and climate, these issues are tackled. And B is that how to ensure our reach. And that's why we keep on talking about digital health solution, that in the villages, in the rural area, like you and me here in cities, we are having access to a doctor within 10 minutes, 5 minutes, 15 minutes. I think the challenge is that how to ensure access to healthcare services in a village within 10 minutes, 15 minutes and 20 minutes. And you will agree with me that I think digital technology, I think provide that solution. Maybe tomorrow AI driven, AI supported, but today digital health solution is the product that in every village, if we have that interface, then people can reach to that. Well, one more issue I think I'll just highlight, that National Human Rights Commission, we are having a core group on health, mental health and other issues basically. Similarly, we also have a core group on environment, and climate, and we harmonize these two groups. Basically. We harmonize both the things together actually, and advisories are issued, cases are handled, and government is basically nudged to take those kind of action. Friends, one or two things I would like to highlight. The long-term impact this environmental degradation is having. Just think about 10% of our population today above 60 years, I think around 7% more than 70 years, their vulnerability to environmental issues, I think is much more than both of us. Come to lower spectrum, every year 20 million children born basically. Just imagine their vulnerability to. So my only request would be, just think about the poorest of the poor, the slum person. I mean, cold waves actually, every year during heat waves and cold waves, beforehand we are issuing advisories, giving direction to various state government. We are looking at data earlier, previous 5 years before 2022, 3,400 deaths took place because of heat waves. So we ensured last year that before heat waves, every state has to be nudged that please take preventive steps. So this should not happen. Similarly, we have done the cold waves, but the reality is that still, you will find that people are basically dying because of these regions. Well, I think Dr. Paul has spoken and he was just talking to me, but for a minute actually I'll dwell, about. Please see in Indian context. In fact, he especially asked me, that's why I'm speaking on this topic. This holistic approach, if you have only 15-20 days of rainfall, you have no choice except to collect water and store it cleanly. It means Swachh Bharat, Swachh, clean India is the prerequisite. If you don't collect this water cleanly, don't store cleanly, let's not expect that we are going to have a very clean water at our home. This treatment technology, all those things is fine, but their human error can take place any point of time. And I think then we are living on edge actually. So Swachh Bharat mission, similarly Jal Jeevan mission, and followed by Jal Shakti Abhiyan that collect water. I think they all go together. It means water bodies you have to protect, you have to keep water bodies, you have to rejuvenate air. I'm very happy, in fact, recently I have seen the kind of interest people took in, let's say, Aravalli, this whole thing, that yes, nature has become important, that people are basically invested in we are not indifferent to these things. So keeping these things in mind, I think while closing, I will suggest 2-3 things, that yes, we all in healthcare system, I think we have to start focusing, which government is doing basically, this Arogya Mandir and Wellness Center and all those things, from treatment to prevention actually. This is one thing I think everybody agrees that I think time has come that we should be more focusing on, and this kind of holistic healthcare, whether it's say Indian system of medicine or Arogya Mandir, and all those things are happening. Second thing is that about from silos to system. I think the health issue is not only the concern of Ministry of Health and Family Welfare. I think we all are involved. Other ministries, other departments, state government, other institution. Third thing is that when we are talking about Viksit Bharat, next 25 years, it means it's not only GDP or even per capita income. It can't be just only GDP and per capita. It means the quality of life. It means the time has come when we must start talking about quality of life, and quality of life including surrounding, including environment, including health outcome, including social equity. I think the time has come for Viksit Bharat, we should be talking about that part, And fourth, which we all know and we are doing here, is basically from vulnerability to resilience. See, in rural India, in remote, forested area, in mountains and desert, until unless we don't develop that local capability and resilience system, this public health or good health, I think next to impossible to manage. Well, all these things can be realized when we have this right to clean air, without any doubt. When we have right to access to safe drinking water, clean drinking water, we have improved sanitation and hygiene, right? Adequate housing, safe working condition, and basically most important is livable habitat and livable cities actually. For all which this thing, I think we all have to contribute and ensure that governance, delivery system, and more importantly, data sharing. To me, the worst thing is that then when the data is not available in open, and when scientific community, research institution, non-governmental organization, they are unable to look at data and basically carry out a study. They should be able to give that feedback. In fact, you might have noticed in Jal Jeevan Mission, we ensure that all data are on public domain and dashboard, and basically very user friendly. You want to download an Excel sheet, please download. And last point is that I think country like ours, we have to use digital technology for automated capturing of data. No more on phone and reporting and these things. It has no meaning. पानी मिल रहा है, सबको नहीं मिल रहा है, phone पे पूछ लिया पानी मिल रहा है. I mean, you can have a digital device, sensor-based IoT device. You can upload your water quality in your tap. You can have a sensor-based IoT device link with your phone. I think this is era, and citizen must demand for this thing. If we don't demand that water quality, let me tell you, I have worked in a state from both sides. I have seen government and public health engineer. They really, they basically work hard. Water treatment plant, they function, and potable water daily testing takes place, data is reported, and water is supplied. But since we are not responsible at the delivery point, that water which reaches to your house, your home, what is the quality? And we have developed a beautiful business model. The water coming from tap, we are not sure. We are not sure whether it's potable or not potable, but we presume it's not potable. So this presumption, this lack of trust, lack of faith, lead to what you call a small device at our home. It could be RO, it could be some candid, it could be some, those kind of, something comes out of this system. That water you also don't know whether it's a potable or not, but you have immense faith because it has passed through this system. Whether it's a UV or something, this water is potable. See the system, and the whole business model just operate on this thing. Why we can't society demand this thing, that I should have a device. I should have a device in my tap or at my home. Today you can test your BP, your sugar, your everything, pregnancy, everything, But water testing at home, not possible because there is no demand, because people are not promoting it. But imagine when I demand and see the power of, power of, public advocacy. I mean, here so many people, and Sunita ji is one of them actually, who had used this public advocacy for action actually. In my opinion, if we start insisting on these things, I think government officials like me, we all will be forced to work actually. Well, friends, I'll also give one or two, just before closing, one or two just example how it works actually. And I have seen in one part of Gujarat actually. I went to Gujarat state in 1990. 85 to 87, Western India, basically huge drought. A lot of migration took place, even somewhere evacuation took place. Water was being supplied through trains, not tanker, but train actually. In fact, there is a data actually for 3 districts 3 districts in Gujarat, last 4 census population came down. Can you imagine that in India, in some district population is coming down, and this was happening in Gujarat. But when this water management was taken care of, that yes, rainwater harvesting, drought proofing, basically, interbasin transfer, linking all water bodies through what we call Sauni Yojana, transferring water, optimal utilization of reservoirs capacity, the whole environment, the whole, this thing. Today, I think Jamnagar has become more livable cities because you will find so much greenery, so much, this thing, So my request is that these importance of these things, I think we have to keep on hammering. We have to keep on hammering that end of the day, we have to make cities or town or villages livable. And if we demand, citizen demand, obviously government will work. But let's not forget that human right or any kind of right you can enjoy without responsibility or without duty. If we have to enjoy our right, I think we have to perform our duties also. With this note, I think allow me to close here and wishing this program very best, and I'm sure I'm looking forward to its outcome, and pretty confident that it will help National Human Rights Commission also actually in formulating its strategies, advisories, or recommendations, and thing. So have a wonderful day. Thank you very much for having me here, and look forward to seeing you. Thank you so much. I have to come there? Oh.
Thank you so much, sir, for that thoughtful and deeply enriching keynote. As a token of our appreciation for your leadership and for sharing your valuable insights with us today, may I now request Dr. Rajendra Pratap Gupta to please come forward and felicitate sir.
How can I felicitate my guru?
Please, everyone, give them a warm round of applause. Sorry, I'm not tall enough. Thank you, sir.
Thank you so much. Thank you.
Moving on, our next session is From One Health to Planetary Health. Over the past few years and more, extensive work has gone into understanding One Health, not just as an integration of human, animal, and environmental health, but as part of a larger planetary health perspective. This session will discuss how we move from fragmented approaches to a more holistic view that recognizes the interdependence between ecosystems, climate, economies, and health outcomes, and what this means for Indian policy. For this discussion, we are privileged to have Shri Rajit Punhani, IAS Honorable Secretary, Government of India, CEO FSSAI, the Food Safety and Standards Authority of India. Then we have Dr. Sunita Narayan, Director General, Center for Science and Environment, Editor Down to Earth. We have Brigadier Jyoti Kumar S. Dharmadhiran, Country Director and CEO, Brook India, and Dr. Rajiv Kumar Jain, Chair, Scientific Committee on Education and Training in Occupational Health. I request our distinguished speakers to kindly join us on the stage. And to steer this landmark discussion and take the session forward, it is my pleasure to hand the proceedings over to Brigadier Jyoti Kumar S. Dharmadhiran, who will moderate this session. Over to you, Dharmadhiran, sir.
Good afternoon, everyone. Dr. Vinod Paul, the speaker previous to me, Sri Bharat Lal, they have outlined what One Health and Planetary Health is. It's a concept. And it's a concept that has been recognized by the top leadership of our country. If you actually go to see, the Prime Minister's office has a department which looks after One Health. One Health mission has been set up. The Prime Minister recently talked about antimicrobial resistance. So the top leadership understands this concept. And I won't dwell upon it because this is a subject which we all know about and every one of us sitting here is involved in it. What's its relationship to public health? Public health is what implements this concept. And One Health just not, and another very important concept is we all talk about silos. Yes, there are lots of silos. And this happens at the implementation level. One Health just does not mean human health. Yes, it is primal. Everything which we do works on achieving good human health. But it is closely associated with animal health, environmental health. Without it, we will not have One Health. 60% of the epidemics and pandemics came from animals in the last 1 decade. The recent COVID-19 pandemic which took place also came from animals. The environment is equally important because these are factors which create the environment for these exciting factors to create ill health. Today, I'm not going to dwell more this is because this is not a One Health session, but what we must understand is what again we all, I think it was announced a couple of years back, it is one world, one health. The planet has to be healthy, then we will be healthy. And three very important aspects of this is the food we eat, the air we breathe, and the work which we do. We should live in an environment which is healthy for all of us. So I have three very eminent speakers here who will speak about all this, and I have requested my panelists that they would speak the main salient points of whatever specializations they come from. And then we would like the very distinguished audience sitting in front of us to give us some comments, give some suggestions, and ask some questions. Because all that happens here will go into formulating a policy, which I thank Dr. Rajendra Prasad Gupta very well, which we have been associated with, to form these thoughts into a policy paper which we can present the government. Thank you very much. I now invite Sri Rajit Punani, IAS. He will speak about the food aspect of One Health.
Thank you. I would have preferred if it was just question answer. I have something which has been prepared by my office, but this is something which I think all of you would know about. You know, I presume, what FSSAI does. We basically, we are the Food Safety and Standards Authority of India. We set standards and look after food safety. A lot of the enforcement is done by the state governments, in which most of them have a commissioner of food safety, and they have an FDA department. I just want to clarify that because we get so much of flack on social media for everything that happens in the country. So I just wanted to clarify that. So for this session, I would just like to highlight our Eat Right India movement, because this, I mean, besides the enforcement and the regulations that we come, we've also launched a campaign called Eat Right India. And for this session, I would think that this is most appropriate. So it has three components: eat safe, that I think our standards do maintain, but then we also have a lot of the unorganized sector. Professor Gupta is here. When I was in Ministry of Labor, we did a lot of work on the unorganized sector. So even food, there's a very, very large unorganized sector. We are still very proud and very, we like our street food, but then we have to also ensure that our street food is hygienic and healthy and safe. So the other is eat healthy. That has become at least the urban middle class has become very aware of it. Our har label kuch kehta hai has become quite popular. I see amongst the younger generation. They do look at the nutrition label, which I've never looked at. But I see many people who say, no, I've looked at the nutrition label. I've seen how much sugar there is, how much salt there is, how much protein there is. So that is eat healthy and eat sustainable. And Sunita Narayanji is here. So we are also, IIT Kanpur has come up with a proposal of the carbon footprint of food. So how do we ensure that what the food that is grown, and that depends on our demand. You see, it's basically consumer demand. Besides marketing is one, I would say definitely one aspect, but it's also otherwise the consumer demand that drives, what is grown. So like when I joined Bihar about 30 years ago, in my garden, makhana was extremely cheap. It was like, garib aadmi hi khate the. Anyone well off would not look at makhana. Now makhana is a superfood. It's so expensive. It's now 1,000 rupees, a kilo. You get it at the farm. When at one point of time it used to be, 100 rupees or even 50 rupees a kilo. So, what do we ensure that the healthy food is cheaper and the unhealthy food is expensive? As of now, we have what we see around is that our unhealthy food is cheaper and our healthy food is more expensive. So how do we change that that paradigm shift is required. So carbon footprint of every crop, how much water is it consumed? So that way millets that has been promoted by the government recently is a big move in that direction, that how do we make grow sustainable crops. And millets have become more and more popular. So how do we ensure that those other crops which consume a lot of water or which require a lot of storage and distribution, how do we ensure that those are grown less? So through this holistic approach, Eat Right India tries to promote both the demand and the supply of safe, health and sustainable food. So that's all I'd like to say. I'd be very happy to answer questions. Thank you.
Thank you very much, sir. You have brought out very succinct facts about where we are going ahead. And at the end of the session, when all three of us, all the three panelists stop speaking, we'll invite suggestions and questions from you. Now I request Dr. Sunita Narayan, she's well known to all of us, to speak, and in one of the strongest environmentalists in our country, to speak on environmental health.
So thank you very much. I am struggling with this a bit. It's working. It's working. Yeah, sorry. So thank you very much, and thank you, Srinath, for inviting me. I'm really happy to be here because this is a unique opportunity. We normally speak to our own community, and I think it's important for us to reach out to all of you in the work we do, because the work I do as an environmentalist, it's very clear that for me, the issue of health is the most important central point in the work we do. We don't work on air pollution. We work on the health impact. We work on air pollution because it has a health impact. You work on water pollution and cleaning up rivers because of the extraordinary health impact it has. And I keep saying that, when it comes to water, we will all drink mineral water, bottled water, and our rivers are dying, other than the fact that now in Indore we find the cleanest city, that underbelly, which I call the sewage underbelly, comes up in the clean water that we have. And that is the issue for us because that's the health impact. When it comes to air, and I like air pollution for that reason, is that it's a great equalizer. Bharatji very clearly said, and I agree with him, the poor are most impacted. But the fact is, air, in spite of all the air purifiers that we are putting up in our houses, we all have to breathe. And we have to fix air because nobody is safe till everybody is safe.
And I think that's really important for us in the work we do. When we work on food, and some of you may remember, we started the testing of Coca-Cola and soft drinks for pesticide. And frankly, for us as environmentalists, we were not interested in the colas. We were interested in the issue of contamination of our food. And for us, the issue of pesticide contamination was really about why is it there? What is the state of our groundwater, where we are beginning to pollute more and more and we are not able to clean up. And of course, that issue of pesticide contamination for us then became one in terms of how do you regulate food and the use of toxins and balance what is nutrition versus poison. We're not getting it right still, but there has been a lot, and FSSAI was set up post our work through the JPC, the Joint Parliamentary Committee. FSSAI was set up, and there's an extraordinary amount of work that you are doing to get this balance right between food for nutrition, food as poison. Then we started working on something also interestingly, because we got a call from many of these work that we do, we're kind of, we're like journalists, we listen. And the work that I got a call from one top doctor in India once saying, he's really worried that he's seeing so much antimicrobial resistance. And for him, the issue was that these are patients who are not exposed to over-the-counter antibiotics. So is there something more that is happening? And that sort of got us started. We looked at chicken and we found antibiotics in the chicken we eat because of the growth promoters that are given, the integrated nature of the poultry industry. We tested honey and we found antibiotics in it because of the fact that, again, it's given for growth promotion, not for as a medicine. And that started the work that we have done over the last some years. I have been a member of the Global Leaders Group, which is a group set up by WHO, by the UN actually, to look at what then needs to happen with AMR. And from our point of view, we have brought the whole concept of prevention into it. And saying that we cannot anymore look at AMR from the point of view of cleaning up after we have contaminated. And that has, in fact, and I can say with some amount of confidence to all of you, at the UN high-level group last year, when the AMR declaration was put out, the issue of prevention was at the core of it. And for us, the prevention issue is really about how do you do changes in the way we do agriculture? How do we grow our food so that we don't have to first contaminate and then clean up? Because we cannot clean up antibiotics after they get into our water system, after they get into the waste system that we have. And we have, as part of the good practices in India, we have the need to do circular economy. So we will take poultry waste and put it back on the ground. But if that poultry waste is contaminated with antibiotics, you are adding to the health burden. So it's a fascinating, I'm giving you this only to explain to you that what essentially we have increasingly found in the work that we have done is that we need this systemic change. We need to think more holistically. We will have to, when we look at water pollution today, and you look at Indore, for instance, and I'm glad Indore has become such a big issue in the country, because frankly, the health burden of dirty water is the biggest scandal that we have in India, and we don't talk about it. We still have diarrhea, we still have gastroenteric diseases. We are now talking about the resurgence of cholera, not so much in India, but in large parts of Africa, it's coming back, again because of the climate change connection, because of more water, and the inability to manage dirty water. But the point for us is, it's not about water, it's about sewage. And it's about the mismanagement of our sewage system so that we care about the quality of water that comes into our houses, but we never think about flushing and then forgetting. That is the model that we have till that pathogen comes through into our drinking water system. So we need a systemic change, and it is possible to do so. When it comes to air pollution, a campaign that we have been working on for years, and in some level, we're failing, completely failing. But we are failing not because of a lack of solution. We are failing because we are not taking it to its logical end. You cannot deal with air pollution unless you understand that you will have to have affordable mobility for all. You cannot have a car-centric economy and yet think that you can deal with pollution. You cannot run your industry based on coal and yet think that you're going to be able to deal with pollution. So the point I wanted to make to your community is that for us, you are very important, because the action we get in our work is driven through health concerns. I believe one of our biggest achievements has been to get a health index for air quality, which links air quality with health. That's an official index. So today when people look at their phones and they see the AQI being high, it's not a number, it's how it impacts our health. And that's the trigger for action. But that also means that we need to be able to work together to find solutions. They exist, but they will require us to go beyond just talking about good food. And one of my big agenda for the FSSAI is to get front of the pack labeling so that everybody knows what is this food all about, because we cannot afford to have diabetes first and then talk about having all these fancy medicines today, which Srinath knows about, that we can deal with it. And the last point I want to make is where this all comes together is our work today is about biodiversity, and it's about the fact that if you have biodiverse foods, it is good for nutrition, it is good for livelihoods, but most importantly, it's good for the soil that we have. So the soil biome is all about biodiversity. And what Srinath reminded me some time ago, and this is the most important thing, that the gut biome is also about biodiversity. So the question of biodiversity is about what's in your gut and what's in your soil. And that, to me, is where the One Health comes together. We don't need any fancy language on it. The question is, the quality of soil is about what you grow. The quality of your body is about what you eat. And both need to be nutritious, biodiverse, and put money in the hands of the poorest. Thank you very much.
Thank you very much. I think after that very passionate eloquence of yours, I don't want to comment anything more. I would request Dr. Rajiv Kumar Jain, please, to tell us something about occupational health and its impact on One Health.
I must thank Dr. Rajendra and Dr. Srinath for inviting me to this important session. And it's a tough job. Dr. Sunita has made it so tough. She has been such a vocal, staunch advocacy expert, I must say. Whatever topic you gave, she knows how to advocate for that topic. So emotionally, I must admire. And I've been watching her for such a long time, and a lifetime passion. I must admire that. Great. The session pertains to One Health and Planetary Health. What comes to your mind when you talk of One Health and Planetary Health? Do you think of yourself? Do you think of the built environment? Do you think of all the life around, plants, animals, all together? Do you think of non-visible environment? What comes to your mind? Like average age in this audience is around 30 to 40 years, as I believe. That's my assessment after seeing the audience. What is your view? What comes to your mind first when you think of One Health and Planetary Health? Anybody? Yeah, yeah. Anything else? Just look at the level of engagement on One Health and Planetary Health. 2020, we faced COVID-19, and it's been more than 75 years of Indian independence that we have been practicing public health, public policy, and other planned developmental process in our country. What is your knowledge regarding biosafety in our country? Do we have at one single place in India one biosafety level 1, 2, 3, and 4? Do we have it? If it is so, where is it located in our country? 75 years of independence. When you think of One Health, can you think of a biosafety laboratory in our own country at one single place, BSL 1, 2, 3, 4, and ABSL, Animal Biosafety Lab, level 1, 2, and 3. If anybody in this hall knows about it, kindly let me know. Anywhere in this country. Yeah, come on.
Is there in NIV Pune.
But NIV Pune, does it have level 1, 2, 3 as well? My question is very accurately verbalized. In India, at one place, BSL 1, 2, 3, 4 and ABSL 1, 2, 3. And a country which is the second largest country in the world, 75 years after investment, so after independence, we have made so much investment through a planned process of development. Do we have anybody in this hall? Kindly raise your hand and let me know. I would like to visit that laboratory. That place.
It's Bhopal also.
My question is, again, I will verbalize. At one single place, level 1, 2, 3, 4 and level 1, 2, 3, animal and human health. What is One Health? Connecting animal health, environmental health and human health. All three together. Do we have it? Yes or no? Say no. If you do not know, say no. In one voice, say no. Yes. That we should be proud of creating evidence. We do not have it, we need it. That's what Dr. Rajendra has been trying to do. Raise voice and make people aware what we are lacking for One Health, what we are lacking for making a policy based on evidence. How do you do research? How do we know that something like COVID-19 is going to come in the years to come? How do we know unless we have a laboratory? How would we ever know? We will never know. USA will tell us, China will tell us, some European country will tell us, but amongst the developing countries, we are the leaders. 2047, we are trying to go ahead with the global leadership vision. So, in January 13, Gandhinagar, there is a biotechnology university. So next time when you go, please visit this university. Our Home Minister laid the foundation stone for level 4 biosafety lab in Gujarat Biotechnology University. First time at one place you will have ABSL 1, 2, 3 and BSL 1, 2, 3, 4 in one campus. And foundation stone laid in 2026 when we were independent in 1947. We have suffered in 2020. After 6 years, this project was announced in 2022. We have got the foundation stone laid in January 13. Fact 1. Fact 2, we make policies to implement. And whose voices we hear? Dr. Rajendra has been creating the nomenclature, which is generic nomenclature of health parliament. What is a parliament? People's voice, where people raise their voice in all shades of thinking process. If you read the logo of Health Parliament, kindly read the 3 byline. What is it? Anybody can get up and read from the screen top left. Kindly read. What are the 3? 3? Yes, that's what. So, Dr. Rajendra, here's a challenge. You've made logos and the byline so small that people find it difficult. He wants you to work hard, right? So anybody, younger lot, who have sharper vision, in your name, everywhere this logo is there, kindly read the 3 phrases under this logo. Wow, one voice, great. But if you see the sequence, I would read it the last first. That is right policies. Right side is right policies. And center is great leaders. But the first is real work. Who will do the work? I, you, or we? We. But there is a voice of we. Are you ready to do the work for transforming public health in this country? No, it's very, very feeble voice. Are you willing to do the transformative public health work in our country for your lifetime, younger lot? Yes. Great. So to do that, you have to take everybody along. And who is that everybody along? Kindly identify those everybody. Your colleagues, your parents, your family, your city, your town, your village. What? Something beyond this? Are you going to take them along? Yes or no? Yes. So who are the others? Those so-called we. When we say we think of our, human beings around. Or we think of something visible, something moving. That is animals. But the plants do not seem to move. But are they non-living? They are living. So we could modify. We'll take all who are living. But are these enough? Air may be not moving, but earth may be moving, may not be moving.
Pardon me, sir.
Yeah.
I have been given a message too.
Yeah.
So
sure. I'm closing.
We would like a couple of suggestions from them also, sir.
Last concluding remark. We have to take living, non-living, and others along because we are built of Panch Tattva. That is, our tradition says we were made of Panch Tattva, we will be immersing ourselves in the Panch Tattva. So we have to get ourselves immersed in creating evidence for public policy so that leadership gets created and we do real work on the ground. Now, the last dimension of this, my contribution is, which is now thought of. The largest sector of occupation in the world is not realized as occupation. This is a paradox. We've been studying occupational health at global level. The largest section of occupation in the world is never discussed or researched. What is the largest number of occupation is there in the world? Number 1. Homemakers. See, one voice, but others, the ladies, were not vocalizing it. Yeah. And the biggest challenge that they face is the indoor air pollution. And they are the largest sufferers. If a husband is smoking, she keeps on having passive smoking. All the effects of air pollution, she is the biggest sufferer because if you see, most of the kitchens are ill ventilated. If you see the AQI inside a kitchen is the worst in the house. So we do have to create evidence based on realities on the ground, do research, and then join the dots together. When we talk of planetary health, environmental health and human health and animal health have to go together. Center for Science and Environment can do advocacy, but ultimately we have to get these evidences on the ground through creation of a leadership based on a framework or an ecosystem which does real work. So that is the message I wanted to convey through this session.
Thank you so much, sir. Thank you. Actually, we would have loved to take questions from you, but all of you must be hungry also. And we will be going for lunch soon. I would request all of you to, just 1 second, please. I'm sure many of you have great ideas. Just mail it in to us, please. And yes, sir.
First of all, congratulations to all three of you. Sunita ji, I love your passion, and that is amazing. Two requests. With a new guideline published in USA, and as you know, we have a lot of issue. Whatever is bad from West comes here, and whatever is good here, it goes to West. So repackaging is the greatest asset. What my request is, biggest issue for all cardiovascular disease and NCD is processed food. And what you talk about microbiome, enteric gut axis. How do we stop our young people from consuming what is not good, and what you talk about healthy food, which is most expensive versus unhealthy food? So that is where how we are getting Coca-Cola and all this, food packaging, which is at nominal price, but that is one which is increasing high prevalence of diabetes, obesity, and mental health disorders. So I think you being such a passionate, not only for India, it's for entire world. Thank you.
So can I just answer this? In fact, thank you so much for asking this. One of my biggest areas of passion and work. In fact, I was a member of Rajiv Ji's an advisory group set up by FSSAI to come up with regulations on this. And it was a three-pronged issue. One was, what can we actually ban? And particularly in schools. And that was very clear, and a lot of work has happened. The second was we wanted very clear front of the pack regulations so that consumers are informed. And that's where the very simple salt, sugar, fat, HFSS, I hate that word because I prefer to call it junk food and keep it straightforward. But I think that's a work that I know that now FSSAI will take up and get done. And it's very, very important because the obesity challenge for us is massive. And the third part of it is really about making sure that we can promote good food, because that's also part of where we need to talk about and change the culture of food. I talked about makhana, and in fact, we have to all take some credit for making sure that we talked about makhana, and we talked about how we need to link good food, which is available in our country, and the whole question about home-cooked food being better than any food that you will get. And that's the advantage of India. We are still not eating bad. We can continue to eat good. But for that, we do need some regulations, and tough regulations, because the processed food industry, you have seen that now in the US, and the kind of absolute deviance that has come out in the new food pyramid. The processed food industry, I have often argued, is more powerful than even the tobacco industry. And Srinath may not agree with me on that, but I would argue that we need to put health back in the hands of people. For that, information in the hands of people is critical.
Thank you so much, ma'am. Would have loved to take questions from you. I would request you to just email it in. There's a section after this also. My brilliant panelists, thank you very much. All of you were very passionate about what are you dealing with. And thank you very much for patiently listening to us.
Thank you, Dharmadhiran sir, for moderating it so well. And I also thank all our speakers, and I want them to please come forward for a group photo. Sorry for all the audience to keep you waiting for lunch. It is officially the lunch time, so we will now break for lunch until 2:15. Please join us for networking lunch outside the auditorium, and we request you to be back in your seats on time, as every minute of this summit is shaping public health in real time. So please don't miss out and be here sharp at 2:15, everyone. Thank you.
Sorry, I had to curtail you. Sorry, I had to curtail you, sir. I got messages and messages. I'm glad you did. I'm very passionate.
What daily habit separates the top? What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users, disease-specific communities, and a unified discussion feed. Access to authentic resources, welfare schemes, and multilingual/voice-enabled support. Patient-reported outcomes, PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes. Ability to post anonymously, edit or hide posts, block users, and connect with healthcare professionals vetted for credibility. Fast forward to April 2024, IPU held its annual conference focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to Niti Aayog and the Prime Minister's Office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first-time IPU Fellowship, designed to transform patient experiences into actionable policy recommendations, published by IIM Raipur and submitted to Niti Aayog. At the 2025 conference held at the India International Center, New Delhi IPU unveiled enhanced versions of the app, the Fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and systemic reforms.
Which doctor to go to? You may need a specialist. In today's fast-paced world, healthcare can feel confusing, overwhelming, even out of reach. For bridging the gap between patients and healthcare systems, here's the Patients Union app, your one-stop solution to make healthcare more transparent, accessible, affordable, accountable, and outcome-driven. Here are the main features of the app. D are easy. A chatbot for health guidance. List of disease conditions. List of medicine. Specialty advisor based on your symptoms. It guides you to a specialist. Authentic resources. Patient-reported outcomes by rating your hospital, healthcare providers, and health services. Events such as Dr. Hour to connect you with a specialist. List of government schemes. Drug-drug interaction. Lab report summary. Multilingual support with Bashini. For now, no more confusion. Just the right care when you need it most. Download the Patients Union app, helping you find the solutions.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users, disease-specific communities, and a unified discussion feed. Access to authentic resources, welfare schemes, and multilingual/voice-enabled support. Patient-reported outcomes, PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes. Ability to post anonymously, edit or hide posts, block users, and connect with healthcare professionals vetted for credibility. Fast forward to April 2024, IPU held its annual conference focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to Niti Aayog and the Prime Minister's Office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first-time IPU Fellowship, designed to transform patient experiences into actionable policy recommendations, published by IIM Raipur and submitted to Niti Aayog. At the 2025 conference held at the India International Center, New Delhi IPU unveiled enhanced versions of the app, the Fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and systemic reforms.
Which doctor to go to? You may need a specialist. In today's fast-paced world, healthcare can feel confusing, overwhelming, even out of reach. For bridging the gap between patients and healthcare systems, here's the Patients Union app, your one-stop solution to make healthcare more transparent, accessible, affordable, accountable, and outcome-driven. Here are the main features of the app. D are easy. A chatbot for health guidance. List of disease conditions. List of medicine. Specialty advisor based on your symptoms. It guides you to a specialist. Authentic resources. Patient-reported outcomes by rating your hospital, healthcare providers, and health services. Events such as Dr. Hour to connect you with a specialist. List of government schemes. Drug-drug interaction. Lab report summary. Multilingual support with Bashini. For now, no more confusion. Just the right care when you need it most. Download the Patients Union app, helping you find the solutions.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Welcome to the journey of the International Patients Union, the only patient-led movement in India striving to transform healthcare from the patient's perspective. In April 2023, IPU officially launched at the inaugural Patients Conference. This pivotal event marked the unveiling of the Patients Union app, designed to connect patients, caregivers, top doctors, policymakers, and industry leaders in a shared digital space. The app offers a robust set of features to empower users, disease-specific communities, and a unified discussion feed. Access to authentic resources, welfare schemes, and multilingual/voice-enabled support. Patient-reported outcomes, PROs, a first-of-its-kind feature in India, enabling users to rate doctors, hospitals, and government schemes. Ability to post anonymously, edit or hide posts, block users, and connect with healthcare professionals vetted for credibility. Fast forward to April 2024, IPU held its annual conference focused on leveraging technology to enhance patient engagement and treatment outcomes. A detailed report from this conference was submitted to Niti Aayog and the Prime Minister's office, highlighting patient-driven policy insights. In 2025, IPU launched the world's first time IPU Fellowship, designed to transform patient experiences into actionable policy recommendations, published by IIM Raipur and submitted to NITI Aayog. At the 2025 conference held at the India International Center, New Delhi IPU unveiled enhanced versions of the app, the Fellowship, and the One Health Report, reaffirming its commitment to patient empowerment and systemic reforms.
Which doctor to go to? You may need a specialist. In today's fast-paced world, healthcare can feel confusing, overwhelming, even out of reach. For bridging the gap between patients and healthcare systems, here's the Patients Union app, your one-stop solution to make healthcare more transparent, accessible, affordable, accountable, and outcome-driven. Here are the main features of the app. D are easy. A chatbot for health guidance. List of disease conditions. List of medicine. Specialty advisor based on your symptoms. It guides you to a specialist. Authentic resources. Patient-reported outcomes by rating your hospital, healthcare providers, and health services. Events such as Dr. Hour to connect you with a specialist. List of government schemes. Drug-drug interaction. Lab report summary. Multilingual support with Bashini. For now, no more confusion. Just the right care when you need it most. Download the Patients Union app, helping you find the solutions.
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focus minutes a day differently. The top 1% in healthcare already use those minutes with the Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning, 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first global think tank, curated for healthcare professionals and leaders, ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day, while others scroll aimlessly. You move ahead. You don't need more hours. You need smarter minutes. Learn smarter, grow faster, lead first. Curated by global leaders. For those ready to shape the future of healthcare, the top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
What daily habit separates the top 1% in healthcare from everyone else? It's not luck. It's not the hours spent scrolling on social media. It's not the full-time degree. It's how they use just 5 focused minutes a day differently. The top 1% in healthcare already use those minutes with Health Parliament. Are you? Research proves it. 70% higher retention with daily micro-learning. 10x better odds of career growth. That's less than 1% of your time, but it can change 100% of your future. The world's only mobile-first, global think tank curated for healthcare professionals and leaders ready to shape the future. Daily insights, global updates, leadership lessons, policy reports, all in under 5 minutes a day. While others scroll aimlessly, you move ahead. You don't need more hours, you need smarter minutes. Learn smarter, grow faster, lead first, curated by global leaders for those ready to shape the future of healthcare. The top 1% in healthcare aren't waiting. They're already on Health Parliament. Are you?
Hi everyone, I request you all to please be seated. We are about to begin the session.
Check. 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 Check.
So, welcome back everyone. Hope you had your lunch. Next up is the session Public Health Transitioning to Digital Public Health. We're living in a digital age, and in India, digital health is already reshaping how care is delivered, from teleconsultations to electronic health records. The ABHA ID ecosystem under the National Digital Health Mission has already registered hundreds of millions of IDs, and hundreds of millions of consultations are being conducted, which signal a deep behavioral shift. If major parts of our health system, data and interactions are already digital, the question is, what does it mean to move from public health to digital public health? For this discussion, I would like to invite Dr. Rajendra Pratap Gupta, Founder and Chairman, Health Parliament, Dr. Krishnan Ganapathy, Past President, Telemedicine Society of India, Emeritus Professor, National Academy of Medical Sciences, Dr. Indu Bhushan, Founding CEO, National Health Authority, former Director General of the Asian Development Bank, and Mr. Gopi Gopalakrishnan, Founder and President, World Health Partners. I request our distinguished speakers to kindly join us on the stage as we explore this transition. And a quick reminder to engage with the live Mentimeter questions for all the sessions. The QR code is there at the back of your delegate passes and also being depicted here on the presentations as we move forward. So, I now call upon Dr. Rajendra Pratap Gupta, the moderator for this session, to take this session forward. Over to you, sir.
Thank you, Sabya. And I know that afternoon session has to be really compelling with one of the greatest leaders to keep everyone awake. And IIC lunch is not that great, I know, so I know that you would still be figuring out what's going on in the stomach. But trust me, it's safe fun given people who eat here. So having said that, let me also tell you that how this session got ideated, and also, you know, a lot of programs, all the people you see sitting here are the people, wherever they have been, whatever positions they have been the people in the trenches. When I say that, I mean they were the ones who did work on ground to change and then translated that at the national level, international level, when they got into that seat to do that. I still remember 2011, I was hosting Jayant Bantia and Vikas Khadge. Along with a host of global leaders, Dr. Ganapathy was also there, along with Anish Chopra, the CTO of United States and Barack Obama's assistant, along with other leaders. So after Jayant Bantia heard that session, he called me out. I said, I am Secretary Public Health Government of Maharashtra. You come and meet me. So I went and met him. He said, Rajan, my biggest problem is we have severely malnourished children in Malegaon area and others. By the time the report comes to me, they are dead. When it comes in the newspaper, my CM calls me and said, "Ye kya dikh rahe hain? Kya kar rahe hain aap?" So he said, "Suggest me a solution which is technology based, so I can get my things on time." By the time Asha Anganwadi workers put to district put to state headquarters comes to me, we are done. So that's where, you know, this idea of digital public health struck, that you need to look at moving public health. And now from 2011 to now, we have evidence in support of that. You know, whenever you do something, look at the panel that is sitting here. We all sit here with the work that is done in this domain. I'll just give you some numbers before I ask them question. UPI's daily transactions are 700 billion. So in as much people can question electricity, digital illiteracy, let me give you the numbers that tell you ABHA ID is 850 million, eSanjeevani 442 million consultations, 1.2 billion mobile connections, 138 crore Aadhaar IDs, DigiLocker 737 crore users, 776 crore records on that. And people have moved from physical to virtual world. Public health also has to move there. those old age times of billboards are not enough. Today you can actually check what people are checking in a particular area on social media or on Google. You can find out there's going to be an outbreak because people are checking those symptoms. That's the level of maturity we have in the state of public health to move digital public health. And today I have a panel with me, and I can briefly introduce, though you know them. Gopi Gopalakrishnan is I would say the person who set up World Health Partners, did the early groundwork. We call it heavy lifting, dirty work, very early on. Some people would have told him, you are ahead of time, why are you doing this? But these are the people who shaped the way country has moved. Dr. Indu Bhushan, the man who was picked, one person in 1.4 billion who was asked to be the founding CEO of NHA, not an easy job to do, and what he did, I think the country is proud. We have Dr. Ganpati. I think when you hear him, I will not need to give an introduction, but he is very humble. He's a neurosurgeon, but he is more known for telemedicine than neurosurgery. But he has mastery in both. So now my challenge is whom to start with. So maybe a presentation from you, Dr. Ganpati, for 10 minutes would be good to wake people up, because they will see some good slides and a lot of humor from you.
Can I have the first slide, please? Thank you, Dr. Rajendra. 600 seconds to talk about digital public health would bring a disservice to that particular topic. And I'm looking forward to Rajendra Gupta giving at least one day for digital public health. Now, immediately after lunch, it's what I'm going to do is to give you a starter, an appetizer, so it works, to make you think that if you do not know more and more about digital public health, you are doing a disservice to the entire concept of One Health. Now, India is a leader in global digital public health, particularly in the LMICs. India stands out not just in numbers, and I'm delighted to have the founder CEO of NHA here. And you can see here, we are using open interoperable DPIs as a health railway. ADBM, we have already known about it. My talk has become much more easier because because the CEO of NHA this morning has gone through all the numbers. So I'm going to go through these slides quickly. Just give you a background. Now, India's healthcare landscape is translating through government initiatives, policy reforms. When I was in active neurosurgical practice for almost 4 decades, I never realized the importance of policy. I think the people on this dais here are playing as much a part in healthcare as some of us who spent our lives in cutting and stitching. Now, private sector innovation, vast, diverse population like India offers an unparalleled testing ground for cost-effective, adaptable solutions. The World Economic Forum in its last conference recognized the role of digital public health. I'm told a healthcare transformation initiative actually has been started by this. Now, what are the facts? We have all gone through these facts, these numbers. E-Sanjeevani as a guesstimate, unfortunately I have no statistically valid numbers. I would guess that 200,000 teleconsults are taking place every single day, in addition to the almost 400,000 teleconsults through the E-Sanjeevani platform. These numbers you're already familiar with. But this is all from published literature, what I have taken. The queue time, I understand, in public hospitals from some of the published papers have reduced from 35 minutes to an unbelievable 5 to 10 minutes in 75% of cases. Claim processing, including government insurance companies, including government-run state insurance, is 85 to 90% faster from 30 days, which is the gold standard then, to an unbelievable 4 days. And as you can guess, all this could only be digital, digital, digital. Now, the most important part, and I think Dr. Vinod Paul also stressed this, was the fact that Ayushman Bharat, everything came after we had put DPI already into place. Without an Aadhaar ID, without UPI statements, without secure document storage and so on and so forth, it would have been impossible to get the large numbers we are doing today. For this, change management is equally important. I'm rushing through this because I'm going to give you some practical examples that what I'm talking is not theory, but what really has happened in the real world. Now, what are the challenges we have? Large, rural, older populations.
This morning, one of the speakers said that a senior citizen being digitally literate is an oxymoron. Now, I am a senior citizen. I may not be as digitally literate as many of you here, but I do understand the challenges which a 75-year-old, 80-year-old, 85-year-old has in operating the digital components of digital health. So this is something. Again, interoperability. This is something fantastic. The Ayushman Bharat has so arranged everything that private hospitals, individuals, everybody can store whatever they want on the cloud, and they will have access, others will have access to it. It doesn't matter today whether you, tomorrow may not be today, but certainly by day after tomorrow, it wouldn't matter whether in my children's time, I'm sure it wouldn't matter whether All India Institute of Medical Sciences, a medical record, or Apollo, or any other private hospital. So this is what is going to be important. Now, what are the challenges which we face? Building digital health systems on top of robust national DPI, attention to change management. Now, the most important thing is you need the design to be formed to achieve equity. We have thousands of PhDs, but then we have millions of people who have never been to college. And this is where the challenge is. The whole thing should be addressed not to the digitally literate, but to the digitally illiterate people. Collaborating with private sector and tech companies to co-develop, I think this is a very, very important word, co-develop, maintain and scale digital solutions. As I mentioned, the design should be not for the digitally literate. And one thing which I would really like to emphasize, which I think people sitting in this audience can do, most of us, including the much younger doctors, even the 30-year-olds, the 35-year-olds, I belong to the BC era. I was trained in the 20th century, but to my horror, doctors are now saying they're pre-AI or post-AI. That is the world we are now living in. Therefore, unlearning and relearning, in my opinion, is much more important than learning. Most of us are, let's say, about 35 years old, we have to unlearn and relearn. And I hope the policy makers will pay importance to this as well. Now, these are all self-explanatory. You can go through it. Again, I was so happy this morning. See, when I joined medical college 57 years ago, it was not health care. It was disease care. 6.5 years of my life, which I now think was a damn waste, I spent in diagnosing, treating, diagnosing, treating, diagnosing, treating. If you could not get admission to any other postgraduate course, as a last resort, you would do MD, Social and Preventive Medicine, SPM it was called. Today, if I were to be reborn with all the technology facilities available, as a neurosurgeon, okay, maybe 15,000 patients I operated over 5 decades. Many of them died because they had very bad brain tumors at that point of time. Today, if I had the opportunity with all the technology, if I do MD preventive medicine, I could probably play a significant part in saving not 10,000, 20,000, 30,000, but several million people. Technology enabled remote healthcare. I dream of the day in my life when MD SPM is treated with much more respect than a pediatric cardiac surgeon. The brightest of the bright in my days would go to neurosurgery, not because I'm there, or cardiac surgery, but purely because that was what was considered. So I think the world has changed completely. Now, when I was preparing for this talk, I was very pleasantly surprised. I came across 27 publications in PubMed index journals with an impact index of more than 2.5 on artificial intelligence and public health. All I did was to do a search, artificial intelligence and public health in India. Sorry, I added the word public health in India. To my horror, almost, I saw so many. I've just taken a few of them here. Look at this. Artificial intelligence in public health policy, the next revolution. All these articles are published in peer-reviewed index journals. And Government of India's initiatives, AIIMS Delhi, PGMI Chandigarh, AIIMS Rishikesh. I was in AIIMS Jammu 2 months ago. AIIMS Jammu has just started AI Center for Center of Excellence in AI, and I understand that public health is going to be one of the major components. You can see clinical decision support systems. 4 days ago or 5 days ago in LinkedIn, I saw the announcement announcement of the first government AI hospital. I had to pinch myself several times to see whether I read it properly or not. Narayana Hridalia, Narayana Health, and several other hospitals have announced the opening of AI clinical departments. I am not talking of the use of AI, but then I am worried, I am concerned, because to me, as an old-fashioned physician, I think I would like to call it AIENI. I would like to project myself as an AI-enabled or AI-literate, semi-literate, native intelligence user. AI-enabled natural intelligence is going to be far superior than to a doctor who is dependent only on AI. Ladies and gentlemen, AI in public health is used as an enabler, a means to achieve an end and not an end by itself. Technology is not the solution. Technology is a means to achieve the solution. Please don't create the solution first and then go in search of problems. This is what is happening in the real world. Again, I was delighted 2 weeks ago from the office of the Principal Scientific Advisor, a lovely document, 14 pages document, democratizing access to AI infrastructure. See, as I told you, I belong to the 20th century. I can't even think of democratizing AI. To me, AI was meant for the elite, of the elite, of the elite of society, but here is how to democratize it. And okay, now this is something which is a little out of public health, but I think as scientists, as literate people, we need to understand this. I'm just quoting what Eric Topol, most of you have heard about him, and this is what Eric Topol says. The fundamental flaw in treating the population and not the person. This morning, I think Dr. Vinod Pal mentioned it. I remember now he was talking of breast cancer, 90% sensitivity. It is not 90% sensitivity. It is 10% insensitivity, if I may call it that way, to use a very crude word. Now just look at this. PSA, prostatic specific antigen. You may not be able to read the numbers. 250,000 people in the United States had a false positive of PSA increase most of them went through a biopsy. Please remember, for the widow, it is 100%. This medicine is one area, surgery medicine is one area where we require 100% precision, not 99.9% precision. So you can see here, this one-size-fits-all blockbuster drug model is obsolete. We are talking of the rise of Homo digitus. And I am very confident that perhaps in my lifetime, there will be enough genomic laboratories available as a part of the public health system. Dr. Rajendra Gupta and all the people here, I may not be alive to see it, but you people can ensure that your children and grandchildren have personalized genomic studies. What cost $10,000 today is available in Delhi, Madras, Hyderabad. There are at least 25 centers in India where for 20,000 rupees you can do 99.5% of genomic studies done anywhere in the world at 5% of the cost. The Indian genome is totally different from the Western genome, and therefore public health, if you are far-sighted, if you're thinking of the future, if you're thinking of 10 years from now, please understand personalized medicine will also be a part of public health. I know it looks like an oxymoron, but personalized medicine should be a part of public health. Now I'm going to tell you the real world. You cannot learn swimming through a postal course. You have to get into the water. You have to dirty your hands. I can talk for 10 hours on digital public health, but that's not going to have any effect. So let's see, what did we do? I am only using a disclaimer. This is not a sales pitch. I am only using this because I was actively associated with public-private partnerships in the Apollo about 12 years ago. I formally stepped down last year. But since I have access to this, I'm showing this. I'm sure there are many, many organizations which have done a similar thing. This is the presence public health. And again, Dr. Vinod Paul mentioned this morning, I'm again giving Apollo as an example. Even as recently as 10 years ago, Apollo Hospital or any of the big corporate hospitals, whatever you name it, we were looking at quaternary care, not even tertiary care. Today, every one of them have realized from a purely selfish point of view, The board of directors of the company have understood that a greater dividend can be declared by a corporate hospital in keeping patients outside the hospital. In other words, keeping them healthy, and healthy means wealthy, keeping them healthy, wealthy, etc. is actually a money spinner, and therefore preventive health checkups are more common. So this is just an example to show. When I left the organization, we were doing 20,000 teleconsultations every single working day. And most thrilling for a person like me, 95% of this was not the affluent elite of the city, of the country, but these are all public-private partnerships. Uttar Pradesh, Jharkhand, Uttarakhand, we were even doing in Lakshadweep and so on and so forth. So this is the power. Primary healthcare, ladies and gentlemen, will very soon, already it has started, corporate for-profit hospitals are going to get involved in primary hospital. Mobile medical units, I don't know the exact numbers. I think we have, Apollo Hospitals has about 85 mobile medical units, and you can see these speak for themselves. This is literally a mobile medical unit. We can do most of the diagnostics, etc. Rajendra Gupta is looking at it. Just one more slide. Yeah, mobile TB screening. This is again something fantastic. 3.5 kilograms backpack, where you have an X-ray machine. We no longer use Fuji. We use a Pune-based World Health Organization approved totally portable X-ray. I'm not talking of mobile X-ray. I'm talking of portable X-ray. And we use the PCR machines which were used for COVID-19. We use it now to test the acid-fast bacillus. Again, teleophthalmology, everything is in millions. It's not a typographical error. When I say 2.7 MN, it genuinely is 2.7 million spectacles have been dispensed. So what is my message? If Moses were to come down to earth again, every one of the 10 commandments would be preceded by a statement, thou shalt digitally transform. Without that, gone, you cannot do. That's what Moses would do if he comes back. Now, we were talking of near universal DPH coverage. Improbable, yes. Impossible, no. AI enabled, can I just finish that please? Another 5 seconds if you don't mind. Somebody has switched off, I'm very happy. You are so, wow. Thank you, sir, for pointing out the time. Like you, I'm obsessed with punctuality, I agree. But senior citizen discount. Just 15 seconds, please. Last slide, if you don't mind. Thank you. Okay, so this, now again, I'm delighted that the National Board of Examinations, I was probably the 10th or 15th person to register, probably one of the youngest people to register. You can see here, they are starting an AI, a 6-month online course. This is the way the government should go. A 6-month online course for the first 50,000 MBBS registered medical practitioners, 6 months online course with a fantastic faculty from Microsoft, Google, AIMS, India, etc., etc. And 6 months from now, if everything goes well, we'll have 50,000 of us who know actually what AI is. And I very strongly suggest that this experiment be repeated for all healthcare providers. The ASHA is no different from me at this point of time so far as AI is concerned. We are almost at the same level. So I think we should do that. Healthcare is independent of where one lives. When I was a medical student, I was told that geography determines what is going to happen. Geography today has become history. Distance has become meaningless, and today it depends entirely on how well you are digitally connected, not on your physical location. So I could go on and on, but I see he's getting restless. Thank you, sir, for inviting me.
Thank you so much, Dr. Ganpati. I think people are so excited to hear you. And yes, he's done amazing work. I also would be teaching at this course that he referred to, nevertheless. So I want to give you just a 30-second example of how old this technology is. 2007 and 8, Kenya was not able to figure out where is this malaria hitting, like we talked about cholera in 1853. So there was, Harvard stepped in for this study. They looked at 11,920 mobile phone towers. They tracked the SMS calls of all the 14.8 million residents of Kenya. And they figured out malaria was happening near Lake Victoria. data science, AI and all is pretty old. This is exactly 2 decades old. If even the technology that we know in India, we have been doing teleconsultations, he's been doing. In Kaiser Permanently, I looked at the data, 2012, their virtual consultations exceeded the face-to-face consultations. It is only that we don't know. These forums are for you to update yourself on the facts. And we have very good leaders. So I'm now moving to Dr. Indu Bhushan. Dr. Indu Bhushan, you had the rare opportunity to get a blank slate and a challenging one to paint India's digital story. You did that successfully. We are very proud of what has been accomplished or what you started as the founding CEO. Given your experience, how do you see the domain of public health getting digital public health?
So thank you, Dr. Gupta. Thank you for inviting me. And as I see it, Dr. Ganeshan has covered Ganapati.
What's in the name? Rose by
Ganesh,
rose.
Ganesh and Ganapati Paryarvachi, na? So Dr. Ganapati has actually covered most of it. So if I'm smart, I would suggest say that thank you very much for inviting me. I'll wait for the questions. But since I'm here, and I'll do the stupidity of saying a few words and a couple of things that I want to say. One is that public health, why digital health? Like people say that digital health is the answer. But some people or not many people ask, what is the question? What is the problem that digital health is going to solve and why digital health is needed for public health? There are several reasons, but one reason is that public health requires solution at scale, and our normal brick and mortar solutions don't lend themselves to work at scale. And for example, if you take COVID, if we had to vaccinate 1.4 billion people, without COVID, probably it was not possible. Similarly, you mentioned about Ayushman Bharat. If we didn't have a IT platform, which was end-to-end from identification of patient to payment to the hospital, it was not feasible. So anything that needs to be done at scale, at large population, I think digital is unavoidable, it's critical, and that's where digital health will come in public health. But the second thing is that the traditional methods are backward looking. By the time we have information, it becomes history. Whereas in digital health, you get information almost as it happens on live basis, and which can actually provide you much better tools for taking decisions and addressing the public health related policy issues. So this being online actually is very helpful. But most important thing is that digital health is able to address this issue of access, equity, and continuity of care, because it can link many applications, it can link many systems, and it can ensure interoperability, as you were mentioning. So that is helpful. And finally, digital health also helps in terms of keeping the records intact, and they can't be changed. So you can also, it's an auditing of what has happened is easier with the digital health. So because of all these reasons, probably digital health is going to revolutionize the way we worked. And I fully agree with you that now we have to train doctors not only in bedside care, but also website care. So I think we should, we have, that's a future to go. But at the same time, I think it will be remiss of me not to mention that digital health has to work for everyone. And we know that there is a digital divide. The large number of population which are not online or not even linked to a cell phone, let alone smartphone. So solutions that we make in digital health have to ensure that they also cover those who are on the other side of digital divide. And finally, there is the issue of privacy and security of data. When you have records on registers spread around all over the country, it's extremely difficult to steal them or leak them, because probably you leak one register with 50 people. their information. But with digital, you can have access to the entire country in large populations. So keeping that record confidential, secure, and private is actually a challenge that probably we should not overlook. And I'll then look forward to questions as you mentioned, Dr. Gupta. Thank you.
Thank you, Dr. Indubhushan. I think you brought some very important point. I think the fundamental thing that you started with is the crux, that why we need to move digital. You talked about scale. You cannot do scale without digital. And I think the second thing, you also talked about the scope. If we have to keep enhancing the scope of what public health can do, you cannot do without digital. The issue of addressing multiple challenges of access, affordability. I think you have laid the fundamentals of why we need to move public health to digital public health. And coming to Gopi, and I have known him, and you ended with a very important point of digital divide. And this is exactly the area where Gopi I have known to have worked with, and I have visited his centers and the phenomenal work you did. So Gopi, how does digital public health bridge the divide based on the work that you've done?
Thank you, Dr. Gupta, Dr. Ganapathy, Dr. Bhushan. It's an honor and a privilege to be part of these discussions. Yes, this is a Goldilocks period, as I say it, and in fact the Goldilocks period is when you have connectivity and you have access to power, you can get the digital system to work very well. But we all have to break it down further, because as the economist Joan Robinson said many 50 years ago, 50 or years more, then India is one place where something and its opposite existing together is true. We have for the well-off, or people who have insurance, or people who are covered by things like DGHS, you have access to some of the best quality of care in the world. We can get excellent attention, excellent care. But on the other side, we also have a chunk of population which is in fact overwhelming in its size, that is getting left out and that is not having anything. And people, when they talk about this section, the only plea that this section makes is get us primary health, because that's a starting point for you. So Goldilocks is wonderful, but we'll have to look at how do we then adjust our system to the rest of the country, because this is not just in healthcare, it is true of any, but let me confine it to healthcare only. But let me frame it in 2-3 ways so that we can, because my experience has been in program management. So it's not policy, or it's not going to be larger abstract things. It's more about the day-to-day operational challenges that we face and how do you address them. The framing is, one starting point with digital health is that it'll have to work, for it to work efficiently, it'll have to work within a closed system. The reason why UPI works very well is because everything is closed. You don't have an intermediary coming in. When you make a payment, there is no intermediary coming and clearing the payment. It's automatic. The India stack is created in such a way, brilliantly created in such a way, which is the envy of the world, but it's a closed system. Same thing is happening with, say, railway reservations. So 90% of the reservations are now online. It works wonderfully because there's no intermediation there. Because digital not only digitizes the data and helps it go to all levels, it also disintermediates, in the sense a health secretary is sitting at the state capital or a CMO sitting at the district hospital can get the data at the same time, as Dr. Bhushan pointed out. It also disaggregates, in the sense the health secretary may get the data for the whole state, whereas the CMO get it just for the district. Okay, this is the difference between monitoring and evaluation. Monitoring is for individual players whose work has to be monitored, whereas evaluation is collective. Normally it's on a sample size, but with digital it can even be 100% sample size. Okay, so these are the advantages of the digital world. So let me frame it, because in programming it stands on 4 pillars. And you will have to address all the 4 pillars for it to work. And to make it easier, let me give an example from traffic so that we can relate to it easily. The 4 pillars are: 1, we'll have to have the norms and the rules established. So when it comes to traffic, we know that, you should drive on the left-hand side, you should not run a red light, you should not come from the opposite side. All those are rules established. Those should be communicated well. That is pillar 2. And it's not like the Delhi police, there is some murmur coming when you're waiting at a red light and someone is murmuring something and you find that the constable standing there saying something into a microphone. That's not communication. Proper communication and empowering a user to know the do's and the don'ts. The third, which probably is the most critical and which needs to be addressed in India very, very aggressively. If you remember when the Chandrayaan-2 failed and Chandrayaan-3 became successful, there was an interview with the head of ISRO. He was asked, why did this happen? Why did that first one fail and why did the second one succeed? He said the first one failed because we were focused on the success. The second one failed because we were focused on avoiding the failure. It sounds so pedantic, but it is in fact the most crucial fact of programming. If you start programming, if you're managing your traffic and you're paying as much attention to people who are conforming to the rules as much to the people who are deviating from the norms, then you're in trouble because you can't make. You will have to have metrics available which will tell you who is deviating. If you go to places like China and Vietnam, and you probably will know because you are based in Manila for a long time, out of every government office, whichever provides service, there will be a panel which is hidden from the guy who is providing the care. You will have to hit the button on the basis of how good the quality was. And that is tracked and that is corrected. Draw a parallel with the primary health center in India. You will find in one corner there is one tin box which has complaint written on it because they have to fulfill the criteria of what a PHC should be. That is either rusted and with cobwebs and no one has either opened it, or if there is a lock, no one can find the key. That probably is the most crucial input for correcting the system, because any system which is set up but it doesn't have a self-correcting mechanism is doomed to failure. That's exactly what is happening now. The fourth pillar is once you know there is deviation, then there will be penalty. We all like to give awards to people who are driving well, etc. That's immaterial. If it happens, it's okay. But what is more important is the ones who are deviating from the norm will have to be corrected. Whatever action has to be taken, because the government's role is enforcement. Enforcement is on the basis of rule of law and the power to enforce the law. It is in fact violence that is given. Organized violence, the power is given to the government so that you can take the people away and enforce it. So this is the system, and the last 2 points about metrics and the enforcement of those metrics is completely absent, not only in the healthcare piece, but everywhere, because you don't have a system. Because I'll give an example from our own program, which we established in a VIP district, and I'll tell you what about it. But before that, we'll come to the healthcare. Since morning, we have been hearing about, and rightly so, these are all established practices, established norms. We're talking about the continuum of care, etc. The basic principle of healthcare provision is what is called triaging. Okay, either the provider can provide the care, or the provider himself or herself will facilitate the care from the right level. In the sense, if there is an MBBS doctor who is providing the care, but if the doctor thinks I cannot do it, it is the doctor's responsibility to make sure it goes to the right level where the care can be provided, which may be a specialist, that specialist may be a cardiologist or an orthopedic surgeon, whatever it is. That is the system. The triaging system is the backbone of any healthcare service delivery system. We have what? We heard in the morning Dr. Paul saying there are 170,000, 1.7 lakh sub-centers, whatever it is called now, 1.7 lakh sub-centers, about 30,000 primary health centers, about 6,000 community health centers, etc. We have that on the basis of the competencies that are available. Okay. At the sub-center level, you have an auxiliary nurse, not a nurse, but an auxiliary nurse available who can provide preventive care as well as can use technology like a telemedicine system to connect with a panel of doctors who may be anywhere in the country for that matter, but can be at least any part of the state who can provide the care. And if the remote doctor is not able to handle this, the doctor can refer the patient to the PHC for anything which is haptic, especially haptic is anything that requires the touch and feel, and it moves on from there. This is an integral approach to a system, not piecemeal. We cannot start from tertiary and now we hear about a quaternary system. That is good for the private sector. The national health policy is in fact brilliant in many respects. It says, look, secondary and tertiary we cannot handle. Doctors don't want to join. 85% vacancy. What are you going to do? Focus on the primary health. But focusing on the primary health doesn't mean just let go. We need a healthcare stack, and health is now a state subject. So the only thing you can do is to recommend what you can do. Create a stack on the basis of what you said, because the structure is the same: sub-center, primary health center, community health center, and city, district hospital, etc. Establish it only on that basis and provide it so that it is controlled. And into it loop your pharmacy and your lab, etc. So that no pharmacist can issue medicine without a doctor's recommendation. Now you walk into any shop, short of morphine, you can get anything else in the country. And why wouldn't you have then resistance, antibiotic resistance, anything we talk about? You can get anything. And why blame the pharmacist? He is making a living out of it. It is the government's responsibility to create the law and enforce the law. That is completely failed, and now we are getting this holier than position saying, oh, this is completely out of hand. We tried to do this 8-9 years ago. We tried to do this. And the lobby, I guess, is too strong for it to happen. I'll end with our experience. Gorakhpur is a VIP district, as you know, in UP. So we had a project, a pilot project, where from primary health center to it will move up on the lines we spoke. The doctors were completely against it. The only thing they would allow us to do is when the patient, and they would come, it's supposed to come from 9 to 4. They would come at 11 o'clock, okay? They will stay for 1 hour, that also to get the patients, and almost all of them had a clinic right outside their PHC, where the patients would be referred there. No way we could register a patient. Register patient would be entered into a computer, they will print out, one slip will be there and that will be given, that's it. We had various tools, including things that can help in the clinical diagnosis. They will get the differential diagnosis, the medicines thereof, all the tests that can be, that will be relevant to this. These things don't matter. So at the end of it, if you don't correct it and if you don't enforce, and some union types would come say, "Humse nahi hoga." We will not do any of this digital thing. We will not use a digital system, because the moment during COVID, we covered the whole of Bihar. We were the only organization giving care to the whole of Bihar and whole of Andhra Pradesh. In Bihar, the doctor would connect for 10 minutes. And in fact, the Bihar government had to issue a letter saying if you don't connect and stay on something, you will be dismissed in service. That is the level, and that has to be enforced. Otherwise, whatever AI you're going to build on is going to be built on a pile of junk. That is the information you will be getting. You will get all the names, etc., but you will have no way. We should collect the information in a proper way and lay out AI on it so that the audit of it and various other mechanisms that will be built to achieve good quality of care can be available to some of the poorest communities in the country. Okay. Otherwise, everything else will be big talk. You will have to get your basics right. In India, the White Revolution happened because Sardar Vallabhbhai Patel got in and said it will happen. The Green Revolution happened because Mr. C. Subramaniam got in and said that will happen. I suggest you read the book his granddaughter has written. 6 months ago it was published. The bureaucracy was completely against it. It's C. Subramaniam in a conference, Dr. Swaminathan got up and said, I want to try it out, give me some 2 or 3 acres to try it out. Others were completely against it. Subramaniam said, no, you go ahead, and it changed from a begging bowl. We now export food. UPI happened because we got the technocrats and the minister drove it. India, things will not happen unless the political figure, someone like the stature of someone like Gadkari or Vaishnav, they get in and force it down, it will happen. Otherwise, I know Dr. Rajan Gupta has been banging his head against this for a long time. Nothing is going to move. Okay, you need the political support. Unless because there are too many vested interests, too many interests there. Unless those are broken, unless that the union that controls both at the A&M level, at the doctors level, we are talking about quality healthcare, which is a fundamental right promised by the Constitution. And why are we hesitant? I don't know. So finally, the Gorakhpur project, after some time in desperation, we just left it. And the only thing that happened was DM gave order to all the PHCs that every morning at 9 o'clock, you should take a photograph and WhatsApp it to me. Okay? So that continued for about 10 days, and even that has stopped, I'm told. Okay? So thank you so much.
I'm a perennial optimist, and I've always seen things changing, but that's the reality too. So we'll take at least 3 questions before we move to next. Yes. And please tell whom you're asking. Yeah.
Yeah, good afternoon. My name is Nyamat. I work for an AI platform that works in respiratory health, and we follow everything that all of you have actually said. But there's no uptake as yet. So people who are already there, the startup India, the TB Mukt Bharat campaign, none of this is actually really going forward, and technology like ours is able to help in mass screening, but we get a lot of resistance from ATRAS, then DPDP Act. There are so many layers. So by the time we reach that, gaadi chhoot gayi hai. And I've been in public health for 20 years. I moved into this space of AI because I feel where man can't reach, technology reaches. So what is your suggestion to people who are already doing this and following the rules, following the compliances, SAMD, we followed HEPA, everything. We don't have anything like, so now we're looking at FDA. Like what do people like us do who are already in this space, and we're just facing so many roadblocks with either the government or the doctors, the really senior doctors are like, we don't trust this, but we're there to screen. Screening helps in prevention. Not everybody needs to get an X-ray, not everybody needs to go through all that. So what do we do, people who already have been in this space and kind of marrying the whole AI social good sort of thing? What would any of you suggest? I'd like to take something back, anything.
Each one of us will have a different perspective. My personal philosophy has been if you want something very badly, you will get it. So it depends on persistence. It is very unlikely that the system is going to change to suit your ends. The more the difficulties, the more the fun it is in trying to overcome them.
I'll give you the example of pulse polio rather than putting you very specific. People were not taking just the drops. You're talking of other things. You know what they did? They stood at toll plazas. They knocked doors. We achieved polio eradication. So there, I think, Mission Indradhanush, we have seen. Look at the percentages we have reached. Rightly, as Dr. Ganpati said, you have to go to people. If you're expecting the utopian because you have a great technology, then what he was saying was right. We have a technology, we want to find a problem now to solve it. But there are ample of reasons and solutions available in this country where we have achieved 97, 98% utilization is because we reached out to people, doorstep, even other places where they go, and we succeeded. Yeah. 2 more questions. Yes.
Yeah. Good afternoon. My name is Matai. I am from NIU. I'm a South Sudanese. I came to India last year and I was shocked because what we heard from there, India is advancing, is going. But when I walked to a pharmacy, I bought antibiotic without a doctor's prescription. I was shocked because I thought India would have already a regulation. This drug should have been controlled already. I thought it was being controlled. Then why am I buying amoxicillin, which is broad antibiotic? And you don't expect to, and you will also be surprised to have resistance. A drug resistance, which is becoming a public health concern worldwide. Why are there no policies? I think been listening since I came here, it became very clear that it just it's a political thing. Why don't we just reform from up? I think that's the solution to me.
So I'll
So
at
why
least
we not?
tell you one thing about the regulation part. There is a regulation, you can't dispense an antibiotic without a prescription. We went to the stage of even saying every antibiotic has a red stripe that tells the patients to understand it's an antibiotic you should not take without a prescription. Day before yesterday, I had an experience that I was standing buying a medication at a pharmacy. Someone came and said, I have a sore throat. I said, okay, take azithromycin, you should be getting well. So I think we have to understand one thing called professional ethics. If you trump that for profits, no regulation works. So that's where I think we have to learn the professional standards of practice. And that is why I think we all need to go back to the basics to understand what is ethics. Do I need to take care of people's health or need to take care of my cash drawer to make money? You can always make money by doing that. I think that guy could have given a cough syrup or something better rather than an antibiotic. But look at the approach that guy. I think we need to teach them ethics along with professionalism. Thank you. That's what I would answer. One last question before we end up, because we have another session.
Not questions, I just want to amplify on that. It's a question of implementation of law. In Kerala, you can't do that. So they got cameras on the counter.
Cameras, there is no electricity, it doesn't work. So we can go on, but I agree that it's the issue of enforcement. Laws do exist. There are systems. You can't get a pharmacy license unless you have a pharmacist. You won't find a pharmacist. But again, I think it's the issue of internal ethics. I would speak what I have to. I'll not be diplomatic. None of the people sitting here would be like
Dr.
that.
Gupta, my take is that digital health actually can address this issue, because once we have this e-pharmacies and all the prescriptions are e-prescriptions and which are linked to the pharmacies, and there's a record of who has recommended and what has been dispensed. So digital health, by virtue of its nature, is also makes the system very more accountable, because everything is recorded. So hopefully in the times to come, because of as the digital health becomes deeper, we'll not have aberrations like that in our country.
Thank you.
Not AI doctor.
So we don't need that if we track.
There has to be a prescription,
Yeah, so
and that prescription will be.
Sir, we'll take that in the open mic for sure. We'll not skip any question. Yeah, Gopi, you have to conclude.
Just one point. One is that, to take your point, Africa is definitely much more organized. Here we don't have that system, because we have GST, which was introduced about 5-6 years ago, which tracks medicine right from the time it leaves the factory till the time it reaches the retail counter. The only loop that has to be completed is between the doctor and the pharmacy. And we have been lobbying for it, I don't know how many years now, and it doesn't work. Same thing is applicable to pathology. Yesterday's Times of India had a report. There are 5,000 pathologists in this country, and there are 100,000 pathology labs. I leave it to your imagination what is happening.
Thank you so much. And ending with that note, with this, Sabya, over to you.
Thank you, sir. Thank you, our esteemed speakers. I request you to kindly step forward for the group photograph. I guess we all had lunch, so we can keep clapping. All right, so our next session is one that will particularly resonate with the students and young professionals in this room, building a rewarding career in public health. For many, public health has meant earning a degree and hoping that somewhere along the way, impact will follow. But if we are producing more and more degrees without a clear intent to create real change on the ground, then what is the point? So, for this candid conversation, we are privileged to have with us Dr. R.K. Srivastava, former Chairman, Medical Council of India, former Director General of Health Services, Government of India. Along with him, we have Dr. Sivaranjani Santosh, Senior Pediatrician, First Aid and CPR Trainer, and a social activist. Their journeys will help us reimagine what a rewarding career in public health can look like in practice and how we can enable more young people to step into leadership roles. So I request our distinguished panelists to kindly join us on the stage, and I would like all of us to give them a warm round of applause. First up, we have Dr. Srivastava, who will enlighten us on how young professionals can build fulfilling careers in public health and on the new opportunities emerging in this field. Over to you, sir.
Thank you, ma'am. How much time we have got?
Sir, 5 to 7 minutes.
No, total time for this session.
30 minutes, sir.
Huh?
30 minutes.
30 minutes. So we divided 10 minutes, 10 minutes and 10 minutes to them. Fine. Thank you very much. So thank you first of all, not only to the organizers, but to the young aspiring professionals who may opt public health as a career in future. I see about 50% of the audience who are young and must be having some career in the mind. It is right that I had a long experience in the government, but today I am not going to talk about the government. I will talk about the aspiration of the young boys and girls, medical and non-medical, who are looking public health as a future career for themselves. India is a little bit peculiar, where historically public health was considered as a second-rated profession, even today. But India is changing very fast as well. From the time NHM came in 2005, public health management cadre came into existence. Government allowed opening large number of the school for public health. The number I don't remember, but I remember there are about 15 postgraduate, certificate, diploma training program in the various aspects of the public health. Divided by the supply side, there was a study conducted in Public Health Foundation in India. I think it was in 2016, which has given a projection up to 2026. The gap was huge. In every 15 sub-public health discipline, and the gap was maximum in the non-medical public health professionals. They were there in MPH courses, they were there in public health engineering, public health lab, health promotion, and so on and so forth. There are schools like NIHFW, NICD once upon a time had a public intelligence course. So there are a large number of schools. There are PHFIs, state regional branches which are running these type of courses. So if I want to give you one impression, there is a huge infrastructural capacity of the training presses which is available in the country, and that capacity is for you, and they are all available on the website. You can go to the internet, search it out, whatever course you like, and you will find a right place. The second thing is that when the courses are there, then are we getting enough applications from the candidate? There is a shortage of applicant for all these courses, although it is a fact that there are certain courses like say public health masters and public health bachelor courses which are oversaturated. There are certain courses like public health engineering where there is sometimes no taker. So there is a wide range of the gap, but it does not make that the courses are not relevant. And there are certain type of new courses which has come out, particularly in digital health, Health Parliament is running one course, certificate course as well. So all these courses you can search out and find out what courses suits you, where the gap of applicant is alarmingly high. The chances of your getting entry into such type of courses increases. Naturally, this is not going to satisfy you at the end of the day. What will satisfy you is rightfully completing the course, the capacity of the training place to give you the best type of training, and the capacity of market to absorb you. These things will matter for any young aspiring person who want to enter into the public health system. Now the most easy part is knowing about the ranking of the institution. So if you like to look at, every institute has got a ranking which is there on the website. It is national ranking as well as international ranking. The students coming out from them are giving their opinion of the course, and you as a young aspiring person will also have good number of connect with other students who are pursuing course over there. You can interact with them and you will find that at the end of the day, some courses are good for you which are having a good training place and which might have a good job market also. The difficult part is the job market. When we go to the job market, for medical graduate there is a fixed type of job market. But for non-medical, the job market varies. We want a monitoring and evaluation expert. We want a content writer for public health program. We want a public health engineer who can take care of our project which is working on street food supplier. So there's 1,000 type of variation which exist. So for them it is difficult to assess what is the job availability for them. You have to do little bit more exercise on the internet to find out what is the reality. Luckily, there is nothing hidden today. If you will work on that, you will be able to know that there is a real job market or there is an unreal job market. You are much more intelligent in internet use as compared to the person of my age or even the young age persons who are sitting in the audience, some professors and other persons. You will be able to find it out. Trust in yourself. Try to work hard, build a career. Two things I would like to assure you. There is a very good career for the non-medical. The career has got better growth chart as compared to the medical doctors. If you don't see the things happening today which are coming in the news daily, I will recall two examples. One is waterborne infection killing person in Madhya Pradesh. This is a public health problem. There are protocols available, there are tools available, there are stereotype strategic framework available which has been prepared, I remember at my time, by NCDC. It has been circulated, there are micro plan, there are macro plan, all these things are available. But there is a lack of persons, professionals who are available in the directorate or with the Ministry of Health are there, or they are silent, they don't have a voice. So there is a need over there which is being untapped. So for last 1 month what we are doing? We are doing only one thing. Today 2 more cases, 2 more nurses died on account of the waterborne infection, and the water was contaminated and the government is acting to correct it. Is it right or wrong? If you are there as a young aspiring public health expert and you have capacity to raise your voice, you can bring about correction. Second thing I will say about the syrup business. Those who are in the pharmacy, public health pharmacy system, they know that the syrup which has damaged so many children, caused mortality to them, is something which is a failure of the regulatory system and ultimately that need correction. Now such type of solution coming out from the public health expert is only possible when young dynamic boys and girls are there and they work there with passion and take public health as a career for their life, for their family, and more so for the lives of those who are banking upon the integrity and honesty in public health care. Thank you very much.
12 seconds to spare.
Thank you so much, sir. Now I invite Dr. Sivaranjani Santosh to share her personal journey, reflect on leadership in public health, and address whether a public health degree is essential. Over to you, ma'am.
10 minutes. Okay. I don't know this. Oh, okay. Can we remove it?
Yes.
Good afternoon. Is everybody awake after the postprandial sleep? Okay. Good afternoon, esteemed chairpersons and all the eminent public health experts and all the esteemed speakers and the delegates. It's an honor to be here among such eminent public health experts. There have been advisories to WHO, UNICEF, the government of India, and I'm literally a bacha here. I don't know. I have not been on many public platforms, and I'm not done anywhere close to what these stalwarts have done, but I did my little bit, and I think that little bit is going to save and did save at least lakhs of children from getting hospitalized or dying due to diarrhea and dehydration. I take pride in that fact, and I think that's why I'm here today. Thank you very much. Now, before talking about building a rewarding career in public health, let me narrate to you about how I felt when I read this order from FSSAI on October 14th saying that no Tetra Pak, no food or beverage can have ORS as standalone with a prefix or a suffix in the trademark or anywhere on the label. It should not have. When I read that order, I couldn't stop crying for more than 2 hours. That was relief, that was relief, like 8 years of battle through multiple channels and all alone and fearing nobody. And when I read that order, I mean, that reward is unimaginable. That reward is unimaginable. Today I met a doctor. She said she came all the way from Dehradun only to listen to me speak. She said she stopped allowing ORSL in her hospital. She now makes sure everybody gets only WHO recommended formula ORS. Okay, that's the reward I got. I have a career in what? Pediatrics. I'm not a public health expert. But the reward I got for working for public health has been humongous. The happiness, what do I say? I mean, I fall short of words. Now imagine if your career is in public health, how much more you can do. How much more you can do. I'm just a pediatrician. Okay, so I'm telling you, if you have the passion for it, if you have the right qualities for it, go for it. It's going to be an immensely rewarding journey for you. Really, public health is the thing we should focus on right now. Okay, so, I mean, if you have a career in public health, you will have the power to bring meaningful changes in public health through impactful public health work, you're going to for sure create a meaningful impact addressing the root causes of health disparities, and you're going to ensure equitable health care, and you're going to ensure you improve outcomes for the vulnerable population, the poor, the children, the women of India. But ensure you have the right qualifications, the right qualities, and most importantly, passion for it. That is the most important thing if you want to go for public health. You can have a degree in anything, bachelor's degree, but try to do a master's in public health. That will help you get into senior positions. Try to do a doctorate. That will help you become a policy maker. That will help you go to a level where you can do advanced research in public health. You will have opportunities in government, WHO, UNICEF, NGOs, corporate CSRs, ICMR, NIN. So, and your focus will be mostly on women and child health, environmental health, occupational health, epidemiology and research. Okay, so now I'll tell you one thing. I've trained more than 20,000 parents, teachers and students, older students, in CPR and first aid for choking and seizures alone, by myself. Okay, and I have raised a petition asking for you all to sign that every teacher, every staff member, and every student from 7th standard onwards in every school, in every nook and corner of India should be trained in first aid and CPR. Here I am having to raise petitions, I am having to submit petitions. But now see this. This is written by Mr. Indubhushanji. He was the speaker just before we were on stage. The founder CEO of, I'm just checking whether you are listening, founder CEO of Ayushman Bharat. He wrote this article, and this is me training people in first aid and CPR. This is a coincidence, so I thought I'll bring it and show it to you. So now, if Sivaranjani, one pediatrician from Hyderabad, says, okay, CPR is very important, will that have more weightage, or will what Mr. Indubhushanji says have more weightage? What he says will have more weightage. Okay, he is a public health expert. He is into public health. Okay, and definitely you're going to save more lives, you're going to impact more lives if you are a public health expert. So definitely a career in public health is going to be rewarding. I'll narrate to you one of my experiences. So there is this friend of mine who moved to Seattle some time back. Her husband collapsed and he wasn't breathing. She gave CPR immediately and saved his life. And she sent me a message, Sivaranjani, today my daughter has a father because of you. Okay, right. Now if Mr. Indubhushanji or any public health expert, make sure CPR is there in every school, CPR training. Just imagine if you are the policy maker, how many parents will bless you that their children have been saved from dying due to choking or drowning related deaths. Imagine how rewarding it is going to be. So please go for public health as a career and make it very rewarding for yourself. Look at this. Where is the PowerPoint? The pointer is there. I'll need those extra minutes. Okay, now look at this. This is ORS on the label. They have deceived for 2 decades, and so many people gave these liquids thinking they are ORS. Okay, we don't know how many children were hospitalized and how many children died. And I have raised a petition, one paracetamol One India. Even these liquids are being given as ORS. These should not be allowed in the pharmacies, hospitals and schools. So if you are a policy maker, please make sure that these liquids are not sold in the pharmacies. Okay, one paracetamol, one strength India. Srinath sir just told me that he has signed my petition because so many children die because of overdose of paracetamol. All this multiple drug formulation, everything is available over the counter, irrational formulations, and children die of arrhythmias, drowsiness, coma, so many things. So all this, if you are a public health expert, you will have the data, you will have all the inputs from the ground level, and you will be able to make policies which can prevent all these deaths, and that is the impact I want you all to have as public health experts. Maybe you won't reach a level where you are the policy maker, but even if you are not in that position, you will definitely impact hundreds to thousands of families. And if you work with passion, with integrity, with method, with ethics, you will achieve what you want to. We have good systems and good regulations in place, but sometimes systems forget the very basics for which they are built for. And there are many regulatory loopholes, and these loopholes will be exploited by people with vested interests. So you and only you can remind the systems of what they are built for. Persist, persevere with method, with integrity, you will be a winner. Thank you. Jai Hind.
Thank you, sir and ma'am. I request you to be here on stage, while I would also request Dr. Partho Saha, the Vice President for External Affairs, Medical Students Association of India, to please come up on stage and share his inputs.
Thank you so much. I hope I'm audible. Okay. So thank you, Dr. Srivastav and Dr. Santosh, for highlighting the importance of having a career in public health. But let me just highlight to you what is the perception that medical students have when it comes to in relation with public health. I am just a fresh medical graduate, so I think I can, print that out for you in a more comprehensive way. Dr. Ganapati just said when he did his MBBS, that time there was a perception that people didn't take up MD community medicine or PSM. That hasn't changed, sir. It's the same now. If you tell somebody that, oh, I think I'll take up community medicine, I will take up something related to public health, they'll be like, oh, you want to do something in community medicine? And that is something that they look down upon us. That is not something like, they're like, you're falling back because you're not getting the branch that you want, and you're not doing something clinical. So that is how the perception of public health and community medicine has been printed for medical graduates, for medical students in India. It is like a shortcoming rather than something which could, gradually help in saving millions of lives by making policies which are going to help the people. So how do we change this? How do we change this perception? So we at MSI, that is Medical Student Association of India, we are India's first and largest student-run medical student organization, where we have more than 25,000 members who are working with us. And through this, we do public health outreach programs, which can be on different topics. Maybe it's on menstrual hygiene. We go to schools where we talk to teenage, not only girls, but also boys about menstruation, menstrual hygiene. We go to ANC ward and PNC ward, and we talk about maternal mental health, which is something which is missing in our curriculum. Then we go to schools and talk to teenagers about the side effects of tobacco consumption. So these are few campaigns that we have been doing over the years. And through these campaigns, every year we reach nearly 70,000 to 80,000 general population. And this is the work that is being done by medical students. And through these campaigns, we want to make that excitement, make sure the medical students learn that everything in community medicine is not just sanitary work and water cleanliness, like it was mentioned by Srinath sir in the first session. So they need to understand that public health is policy making, health financing, health governance. So these are the things that should be made clear to the medical students. That's why we at MSI, we are trying our best to move forward to bring back, start a new kind of a thing where people are interested in taking public health as a career option. Because once we start taking those steps, we will start filling up the dream that Rajendra sir is having, that we don't have leaders who are of 35 or 45 here. So, but when we are at 25, if we are given the opportunity, then we are going to be the leaders in when we are 35 and 45. So that's why over here we have so many distinguished speakers with us. We would like you all to come join us in MSCI, collaborate with us, and make sure that spark is ignited in medical students to take up public health as a career where they can see themselves working to save lives, not only through medicine and surgeries, but also through policies and different ways where we can make a bigger impact as a medical fraternity. Thank you.
I'll be the first one to be there.
Thank you, ma'am.
Thank you, Dr. Partho. So we now invite a few questions and comments from the audience. This is your time to engage with the two speakers here. Kindly raise your hand and we'll hand you over the mic. Please keep your questions crisp and short so that we can take as many as possible before our chief guest arrives.
Namaskar. I'm Dr. Ganesh Joshi, alumni of AIMS in rehab medicine. This is, I think, the best session where we got all the three people. I have been fighting for PMR in MBBS since it has been in the regulations in 2021. So MBBS 2021 admission has PMR in MBBS as mandatory subject, but it is not being taught. So I have approached highest authorities, sir knows, and everybody is knowing. But now they are exam going in 2 months, they don't know the PMR, and in next year in internship, they have internship for 15 days in orthopedics and PMR. So since Ghosh is here, he is from medical students body, I would request that kindly take it up. Get introduced to PMR at least, get introduced to the healthcare for people with disabilities. Unless you know how to approach a deaf person, a blind person, unless you know how to take care of a mentally ill or intellectually disabled person, you won't be a complete doctor, because this is not the Bohr committee time. This is NHP 2017. So we have 5 categories at primary healthcare in the village. So you must know rehab, and without rehab, kindly don't enter internship. Thank you.
Thank you so much, sir. Any other discussion points or comments or questions?
My question is to Srivastavji, and first of all, congratulations to you for what you're doing as a primary practicing physician. And where is Ghosh, the young man? I want to address two of you. When I went to med school at Mumbai, my name is Dr. Kansapar. I used to practice in Pennsylvania, retired. Want to bring some important suggestion to you and your colleagues. Student leadership should be started when they enter medical school. I was not taught to be part of organized medicine, and I was not to make a rules and regulation for great state of Pennsylvania. So if we try to change this behavior, and MCI or medical organization can have students start having leadership course at young age, in first year med school, and we create them trustee position so they can vocalize, they can represent. And then as they become resident, we have by state election. So some of us became board of trustee, and we implemented the rules and regulations which were good for our state. And then we go to national level called American Medical Association, which everybody knows. but I don't know what is the status right now, Srivastavji. So if you can bring the positive dynamic change with what we are trying to do, digital health, if that course is implemented with the demand from young people like them, and they are making decision, because problem is we old people don't want to accept what is the new technology. So if we empower them, I think there'll be a lot of leaders for the policy, because we are lacking them between age 30 and 40 in the government of India to represent them, who that is their future. And for my age, for 70 plus, for all senior citizens, their decision will be important. So that is very important to promote leadership for the young first year medical student, resident, then the professor, and there should be quota for them rather than having 50-year-old take a leadership for medical council. We have a student council, and I'm proud to say one of our old Indian descent has become the first time AMA president in the history of 170 years, but he was born in Michigan, Bobby Mukamla. So we need to create more GOSIs who represent students' leadership for changing the dynamics. What Gopi Kishan ji bol rahe the, कि it is difficult to change the politics, but if there are a lot of voters are there with young dynamic votes, I think we'll have a new medical council represented by young people also. So my humble request is to bring the dynamic positive change. Thank you.
Thank you so much, sir. We'll just be able to take one more question after sir's comments.
BLS, but nothing happened that time. It is your time, so that you can recommend to the Ministry of Health Education. And the second program, I am recommending climate change and human health to be put in the curriculum, school curriculum.
Thank you so much, sir. Could you please pass the mic to me? Sure, sir.
Okay, the first question by Ganesh, Dr. Ganesh. I think it is a problem which you have tried to address. It is not a question, and it relates to entirely different area. So this is not the right platform where I would like to respond to this particular question, but I know that there is a problem. The second question was rightly targeted to the topic of this particular session. There are certain facts which we have to keep in mind in India, and let us not compare it what is happening world over. The first fact is that public health or PSM was considered as an inferior specialty in the medical college when I was a student, and it is considered as an inferior specialty even today. This fact we have to keep in mind. The second fact is, are we static or we are dynamically moving forward? As a policy maker who has seen both Medical Council of India as well as the Director General of Health Services, the Health Ministry, I am really very sure that we are moving forward, and moving forward from 2005 onward on a very fast track as far as public health is concerned in the medical colleges. The third thing is the perception of the student changing, or the perception of the students is again static? The gentleman had just said that the student union has started certain programs which are of public health nature. It creates awareness. It was not there at my time and might not be there at your time. I give you another example. Young Doctor Association of India, led by Rohan Krishnan, is an association which has got a online connectivity with at least about 2 to 3 lakh doctors, and they are organizing programs once in a week in which experts come, they talk about it. I have participated in 3 programs and I have talked about 2 subjects. One is public health for the young doctors, how valued it is for the policy planners, for the program planners, for the program executors, and for the public. Because for me, public health is not PSM degree. Public health is something which is concerned with the health of public. And public is not individual. It may be a family, it may be a community, it may be anything. And it will cut across all the specialty. It may be in the pediatric, it may be in the waterborne disease, anything it can be there. I have talked to them. I have tried to give them the message that such type of training programs are available in India. I have listed them the 15 training programs where they are available and what they can do. So this is a forward movement. The third thing is that we had been talking for long time that in the Ministry of Health, Directorate General of Health Services, where there is a subcadre which is known as Public Health Subcadre. At my time when I joined the ministry, 1997, there were 3 persons. While in the cadre of the specialist, there were some thousands of persons, teaching faculty, some thousands of persons, but in public health only there were 3 persons. When I left it, somewhere around 2012, there were about 40 persons, 40. It is not a big jump, but it is a betterment. What I am trying to convey that the things are moving forward. Let us try to look at the regulatory component. The regulatory component has provided large amount of ease of incentivizing those who want to enter into the public health system. And that incentivizing is at the time of opting for the branch in postgraduate counseling. So these are the things which are going on. And that's why I am hopeful that tomorrow we will be able to take care of this particular component of medical graduate. But I am not very much concerned about the medical graduate, because we cannot fulfill the demand of a vast country like India with 1.4.5 billion population. Behind one medical doctor who is PSM qualified or public health qualified or MPH, there are 10 non-medical public health experts which has to be trained. So I gave my full emphasis to that, and I again gave you the same emphasis. So that is the response to your second question. And third question, sir, which is you are starting certain courses which are very relevant, and I appreciate it, but not within the subject matter of this topic.
Thank you so much, sir. We'll just take the closing comment by Siva Ranjani, ma'am.
I'll just
and then we'll
take
proceed.
10 seconds. Ma'am is here. Just request you all to sign the petition, one paracetamol, one strength, India. And to save lives of children. To sign the petition, all schools should be equipped with first aid for choking, seizures, and everybody should know CPR, at least calls. And third thing, previous slide. This kind of deceptive labeling should not be allowed to jeopardize the lives of our children, people with diabetes. So whenever you see me on social media shouting, please say no to these deceptive labels, please support me. That's all. Thank you so much.
Thank you so much, ma'am. Thank you so much, sir. I would request you both to come forward for a group photo.
Thank you, sir. Photo.
Thank you, sir. Thank you, ma'am. So before we move to our next session, we're honored to welcome our chief guest for the day. To formally welcome her and set the context, may I invite Ms. Mevish P. Vaishnav, President, Health Parliament, to kindly come forward and welcome our chief guest.
it is my privilege to introduce Srimati Rahatkar ji, who brings over 3 decades of experience in public health with deep engagement at the grassroots and across local, state, and national governance. She began her journey as a municipal corporator and later served as mayor of Chhatrapati Sambhajinagar, Aurangabad, leading initiatives in urban development, healthcare, education, and women's empowerment. During her tenure as chairperson of the Maharashtra State Commission for Women from 2016 to 2020, she spearheaded impactful efforts to address the social, financial, domestic, and safety challenges faced by women across Maharashtra. I also had the opportunity to work with her on the issues of anti-human trafficking, and I witnessed firsthand a unwavering commitment and action-oriented leadership. A champion of women-led development, she has consistently strengthened implementation and awareness on issues such as POSH, women's safety, anti-human trafficking, and digital literacy. She is a recipient of the National Law Day Award in 2017 and the Savitribai Phule Award, and is also an acclaimed author on women's rights and empowerment. Today, as chairperson of the National Commission for Women, she continues to advance gender justice and women-led development, both of which are central to equitable public health outcomes. It is an honor for us to welcome you, ma'am, and we welcome you to the Public Health Transformation Summit. We truly privileged to have you, ma'am.
आज के इतने महत्वपूर्ण अवसर पर यहाँ पर उपस्थित डॉक्टर राजेंद्र प्रताप गुप्ता, डॉक्टर श्रीनाथ रेड्डी जी, अभी हम हमारे कुछ स्पीकर्स को सुन रहे थे। आप सभी और उन्हीं के साथ साथ आज के दिन भर यहाँ पे जो अन्य अन्य स्पीकर्स आए हैं और सभी मेरे साथियों, आज बहुत खुशी है कि एक महत्वपूर्ण विषय पर यहाँ पे हेल्थ पार्लियामेंट हो रही है। मैं ये समझ रही हूँ कि ये पब्लिक हेल्थ ट्रांसफॉर्मेशन समिट में आप सभी के साथ जुड़कर मैं बहुत ही आशा का अनुभव कर रही हूँ। आज मैं ज़रूर कह सकती हूँ कि भारत केवल बीमारियों से नहीं लड़ रहा, तो भारत स्वास्थ्य की एक नई व्यवस्था बना रहा है और इस परिवर्तन के केंद्र में खड़ी है भारत की नारी शक्ति। हम देखते हैं कि परिवर्तन जब होता है तो कितनी बार महिलाएं सबसे लास्ट रहती है। ये अनफॉर्चुनेट है, बट ये हमेशा हमें ये देखने के लिए मिलता है। पर आज आप देखिए कि अगर इसको भी हम मान के चलते हैं तो वो परिवर्तन उन महिलाओं तक पहुंच गया है जो न केवल अपने घर की आशा स्थान है, न केवल आधार स्तंभ है, तो वो घर की नीति निर्माता भी है और वो अपने घर को आगे चला रही है। आज जब हम इस समय पर बात कर रहे हैं तो हमें ये स्वीकार करना होगा कि विमेंस हेल्थ ये कोई सामाजिक मुद्दा नहीं, बल्कि भारत के विकास की नीति है। स्वस्थ महिला स्वस्थ परिवार बनाती है, स्वस्थ परिवार प्रोडक्टिव समाज बनाता है और प्रोडक्टिव समाज आत्मनिर्भर राष्ट्र की नींव रखता है। यही कारण है कि आज भारत ने महिला केंद्रित विकास को राष्ट्रीय नीति बना दिया है। कुछ दशक पहले जब हम देखते थे भारत में तो थोड़ी सी ये प्रक्रिया बहुत कठिन सी ही लगती थी, मगर आज हमारे देश की तस्वीर इतनी बदल चुकी है पॉजिटिव वे से। आज मैं बहुत अच्छे तरीके से आपको बता सकती हूँ, थोड़ी सी खुशी भी जाहिर करती हूँ कि भारत का मैटरनल मॉर्टेलिटी रेशो घट गया है। ये बहुत बड़ी बात है, पर यह बदलाव कोई अपने आप में नहीं हुआ है। इसके लिए हमने काफ़ी अच्छे प्रयास किए हैं। यह हमारी जो आशा बहनें हैं जो गांव-गांव जाकर काम करती है, उनके मेहनत का परिणाम है। उसी के साथ साथ जननी सुरक्षा योजना, आयुष्मान भारत और उसी के साथ साथ मैं ये कह सकती हूँ कि डिजिटल हेल्थ मिशन और लाखों लाखों डॉक्टर्स, नर्स, इनके सभी के सेवा भावना का परिणाम है। सेवा भावना है, पर उसको लेकर आना भी बहुत बड़ी बात है। भारत ने वो परिवर्तन साकार कर लिया है कि जो जो इसके साथ जुड़ा हुआ व्यक्ति है वो केवल काम के लिए नहीं जुड़े, तो वो सेवा भाव के साथ वो जुड़ जाए। और उसी के साथ साथ एक योजना का उल्लेख मैं भूल गई, जो प्रधानमंत्री मातृ वंदना योजना है। ऐसे अनेक अनेक विषयों को लेकर हम आगे चल रहे हैं। आज मैं ये भी आपको कहूँगी कि गरीब से गरीब आज की महिला भी, सभी के लिए है ये, पर महिलाओं के लिए ज़्यादा बात करूँगी कि आयुष्मान भारत कार्ड के साथ 5 लाख रुपए तक का मुफ्त इलाज आज सभी को मिल रहा है। इसका बहुत बड़ा उपयोग महिलाओं को हो रहा है। मैं ये कहूँगी कि ये केवल इंश्योरेंस की बात नहीं है, तो ये बात डिग्निटी की है। ये डिग्निटी के साथ आज भारत अपने देश की महिलाओं के साथ चल रहा है। आज हम ये भी देख रहे हैं कि स्वास्थ्य के क्षेत्र में विज्ञान और करुणा का बहुत अद्भुत संगम हम देख रहे हैं। ब्रेस्ट कैंसर जैसी जो गंभीर बीमारी है, इसकी पहचान अब शुरुआती चरण में ही हो रही है। नॉन फिजिकल स्क्रीनिंग टेक्नोलॉजीज़ के माध्यम से अब शुरुआती अवस्था में बिना दर्द, बिना संकोच और संपर्क रहित प्रक्रिया से आज हम उस महिला की बीमारी को पहचान करवा जा रहे हैं। इससे अधिक महिलाएं समय पर जांच कराने के लिए आगे आ रही है। खासकर वे महिलाएं जो अभी तक डर या सामाजिक झिझक के कारण पीछे रह जाती है, आज अपनी आवाज़ को लेकर वो आगे बढ़ रही है। मुझे लगता है कि ये सबसे बड़ी बात है कि उनको अपनी आवाज़ मिल गई है, उस आवाज़ को वो पहचान रही है और आगे बढ़ रही है। प्रगति केवल तकनीकी उपलब्धि नहीं है, तो यह केवल एश्योरेंस नहीं है, तो ये भी एक डिग्निटी है। आज मैं बात करूंगी विशेष रूप से हमारे यहाँ जन औषधि केंद्रों की। इसके पहले बहुत कठिन होता था कि जो मेडिसिन लेकर आना है वो मेडिसिन कितना महंगा होगा, पर आज हम देख रहे हैं कि प्रधानमंत्री जन औषधि केंद्र के माध्यम से देश के हर कोने में सस्ती और गुणवत्तापूर्ण ऐसी मेडिसिन हमें उपलब्ध हो रही है। जब एक महिला अपने पति या बच्चे की दवा कम कीमत पर खरीद पाती है, तो वह बचत उनकी शिक्षा, उनका पोषण और उनके भविष्य में वो निवेश कर देती है। ये भी हमने समझ कर लेने की बहुत ज़्यादा ज़रूरत है। यह है हेल्थ से वेल्थ की यात्रा जो हमारे देश की महिलाओं ने शुरू करी है। एनीमिया हमारे लिए एक बहुत बड़ा चुनौती था और महिलाएं तो एनीमिया की शिकार तो सबसे पहले होती है, लेकिन भारत ने इसे नियति नहीं माना, भारत ने इसे मिशन बनाया। पोषण अभियान, एनीमिया मुक्त भारत, मिड डे मील्स और आयरन सप्लीमेंटेशन जैसे कार्यक्रमों ने साइलेंट रिवॉल्यूशन शुरू कर दिया है, जो आज भारत की महिलाओं के जीवन में एक बहुत बड़ा परिवर्तन लेकर आ रहे हैं। नेशनल कमीशन फॉर वीमेन के अपने अनुभव से मैं पूरे विश्वास के साथ ये कह सकती हूँ कि जहाँ महिला सुरक्षित होती है वहाँ वो स्वस्थ भी होती है। सरकार ने महिलाओं की सुरक्षा के सिस्टम को बदल दिया है। वन स्टॉप सेंटर्स, विमेन हेल्पलाइन, फास्ट ट्रैक कोर्ट्स, मैटरनिटी बेनिफिट, नए लेबर लॉज और डिजिटल शिकायत प्रणाली इसके ये उदाहरण है। हमें हेल्थ की जब हम बात करते हैं तो हेल्थ के साथ साथ अन्य जो चीज़ें हैं उसको हमें साथ जोड़ना होगा, तभी उस प्रगति को हम ठीक तरीके से आंक सकते हैं। डर से मुक्त महिला समय पर इलाज कराती है, नौकरी करती है और देश की अर्थव्यवस्था में वो योगदान भी देती है। आज ये चित्र हमें दिखाई दे रहा है। आज भारत AI, डिजिटल हेल्थ रिकॉर्ड, टेलीमेडिसिन और सिटीजन सेंट्रिक ऐप के माध्यम से स्वास्थ्य को हर महिला तक पहुंचा रहा है। नेशनल कमीशन फॉर वीमेन इन इनोवेशंस को हर जिले और हर पंचायत तक हम लेके जाने का प्रयास कर रहे हैं। हम मानते हैं कि महिला माँ है, वो किशोरी भी है, वो कामकाजी भी है और वो वरिष्ठ नागरिक भी है। इसलिए हमारा पब्लिक हेल्थ मॉडल एडोलसेंट से लेके मेनोपॉज तक निरंतर सुरक्षा कवच बना रहा है। लाइफ कोर्स केयर अब भारत की नई पहचान बन रही है। आज महिला स्वास्थ्य केवल स्वास्थ्य मंत्रालय की जिम्मेदारी नहीं है, तो स्वास्थ्य मंत्रालय के साथ साथ स्वच्छ भारत, उज्ज्वला योजना, जल जीवन मिशन, सुरक्षित परिवहन, स्किल इंडिया के साथ भी हम जुड़ गए हैं। महिलाओं का स्वास्थ्य केवल स्वास्थ्य की बात करते हुए पूरा नहीं होता है, इन सभी को हमें उसको आंकना होता है, तभी वो स्वास्थ्य अच्छा रह सकता है। और भारत ने इन सभी विषयों में बहुत अच्छा काम भी किया है। ये न्यू इंडिया की इंटीग्रेटेड गवर्नेंस है, जहां हर विभाग महिला के स्वास्थ्य को मजबूत करने में भागीदार है। आज हमारा स्पष्ट संकेत है, हमारी महिलाएं हमारी शक्ति है, उनका स्वास्थ्य हमारी संपत्ति है, और जब उनकी सुरक्षा हम संकल्पित करके करते हैं तो हम अपने आप में आगे बढ़ते हैं। जब नारी स्वस्थ होती है तो भारत समृद्ध होता है, जब नारी सुरक्षित होती है तो भारत निर्भीक बनता है, और जब नारी आगे बढ़ती है तो भारत विश्व का नेतृत्व करता है। मुझे आज आपके सामने ज़रूर कुछ तथ्यों को रखना है। आप देखिए कि 2025 तक हमने हमारे देश में क्या क्या काम किया है। जब इसको हम देखेंगे तो बदलता हुआ हेल्थ के सेक्टर में भारत कैसे बदल रहा है, ये हम ज़रूर समझ पाएंगे। 39.79 करोड़ लोगों को हाई ब्लड प्रेशर बीपी के लिए हमने स्क्रीन कर लिया है। 39.60 करोड़ लोगों को डायबिटीज के लिए हमने स्क्रीन किया है। 33.57 करोड़ लोगों को ओरल कैंसर के लिए हमने स्क्रीन किया है, और उसी के साथ साथ 15.72 करोड़ महिलाओं को ब्रेस्ट कैंसर के लिए हमने स्क्रीन किया है, और लगभग 10 करोड़ महिलाओं को सर्वाइकल कैंसर के लिए हमने स्क्रीन किया है। आज अगर हम महिलाओं के स्वास्थ्य की बात करें तो सरकार की योजनाओं से जमीन पर हमें बहुत बड़ा बदलाव भी दिखाई देता है, जिसको हमने ध्यान से देखने की ज़रूरत है। आज आप देखिए कि करीबन 90% डिलीवरी अस्पताल और स्वास्थ्य केंद्रों में हो रही है। ये अपने आप में बहुत बड़ी चीज़ भारत कर रहा है। यह बहुत बड़ा बदलाव है, क्योंकि सुरक्षित डिलीवरी का सीधा मतलब है माँ और बच्चे इन दोनों की सुरक्षा है। प्रधानमंत्री मातृ वंदना योजना जो देश में चल रही है, इसके अंतर्गत लगभग 3 करोड़ 80 लाख महिलाओं के हमने सीधी सीधी आर्थिक मदद करी है, ताकि गर्भावस्था में और बच्चा होने के बाद भी उन्हें सही पोषण और सही देखभाल मिले। आयुष्मान भारत के आरोग्य मंदिरों में अब तक करीबन 495 करोड़ बार लोग इलाज और जांच के लिए आ चुके हैं। यही महिलाओं की बीपी, शुगर, स्तन कैंसर, गर्भाशय कैंसर जैसे बीमारियों की करोड़ों बार जांच हो चुकी है, जिससे बीमारी समय रहते पकड़ी जा सकती है। अब मैं एक बात ये भी कहूँगी कि माँ बनने में अब जान का खतरा भी बहुत कम हो गया है। हमारे यहाँ एक कहना होता है कि माँ बनना बोले तो एक नया जन्म लेना है, ऐसा हमारे यहाँ कहा जाता है। इसका कारण ये है कि कितनी बार बच्चे को जन्म देना, एक नया जीव को जन्म देना, ये तो बहुत बड़ी बात है, पर इसके पहले माँ के जीवन को ही कितनी बार खतरा होता था। अच्छी सुविधाएं नहीं मिलती थी तो माँ की जान को भी खतरा होता था। पहले माँ बनना कई महिलाओं के लिए जान जोखिम में डालना होता था, अब स्थिति बदल गई है। मैं ज़रूर ये कहूँगी कि जब 2014 की बात हम करते हैं, तब माता मृत्यु दर जो MMR है वो होता था 130, और आज जब मैं 2023 की बात करती हूँ तो मैं 23 की बात कर रही हूँ, ना कि 26 की कर रही हूँ। थोड़े से आंकड़े थोड़े से पुराने होते हैं, क्योंकि ऑथेंटिक आंकड़े आने में समय लगता है। तो मैं 23 की बात करती हूँ तो आज वही MMR 88 पे आ गया है। 130 से लेके 88 तक आना ये अपने आप में बहुत बड़ी अचीवमेंट है। हर 1 लाख डिलीवरी में मरने वाली माताओं की संख्या अब 130 से घटकर जो मैंने कहा 88 हो गई है। भारत ने 1990 से अब तक इस प्रकार की मृत्यु में 86% की कमी कर दी है, जो दुनिया के जो औसत 48% से बहुत ही ज़्यादा बेहतर है। हमने ये देखना चाहिए कि दुनिया का जो रेट है और हमारा जो है इसमें बहुत बड़ा अंतर है। भारत ने ये अचीव किया है। ये क्यों अचीव किया? क्योंकि भारत ये सोचता है कि हमारी जो घर की महिलाएं है, ये हमारी महिलाएं हमारा आधार स्तंभ है, घर की रीढ़ की हड्डी है। और जब तक हम इनका ख्याल नहीं रखेंगे, इनकी सम्मान की, इनकी गरिमा की, इनकी सुरक्षा की और इनके स्वास्थ्य सेवाओं की हम बात नहीं करेंगे, उसके बिना हम आगे नहीं बढ़ पाएंगे। और इसी भावना के साथ हमारी सरकार ने जो काम किया है वो काम आज के समय के लिए बहुत शानदार है। मैं और भी कुछ मुद्दे आपके सामने रखना चाहती हूँ कि गर्भवती महिलाओं को फ्री इलाज और सम्मान मिल रहा है। सरकार की अनेक अनेक योजना है जिसके माध्यम से आज हमारी महिलाएं सुरक्षित डिलीवरी कर पा रही है। जननी शिशु सुरक्षा योजना JSSK के तहत 2024-2025 में 1.97 करीबन 2 करोड़ महिलाओं को फ्री डिलीवरी, फ्री दवा, फ्री जांच, फ्री एम्बुलेंस, फ्री ब्लड मिल चुका है और हर गर्भवती महिला की नियमित जांच भी हो चुकी है। प्रधानमंत्री सुरक्षित मातृत्व अभियान PMSMA के तहत अब तक 6.85 करोड़ गर्भवती महिलाओं की जांच हम कर चुके हैं और 1.03 करोड़ हाई रिस्क प्रेगनेंसी समय रहते पकड़ी गई, जिससे जान बचने के मौके बहुत ज़्यादा बढ़ गए हैं। मुझे लगता है कि ये अपने आप में बहुत बड़ी बात है। हम अच्छी सुविधा दें, पर उसके साथ साथ जितनी भी महिलाओं की जान की जो रिस्क है उसको हम और कम 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 करते जाए, ये सही मायने में मेरे नज़र से अचीवमेंट है और ये अचीवमेंट हम अभी काफ़ी अच्छे तरीके से पा रहे हैं। आयुष्मान भारत की जब हम बात करते हैं तो कुल 49% कार्ड महिलाओं के नाम पे है। हम इक्वालिटी के साथ चलते हैं, ये केवल बोलने की बात नहीं है। महिलाओं के नाम पे कार्ड करने के लिए उनको ढूंढना, उनके पेपर्स निकालना, अपने आप में अनेक चीज़ें होती है जो कि उसमें थोड़े से चैलेंजेस होते हैं। उसके बावजूद आज 49% कार्ड जो है जो महिलाओं के नाम पे है और अस्पताल में भर्ती मरीजों में 48% महिलाएं हैं। ये बताता है कि इस देश में कोई भेदभाव नहीं होता है। महिलाओं को बहुत अच्छे नज़र से देखा भी जाता है, उनके इलाज भी की जाते हैं। आखिरी एक मुद्दा ज़रूर कहूँगी कि HIV और STI से महिलाओं की सुरक्षा करना, इसके लिए भी हमने बहुत प्राथमिकता दी है। जो साल अभी चल रहा है, अभी ख़त्म हुआ 2025 तक 2.08 करोड़ गर्भवती महिलाओं की हमने HIV की जांच हम कर चुके हैं और उसी के साथ साथ 2.09 करोड़ महिलाओं की सिफिलिस की जांच हम कर चुके हैं और 1127 सुरक्षित STI क्लिनिक हमने पूरे देश में हमने स्थापित किए हैं, जिसका लाभ हमारी महिलाओं को हो रहा है, जिससे माँ से बच्चे में बीमारी जाने का बचाव बहुत अच्छे तरीके से हो सकता है। आज मैं ये कहूँगी कि ये है हमारी सफलता की कहानी कि जहाँ पे भारत केवल बोलने के लिए महिलाओं को अपनी माँ का, देवी का दर्जा नहीं देता है, तो भारत उनके लिए प्रयास करता है कि हमारी बेटी, हमारी बहन, हमारी माँ अच्छे तरीके से सुरक्षित रहे। वो हमारी घर की रीढ़ की हड्डी है, वो हमारा आधार स्तंभ है। ये ध्यान में रखते हुए उनको सम्मान के साथ, गरिमा के साथ उनको अनेक हेल्थ फैसिलिटीज मिले, इसके लिए हमने काफ़ी अच्छा प्रयास किया है। मैं आज ये जरूर कहूँगी कि देश के यशस्वी प्रधानमंत्री नरेंद्र मोदी जी के नेतृत्व में भारत आगे बढ़ रहा है। आज भारत में केवल हेल्थ की बात करके ही मेरी बात समाप्त नहीं हो पाएगी। हेल्थ के साथ साथ हमारी बेटियों को, हमारे महिलाओं को अनेक अवसर मिल रहे हैं, जिस अवसर के माध्यम से हमारे देश की बेटियां आगे बढ़ चुकी है। आज मैं ये कहूँगी कि चाहे हमारी 26 जनवरी की होने वाली, देश की सामने होने वाली परेड हो, उसका नेतृत्व इस देश की बेटी करती है, या दुनिया में सबसे ज़्यादा नंबर 1 की संख्या में अगर महिला पायलट्स कहाँ है तो वो हमारे देश में है। बात इतनी नहीं है, जब बात आती है इस देश की महिला वैज्ञानिकों की, तो इस देश को आगे बढ़ाने के लिए चाहे हमारी इसरो की मुहिम हो या चांद्रयान की मुहिम हो, हमारी महिला शास्त्रज्ञों ने, महिला वैज्ञानिकों ने उसमें बहुत बड़ा हिस्सा भी दे दिया है। और अपने आप में मैं ये भी कहूँगी कि ये एक ऐसा देश है कि जहाँ पे मातृशक्ति की हमेशा पूजा होती है। आज भारत ने जो हेल्थ सेक्टर में प्रयास किए हैं, मैं तो ये कहूँगी कि सही मायने में मातृशक्ति की पूजा आज हो रही है, क्योंकि उनके हेल्थ के लिए, उनके काम के लिए, आगे बढ़ने के लिए, एजुकेशन के लिए, उसी के साथ साथ स्किलिंग के लिए, नौकरियों के लिए हर जगह पे बेटियों को अवसर मिल रहे हैं। पर मेरा खुद का ये मानना है कि ये सभी अवसर बहुत महत्वपूर्ण है, पर जब तक हम उनके हेल्थ सेक्टर में अच्छा काम नहीं करते तो उसके सामने बाकी अवसर थोड़े कम हो जाते हैं। बट ये बहुत खुशी की बात है कि भारत हेल्थ सेक्टर में महिलाओं के लिए बहुत शानदार काम कर रहा है, आगे बढ़ रहा है। नेशनल वीमेन कमीशन की अध्यक्षा के नाते मुझे आज आपको ये भी कहना है कि हमारा भी काम बनता है कि देश की महिलाएं किस तरीके से आगे बढ़ रही है, उनका हेल्थ इंडेक्स किस तरीके से अच्छे तरीके से आगे बढ़ रहा है, उनको सुविधा मिल रही है, ये देखना भी हमारा काम है। उसी के साथ साथ जो सरकार की योजनाएं हैं, इन योजनाओं को जमीनी स्तर पर कैसे उतारा जा रहा है, व्यवस्था कैसे काम कर रही है, क्या सही मायने में महिलाओं को, गांव की महिलाओं को उपचार इलाज मिल रहे हैं, ये भी देखना हमारा काम है। और सरकार ने जो व्यवस्था बनाई है, उन व्यवस्थाओं को आखिरी महिला तक पहुंचाना, वो कैसे पहुंच रहा है, ये भी देखना हमारा काम है। हम ये काम लगातार कर रहे हैं। अभी अभी हमने सोचा है कि आने वाले दिनों में राष्ट्रीय महिला आयोग पूरे देश भर में विमेंस हेल्थ जो कॉन्फ्रेंस है, विमेंस हेल्थ पार्लियामेंट आयोजित करेगा। गांव-गांव जाते हुए, यूनिवर्सिटीज़ में जाते हुए, गांव की महिलाओं को बुलाते हुए उनके लिए क्या क्या व्यवस्थाएं बनाई है, उसके बारे में हम अच्छे तरीके से जानकारी देंगे। मुझे विश्वास है कि जितनी अधिक महिलाएं ये जानकारी लेगी, उतने अच्छे तरीके से वो और भी वो स्वास्थ्य सेवा कर पाएगी। और मुझे विश्वास है कि इसी तरीके से आज जो हमारी देश की शक्ति हमारी महिला है, इसको आगे बढ़ाने के लिए जो प्रयास हो रहे हैं, ये प्रयास केवल भारत में नहीं तो विश्व के पटल पे बहुत शानदार साबित हो चुके हैं। आइए हम सब लोग मिलके हमारे देश की महिलाओं को आगे बढ़ाने के लिए हम मिलकर काम करें। पर मैं आज आपका भी बहुत बहुत अभिनंदन, धन्यवाद करना चाहती हूँ कि आपने इतने अच्छे तरीके से आज इस हेल्थ पार्लियामेंट का आयोजन किया। सुबह से ये शुरू हो गई है। मैं मेरे कलीग्स को मैं पूछ रही थी कि अभी तो 4 बज गए हैं और पता नहीं यहाँ पे कौन होगा या नहीं होगा, तो उन्होंने मुझे कहा कि आप चिंता नहीं करें, लोग यहाँ पे बैठे हैं। जब मैं आई तो मैंने वो अनुभव कर लिया और मुझे बहुत प्रसन्नता हुई। पर इसका दूसरा मतलब ये भी है कि आप अपने विचारों के साथ, आप अपने जिस क्षेत्र में आप काम कर रहे हैं, उस क्षेत्र के काम के साथ आप इतने कमिटेड हैं कि आपने पूरा अपना समय इस विषय के लिए दिया है। आदरणीय गुप्ता जी, मैं आपका और आपके सभी साथियों का बहुत बहुत अभिनंदन करती हूँ। और इसी तरीके से हम जब मिलकर प्रयास करते हैं तो हम ज़रूर ज़रूर आगे बढ़ेंगे। इन सभी कामों के लिए राष्ट्रीय महिला आयोग हमेशा हमेशा के लिए आपके साथ रहेगा। बहुत बहुत धन्यवाद।
Thank you so much, ma'am, for that inspiring and thought-provoking address. As a mark of our appreciation and respect, may I now request Dr. Rajendra Pratap Gupta, Summit Co-Chair, to kindly provide a memento to ma'am. Yes.
Before I give the memento, I also want to narrate 2 of my experience of working with Vijaya Radkar ji. When she was the chairperson of the State Mahila Commission, Women's Commission, she did phenomenal work in women anti-trafficking, and she gets the works done innovatively. She got the guidelines prepared. I was a part of it. Last year I got a call from her, which you should appreciate. She is among the very few genuine politicians of our time. She called me and said, राजेंद्र जी, पूरी नेशनल वुमेन्स कमीशन की वर्कशॉप हो रही है अयोध्या में, मैं चाहती हूँ हेल्थ चेकअप करें, आपको जैसा कर सकते हैं कॉम्प्रिहेंसिव हेल्थ चेकअप हो, उसका आउटकम देखिए। ये आज पब्लिक हेल्थ समिट में बोल रही है, मैं आपको एग्जांपल देता हूँ। नैनीताल स्टेट की एक कमीशन मेंबर का बीपी 200 था, वो हमने वहाँ पकड़ा, उसको पता ही नहीं था। तो सबसे पहले उनको डायस पे जाके बोला आपने मेरी जान बचाई है। तो पब्लिक हेल्थ चैंपियंस ये हैं, और हमको ऐसे लोग, हमारे लीडर्स हमारे बीच हैं, ये हमारे लिए बड़ी बात है। थैंक यू सो मच।
Thank you, sir. Thank you, ma'am. We now turn to a topic that is impossible to ignore when we talk about health systems: Big Pharma in public health. Pharmaceutical companies are among the biggest influencers in healthcare through the medicines they develop, the treatments they make possible, and the resources they command. To talk about public health transformation while keeping pharma out of conversation would be to ignore the reality of our times. And I'm very sure that a summit hosted by Health Parliament will never do that. Without further delay, I would like to invite Mr. Annaswamy Vaidesh, former Executive Chairperson, Suven Pharmaceuticals Limited, former MD, GSK Pharmaceuticals, Mr. Praveen Akinapalli, Country President and Managing Director, AstraZeneca, India, Professor Dr. Nimesh G. Desai, former Director, Institute of Human Behavior and Allied Science, IBAS, Ms. Viveka Roy Chaudhary, Editor, Express Pharma, Express Healthcare, and Express Nutra, the Indian Express Private Limited, and Mr. Ravi Uday Bhaskar, Director General, All India Drugs Control Officers Confederation. I request our distinguished panelists to kindly join us on the stage. To moderate this session, we have Ms. Viveka Roy Chaudhary, who brings a sharp policy and accountability journalism perspective to this conversation. Over to you, ma'am, to take this discussion forward.
I'd ask my panelists to please take their sessions. I'll just make a couple of introductory comments from the mic. Just find it easier to read from the podium. So the session brief is that we will examine the evolving role of the pharmaceutical industry in strengthening public health outcomes. And I'd like to bring everyone's attention to the Access to Medicine Index, which evaluates 20 of the world's leading pharmaceutical companies every 2 years. And it rates them in an index according to their efforts to expand access to their products. Now, what's worrying is that the 2024 index shows an overall stagnation in these companies' efforts to improve access to their essential healthcare products across the LMICs, which is evidenced by an uneven progress across the technical areas. In other words, pharma companies are not investing as much back in public health of the very populations that they see as a market, quote unquote. So how can the conversation shift from go-to-market to access to public health? How much does Big Pharma invest back into public health outcomes? How aligned are corporate strategies with national health priorities? Pharma is arguably one of the biggest influencers in healthcare ecosystems given their financial clout. But do they wield this influence with responsibility and accountability? Accountability cannot exist without participation, and leadership requires the willingness to engage with difficult questions. And which is why this panel discussion is a start towards participation, and I'd really like to thank Dr. Rajan Pratap Gupta, for including such a session on pharma. It's the last session of the day, so I really congratulate you all for being in the audience with us through the day. The advantages that we get to mention what other speakers through the day have spoken. So give me leave to mention what other panelists have, indirectly or directly mentioned the pharma company's role in public health. They talked about the, ma'am is sitting here, she has fought against ORS misbranded and misguided ORS sachets and products marketed by well-known pharmaceutical companies. The AMR crisis, which is at least in part formed by the push from pharma companies to load up pharmacies with antibiotics and not looking at prescriptions. The lack of new antibiotics is also due to the lack of pharma companies to invest back into antibiotic research, because they see it as a 5-day course or a 10-day course of medicines rather than NCD medicines, which are lifelong. So with those comments, let me move to my panel, and we have a very distinguished panel from pharma industry and a mental health specialist. We've talked about mental health through the day as well. So a practitioner of mental health and involved in policies. And we also have someone who's been a quasi-pharma regulator on the export-import side. Mr. Vaidhesh, let me move to you first. You have over 3 decades of diverse experience in the healthcare and FMCG domain. How much really does Big Pharma invest back into public health outcomes? And how aligned are these pharma companies with national health priorities? Could you give us your view on that?
Good evening. Good evening, and can you all hear me? Yeah. So first and foremost, I really want to convey my appreciation to and congratulate our chief guest. She made such an inspiring presentation on women's health and how much impact that our India is doing. So it's quite a moving presentation from her. So she's not here, but I just want to say a great work that's being done. So number one, see, first and foremost, you need to understand healthcare is a very complicated subject compared to all other industry. Because the healthcare, you know very well, it's made up of multiple members in the ecosystem. Whether it is a payer, provider, policymakers, playmakers, physicians, and patient. Now, each one of them have to be aligned to serving the patient interest. So it is not a question of either or. Okay. So unlike in Western world, India, our healthcare system is not integrated where the common interests are not aligned. Okay. Unlike in a developed world where there is a patient care pathway is well defined, standard of care is well defined, and then it's costed out, and then they figure out how to make sure that every patient or the person who is supposed to get a care is well receive the care that is required. So whether good or bad, but the way in which in India it happens is that we all need to appreciate the fact when we gain independence, our average longevity was 37 and 38, if I'm not mistaken. And today, your average longevity has gone up significantly to almost 70. So you all need to recognize the fact pharma industry has played a very big role in making sure that you are able to live longer, right? Compared to many other countries, things have not happened. Today, nobody dies of stomach ulcers. With the advent of, I still remember my GSK days, when ranitidine was brought in, it transformed the way in which your gastric ulcers were treated in the country. So now, similarly, I can go on and on about whether it's an HIV, whether it is even including COVID, the kind of investment the companies have made, pharma companies, in every aspect. Even today, breast cancer, if you look at it, we have made a very big strides in managing the breast cancer. If you think there's only one element in the ecosystem has made a difference, no, not at all. today you are able to manage diabetes so significantly, it's also because the companies have made huge investment in making sure the care is delivered to the patients. Now the question is that, is there a outcome-based data that's available to us? I personally believe that we all need to start having the data, public health data, where were we and where are we today, and what these companies have made a difference. By having a CSR of 1.5 to 2%, in my opinion, it's just a project. But we need to be looking at beyond CSR, how each and every drug, whether it's a tuberculosis, whether it is some lymphatic filariasis, like for example, GSK, we have been working with WHO for eliminating lymphatic filariasis. Nobody even knows. For 15 years, albendazole tablets have been given, more than billions of tablets. Nobody knows about it. So that's a big investment. There's a separate manufacturing that happens only to eliminate lymphatic filariasis in this country. So I think there's a lot of misconception about the pharma industry is not investing back. I think there's a huge amount of investment. Only thing is that you need to skeletonize that information, and so that people understand where do we play and where we should be playing more. I think it's a question of more rather than not having put it back into the healthcare system.
Okay, so in other words, the pharma industry is doing good, but should also be seen to be doing good. So visibility. Mr. Praveen Akinapalli, of course, AstraZeneca, everybody heard about your company during the COVID vaccine times because of Covishield, which came thanks to AstraZeneca and the Oxford collaboration. It's very well documented. But taking out from what Mr. Vaidesh said, spending CSR on health is one thing. And I know your company website lists a lot of projects which you all do under CSR, which is connected to health, whether it is upgrading PHCs, etc., etc. How can this go beyond that project timeline? How do you make it more sustainable? How do you kind of create a mechanism where a pharma company can invest into public health on a more sustainable and in a more long-term manner? Your thoughts on that, please.
Yeah, thank you. First of all, I know it has been late in the day, but fantastic in terms of just the breadth of the conversation, because I think it reminds us the truth about public health, which is that there is constant progress, but it is never perfect. Progress over perfection, and that is just the way it works, and it's very complicated, right? So first, I would actually, in fact, challenge the premise of the question that CSR alone is how in fact, I think the most of our core being is actually about public health, right? Because ultimately, if you think about what pharma does, like if you think about, and I can only speak of AstraZeneca, for example, is our mission is to push the boundaries of science to deliver life-changing medicines. If public health is not that, then what is it, right? Because ultimately, it is about moving the needle forward through innovation that will improve health outcomes. And that is at the core of our business. I think CSR is a very nominal part of what we do based on, but I think what I would say is that we contribute to public health through the core of the purpose of our organizations. And I'm talking about the innovation-based pharma right now, for example. So last year, AstraZeneca spent about $10–12 billion in R&D. Now, that is what is translating into us finally trying to say that, cancer may be curable. Finally, there might actually be a cure to cancer. And I would say that that is a very important part of how you address public health. You take these very challenging questions that have been really impacting health over centuries, and you're saying that we are going to move the needle forward. So I would say that that's at the heart of what we do, is that our overall mission is about improving public health. And so that will continue. Then it is sustainable because that is at the essence of our overall purpose. The CSR related activities, of course, will continue to go up. And one of the things that we do is that we always try to be the catalyst where we prove a concept, but then, of course, leave that to the health authorities to then take that forward, or the state governments to take that forward. So we play sort of a catalyzing role rather than something that can be sustainable.
Okay, thank you for those thoughts. Dr. Desai, as the healthcare practitioner on the panel and as a mental health practitioner with decades of experience in NIMHANS, and you've also had a lot of experience and played a key role in policy on urban mental health and psychosocial services. What are your views on how the pharmaceutical industry has influenced and shaped healthcare systems? Could you give us some views on that, please?
Thanks. If you'll allow me, I'll expand that to larger issues of public health, specifically, of course, coming from my position on public mental health. As you'll all realize, forgive me for my bad throat. I have had a severe bout of upper respiratory tract infection that I'm just getting out of, and yeah, you should take antibiotics. Having flagged that only as a neutral, relatively neutral position. The second neutral position is that I've been a practicing clinician in psychiatry and mental health that includes medicine, and have tried following Srinath for the second half of these nearly 50 years to try and also ride the horse of public health. Srinath isn't too thrilled, be that as it may. No, with me. I want to say that if I understood correctly, and forgive me if I am mistaking this, these two co-panelists kind of took a position that was at least explanatory, if not defensive. If we had our activist friend on the panel, you would have had a very different position. I would really want to take, as is my want and as is my learning, what I would call as a pragmatic idealist position, somewhere of a middle position where psychiatry for clear evidence has benefited hugely from pharmacology and pharmaceutical sciences. Psychiatry would have been nowhere near what it is today, but for pharmacology and pharmaceutical sciences both. I could say that for all of medicine, but some of my colleagues will know better. On the other hand, there is this whole issue of big pharma. When some of us, the first two generations of post-independent India, were undergoing medical education and training to be doctors and or public health professionals, including PSM, commerce was a bad word. Commercialization was a much worse bad word. Much worse of an abuse was corporate and corporatization. Let's accept it. By now, that's a reality. That's a reality that we'll have to live with. Does that always bring in problems? Sometimes it does. And allow me to cite one or two examples. I think you all might remember what happened through the COVID epidemic and the exploitation of human suffering. But one thing that I've never been able to get out of is, and friends, reliably known that following World Trade Center collapse. Oh, thank you. Oh, thanks. Thank you. Is that better? I thought it was only my throat. Following the World Trade Center collapse, the three major pharma giants in the US trebled their TV promotion budget for tranquilizers. Mind you, I'm not talking about increase in sales, which can happen. People are suffering, so go and take tranquilizers. Over-the-counter purchase. Prescriptions can increase. But here are pharma giants trebling their TV promotion budget for tranquilizers. So at one level of consideration, and I'm sure you'll agree, this could be termed as capitalizing, if not monetizing, human misery. At one level of conceptual framework. And yet, the realities of what these two friends have said and a whole lot of other benefits is also undeniable. So I would really think that we need to look at the triangle of science, of pharmacology and pharmaceutical sciences, and the whole trade structure that comes with it by now. So the science of it, the human welfare that we are all here for, and the commerce angle of it. The trouble, I think, is when it becomes big. It's the corporatization that brings in a whole lot of difficulties that we are also uncomfortable with. Now, are there solutions? I think there are. I think there are. Like our chief guest mentioned, and believe you me, for the last 5 or 10 years, I buy medicines, whatever little I need, thankfully, not too much at all, only from the Jan Aushadhi Kendra. I do not buy medicines from the regular shop unless they don't have it. So I think PM Jan Aushadhi Kendra, to a whole lot of such ideas, are good solutions. whole lot of what Public Health Foundation and a whole lot of other agencies do are good solutions. I would say, ending this part at least, that we will have to learn to live with this elephant in the room, so to say, with all respect to all concerned, and learn to ride it well enough. You remember those exhibitions and melas where you have this bull where you are supposed to ride, and they keep playing it around, and most people fall down. Very few people can sustain that for a few minutes. Will human race, will we in public health field be able to, somewhere with the governance help, be able to strike that good balance between commerce, science, and public welfare? I hope we will. Does that make sense, or did I miss out on it?
No. That makes perfect sense. And I thank you, Dr. Desai, for taking both rounds. Actually, I'm going to do a second round on recommendations, but thank you for taking, putting your recommendations in your answer itself. We have around 11 minutes. And I move to my last panelist, who's waiting very patiently. What do I say about this person? He's done a lot for the image of, India as a pharmacy of the world, because thanks to when he was in the post of Director General of Pharmexil, Mr. Ravi Uday Bhaskar has really, taken Indian medicines across the world. And he's also spoken up very emphatically on the quality of those medicines. In fact, it was not his mandate, but he did ban one of the companies which was making the cough syrups which caused deaths of infants abroad. So, Mr. Ravi Uday Bhaskar, your views on what has been the influence of pharma companies on public health, and could you also attach your recommendations on how we could and how the government can create policies which can really put in place, strict mechanisms to ensure that pharma does give back and support public health national priorities?
Thank you, Viveka. This is the last session as well as I am the last panelist. So don't mistake me, I developed the shivering just because of my service in the government for 36 years, and internal conflicts and anxiety and stress has made me to shiver. So I will try to control it, but don't take it as it's my disorder. But whenever I was talking something from my heart, I always have this problem, I welcome it. So here, Rajendra Pratap Gupta has clearly mentioned about the Big Pharma. I'll confine myself to the Big Pharma located in India. We have to place it on record. The contribution of the Indian pharmaceutical industry for the public health in India is immense. You cannot say that, what they are doing is not correct. But when it comes to the public health, what I feel, they are doing business. The business always go in the calculation of profit and loss. So India is giving more benefit to the global market rather than the Indian consumer. That's what I feel. So if you take the United States, in 2022, we exported $7.1 billion worth of drugs to them, but their savings to their healthcare is that $219 billion USD. And in the last decade, as per the IQVIA report of 10 years, USA has saved 1.3 trillion by buying generic drugs from India. So Indian pharmaceutical industry is doing good job. At the same time, they are more calculated in terms of profits and loss. If you see the major pharmaceutical industry in India is spending some money on research and innovation, and they are trying to give the new drugs, and they're working on that. But the average spending is 4 to 7%. If you compare with the global spending on research and innovation, is around 15%. Yeah, 15 to 20%. So our Indian pharmaceutical industry, what I observed, whatever money they are getting, they should not have any risk. They can't wait for the returns. They are focusing more on diversifying their profits which are coming from the public. We witnessed as a regulator, when I joined directly from the university, I observed most of the manufacturers, the top pharma houses today, they've started with not even 10, 15 crores. Today they are almost, 20,000, 30,000 crores. In that process, they help the Indian population, but at the same time, their vision, take for example, the import dependence. Viveka, I'll cover and you need not come
please,
back to me again. Yeah.
Absolutely. No,
Yeah.
no, no.
So
From you, we will go back through the panel. So
yeah.
please,
The major problem is that, even though we are exporting $30.47 billion in the last financial year to more than 200 countries, our exports are almost, more than our domestic market. Do you think that the people in India who are really they're having an access to all these medicines and at the same time are available or affordable? What makes the government to start Jan Aushadhi? The reason is that the drugs which were sold in around 7 lakh pharmacies in India, the cost of the drugs are more. That is the reason government has floated this Jan Aushadhi. So they need, instead of giving an alternative to the commercial pharmacies, government has to think about the price control. Take for example, when she was talking about the ethics, I'm not going to go back to Nexavir and all those issues. Very recent issue with, the spinal muscular atrophy. The drug, risdiplam. Risdiplam of Roche is almost 18 crores per year. That is, if the NATCO has fixed that price for 15,900 per month, that is coming around 18 lakhs or something like that. So for that, the Roche appealed in the court and they contested. So here, the public interest is much more than the patents. So in that, some Indian companies are fighting for the benefit of the people. At the same time, the pharmaceutical industry, we conducted one report on overseas foreign direct investment. Once it comes to the question of healthcare, we have to think about the global population. Our investments in unprivileged countries, poor countries, low income and middle income countries, we are not paying any attention. We are more bothered about the European market and we are more bothered about the American market, where we are going to have more profits. Take for example, what makes India to leave that active pharmaceutical ingredients and intermediates and basic chemicals to China. We were doing that very well in 1990s. We were not dependent. Now 75% of our APIs, intermediates and basic chemicals we are importing. The reason is that we observed if you shift from API manufacturing, intermediates manufacturing to the generic formulations, you will have more profit. In that process, they got more profits. In the process, India lost the privilege, just like Europe left their chemical industry. Now, if China stops supplying these APIs, basic chemicals, and intermediates, you are nowhere. You can't call yourself as a pharmacy of the world. So this kind of the miscalculations, which were not properly guided by the government, and we closed the industries like IDPL and all. The government need to think about public health means the government also should have a responsibility to balance. At the same time, we need to feel very proud of Indian pharmaceutical industry, and at the same time, they need to move forward. They have to take the public interest at the top rather than the interest of the companies. Thank you very much.
Thank you. Thank you. Moving quickly down the panel again, we've got 2 minutes as per the clock. But I'd like you all to restate. I know that in your opening comments itself, you all have mentioned your recommendations. But Dr. Desai, if you could give your recommendations quickly.
One, sorry. I'm sure you can hear me, right?
No, the mic won't pick it up.
Don't try the RDPL model. Most of us here may not know the IDPL. The Indian Drug Pharmaceutical Limited developed in the 80s near Dehradun went kaput completely. It didn't work. So don't try and replace the commercial sector with IDPL kind of thing. The famous Yogacharya, again from Dehradun region, who has plenty of nutraceuticals and pharmaceuticals, I guess at least is keeping the capital in. Keep the capital in rather than flowing out. Two, most importantly, honestly, track the unholy nexus between the pharma industry and the doctors and the healthcare. Let's face it, there is some amount of holy nexus, if one might call it, but there's a huge amount of unholy nexus that needs to be tracked, and that we are not doing at all. We're just doing patchwork there. Encourage more rational use of medicines, psychotropics, painkillers, antibiotics, all, like I give you my example at the start. Can we, in part, as part of that, not let people go for quick fixes? We all want quick fix. Pain relief, bit of depression. I don't know how many of us remember Prozac story. When fluoxetine, the first active antidepressant came up, if you had a fight with the spouse at home, you take a pill. If your boss gave you a bad time in the day, you take a pill. The similar thing happened with sildenafil, right? So we need to educate people to not do that. Can we really get into more genuine collaborative decision making in clinical practice, between patient and the doctor, alongside the rational use? And lastly, the big dilemma, I think, is what my friend referred to. We would love to have Indian pharma industry make more money for the country. But the moment you do that, obviously the effect is going to be here too. So that's a big dilemma. How do you encourage Indian pharma industry to dominate the global scene, as he called it, let India be the pharmacy of the world, for the world, and yet we don't want excessive drug use here. I don't know how.
So pharmacy of the world and pharmacy of India also, but balance the use and rational use of pharmaceuticals. So moving now to the two pharma execs on our panel, Mr. Praveen.
Yeah,
your
I think,
recommendations.
so look, we're in a public health forum, so let's talk about facts and data, right? So when you start with, you look at life expectancy, and we started with that. It was 50 years, maybe by about 30 or 40 years ago, now it's 70. And across the world, it's gone up. And you say, okay, what has driven it? Clearly, there was infant and child mortality that got better. But once you become a little more prosperous, I think the real driver of increases in life expectancy have actually been the benefits of cardiovascular disease management, for example, reduction in strokes, reduction in heart attacks. And what has caused that? Statins, a lot of different new medicines. And where did they come from? They came from Big Pharma, right? So, and the reason I make that point, and now we're finally talking about cancer being a chronic disease, not a life, a death sentence the way it used to be. Again, why is that? Because of amazing innovations that are happening. So I think, look, Big Pharma that is truly based on science and innovation and pushing the boundaries of science to deliver new medicines is what moves the healthcare forward. And that's a fundamental driver of improving public health across the globe that we need to feed. But the balancing fact, which I think was very rightly pointed out, is then how do you enable equitable access, right? So this is one of the toughest questions in healthcare. So there is no easy answer to it, but it is important not to come to hasty conclusions on an answer that doesn't exist. So I think it is a progress that we need to constantly drive. It has to be, based on innovation, because if you have no innovation now, you will have no generics tomorrow. Tomorrow's generics are based on today's innovative products. So ultimately, the fundamental engine that actually drives all of this is innovation. Innovation is risky, and there's always ways. Hopefully, AI is going to actually help with that right now. We are hoping that it is going to make it much more efficient and less expensive, hopefully, eventually. So I would say those are the two big drivers, is that we have to constantly support innovation, but we have to work together to figure out ways on how do you enable equitable access of that innovation.
Thank you. Neatly summed up. Mr. Vaidesh.
See, fundamentally, healthcare is the one subject where we deal with dichotomy. One is public good, Jan Kalyan, other one is profit maximization. Now the question is, those who come in to do public good at the end of the day, they also end up in trying to maximize. Sometimes people err on the extreme side and they end up being a villain of the society, right? So it's a kind of a balance that society tries to make. I happened to work with the Communist Party School of China for about 3 years, looking at healthcare financing for China, like the way in which we do in India. One of the things that they did is that we will not come up with our own healthcare financing model. In fact, you need to remember, a healthcare issue is not about public health or a general health. It's about how do you financing the health burden, right? So we need to split that. Now the problem comes when you don't have the financial model to deal with the health burden, then we start abusing pharma companies, we abuse so and so person.
The bigger the target, the bigger the, so
we
Big
start
Pharma has a
thinking,
big
oh, you are
target on
making
its
money,
back.
corporate hospitals are making money. So now we need to split these two. One is financing model that is required for your country, right? So we did that in China, where 8 countries were identified: Germany, Canada, USA. Each country has its own unique way of managing the healthcare financing, right? Now the question is that some are successful, some are badly off. Like for example, US is not in great shape. Nobody would like to follow a US model of healthcare financing. German model is pretty good in terms of, we have a professor sitting here, he knows more than anyone else about the public healthcare financing. So what is very important thing is that we should not throw the baby with the bathwater, right? Today you have a model that is functioning, right? Whatever the financing model. Like you have a Jan Aushadhi as a way of managing your medicines being given, Prime Minister's model on taking care of below poverty. So everybody is trying to figure out some model. The way in which I look at it is, let's not try to say this is wrong and that's right. Instead, we should say what is good for our country. Like for example, India is a health is state subject. You go to Tamil Nadu. Tamil Nadu is following one of the best healthcare model. Now, why can't I replicate that in other states, right? Now, if you ask me, we don't follow our own models, or Kerala or any other state that is having a model. Frankly, in my opinion, you have got a lot of islands of excellence in our country. Why can't we replicate those models, right? COVID, we had a fantastic model of integration the entire healthcare system. As soon as the COVID is gone, pandemic is gone, now it's all gone back to the state. Because during COVID, through the special gazette, central government took charge. Now the entire patient care pathway was well defined by central government, and the drugs, protocol, everything was defined, financing was done. Fantastic. We could manage and manage to keep the pandemic in control. Now, if you ask me one suggestion, please bring back the model of what we did during COVID of integrating healthcare of all the players, whether it's a pharma company, whether it is a policymakers, physicians, everybody knew what is expected of them. If you go to a doctor, he will tell you, you are suffering from COVID, this is the protocol. This is a drug that you need to take. There was no difference. Though there were abuses here and there in some places, frankly, in my opinion, we got a fantastic working model. Now, we need to figure out not to throw away the success model and start implementing it for almost every disease state that we have in the country, whether it is for diabetes, whether it's for weight loss program. Now, Monjaro is becoming very popular. Now, everybody is wanting to reduce weight. Now, randomly doing something, I would recommend that if at all government can do something about it, please bring back the model, successful model of COVID that will help us in managing our country. We managed it with less money, right? In a sense, the entire country was in full control compared to the rest of the world. So that would be my first recommendation.
So could I add just one comment, because there's been so much about COVID,
Yes.
and of course, AstraZeneca brought Covishield, right? Now, if the story behind it is that clearly we were actually not even in vaccines. That was not something that we were looking to do. We only did it because Oxford University and the government of the UK at that time said, look, we need some big pharma to do it, and it was done at no profit globally. Now, the reason AstraZeneca could do it at no profit was because we actually had a bigger business that would be able to support it. So I think that is where I think you've got this public-private partnerships, and ultimately you do need the resources that will drive innovation and can also bring that innovation across the globe. And I think that's where Big Pharma would have a place, just like I think lots of the other players within healthcare.
Yes, and also the role of Serum Institute of India, which is, an Indian player, again, playing its role beautifully. So on that note, I'd need to end because I've got a love note from the organizers.
I know, sorry.
Any open comments? Yes, please.
Regarding cerebral palsy, we had a drug, BONT, botulinum neurotoxin, 30 years ago. But we could not use it because it was 25,000 rupees 20 years ago. Why it was so? Because it was being used in beauty and skin crease and all that. So why it happens that the drug which is used for beauty treatment by non-doctors say, it has stopped the cerebral palsy children to walk. Why it is so? Why can't there be a divide?
Thank you. One more comment, please.
We have an
I
open
think
mic
we have
coming
3
up.
comments.
I
Can
guess
we take
have an
all
open-
3? Yeah.
My question is, Ravi Shankarji, you are amazing. Your solution, if we make all the API in India, it will benefit the world, because China is like a controller for entire world. And as you said, policy is very important. What is your suggestion how to curb that wild elephant who is roaming entire world and destroying? So if we make API in India, what would your suggestion to Indian government and US government, how to become self-reliant?
In one sentence, sir.
We suggest so many things to the government, but government will act on their interests. I'm very sorry to say that. I'll quote one example of Dr. Sivaranjani. Yes, you are talking about ethics. When she won the case, FSSAI has given a decision in her favor. Despite that, one of the manufacturing companies went to the court telling that I have a stocks worth of 100 crores in my godown. You allow me to sell this. That itself shows very nakedly about the, some industry may be exceptional, that is very naked anti-people stand of the pharmaceutical industry. I'm very sorry to say that.
We have a...
I want to say something here. Not only that, now the rebranding is also so deceptively similar to the original branding. I mean, they're not ready to just stay ethical, and like they can still sell, like, ethics, that's all. We want ethical business. Business is business for profit, but stay ethical. Don't play with public health. That's what I want to say.
Thank you. And to the gentleman standing patiently, thank you so much.
I've got one suggestion. We are Ramesh Verma from Mary Health startup on community health. Now, one good thing which has happened is about generic health, generic medicines. But generic medicines have created its own problem because the doctor is not recommending those names. So the patient does not know what he's taking, and at times if he's taking 3 or 4 medicines, there is a lot of confusion. So this is some small fundamental thing which will make a lot of change, which need to be adopted. Thank you. That's it.
Thank you. Thank you.
Maybe if I could answer that
Yes,
question, right?
please,
Which is,
please, yeah.
I think it is really important because, like, a lot of, I'm sure, Big Pharma, like, there's a lot of very strong commitment to ethical behavior. I think the challenge sometimes is that pharma is a broad label for a wide range of companies. So I think it is important to differentiate, in terms of ensuring, first of all, from the industry to be committed to ethical behavior, and from the public, I think, to understand that it's a very broad range, and there are certainly a lot of commitment, I think, from Big Pharma, at least, which is what we're talking about. And I can only speak for AstraZeneca, where, 100%, it's always about trying to do the right thing, and we do our very best. So I think that's the other thing that from a public perception, sometimes sort of puts it a little bit of a challenge.
I want to quickly say
Yes.
that I have a book that's called Oxymoronica. This professor of psychology has put together all the phrases in the Indian language, English language, that those are oxymoronic. So I am reminded of that book. What Rajan has given to us and all of us is an oxymoronic problem to solve. Business, commerce on the one hand, and welfare on the other. Who will bell the cat is not the question. We all want to bell the cat reasonably. Will the cat be belled at all?
I think the organizers are really been very patient.
I know
Thank you.
this session is going to go on, very interesting session, but
One minute
unfortunately we are out of
solution.
time.
Basically, if allowed to print the name of what the doctor has written on the prescription, if that can be printed on the medicines, that will solve the problem.
Yeah, we have an open mic session coming up very soon. So
Yes. Yeah. Okay.
thank you,
So,
panelists. Thank
yeah,
you
thank
very
you.
much
Thank you, sir.
for a very insightful discussion. I now request the panelists to come forward for a photo. Thank you, panelists. I now call upon Dr. Sabir to guide us into the next session. Very exciting session coming up, guys. Thank you.
Thank you, audience. You've been very patient, and finally we are here for the open mic session. So all your questions, discussions, it's all open now, and I would request people who have not questioned or put forth their points to stand up and put forth your points. We are running short on time, so please be very crisp and brief in your questions. And to guide this discussion forward and respond to your inputs, I invite our summit chair, Professor K. Srinath Reddy, and our summit co-chair, Dr. Rajendra Pratap Gupta, to kindly join us on stage. In this open mic, you are invited to share one idea that you believe can transform public health in your context, and to respond to something you heard today, what resonated with you, what you disagree with, or what you think needs to be taken further. And also offer a question or a challenge that you believe we must collectively confront. And you have our summit chair and co-chair to answer everything for you. Please engage in this session.
So let's not waste time, use the time we have at hand to attempt to answer your questions. We may not have answers, I can tell you. That's the rider first. As co-chairs, two things to riders first is totally out of my cognitive abilities at this point in time. But you're so excited. One thing I want to appreciate those sitting back making notes. You actually helped me fulfill the objective by making the best use of this summit. So first salute to you. Please shoot your questions.
Hello.
Can you please pass on the mic?
So
Yeah, you after him you can go. He was just waiting for that. Yeah.
I'm Ramesh Verma. Sorry, I introduced myself earlier also. Basically, public health will improve significantly by the use of AI right at the last mile. Now, there is a challenge that at the last mile, people need to be trained, and we need to accept whether they can take certain decisions which were earlier taken at the health professional levels. So I would like to know how to go about that so that we don't make a mistake. At the same time, the opportunity is great to change the impact, but we need to be careful on that. That's all. Thank you.
You're absolutely right, sir. a lot of technologies are coming in at a breathtaking pace, but the health system has not kept pace, both in terms of preparing the people at the other end, whether they are frontline health workers or whether they are people who are working in the hospitals, to appropriately apply those technologies in a fairly discriminant fashion, understanding what the advantages and disadvantages are and where the pitfalls lie and where the positive benefits lie. So it's absolutely necessary for us to train people right from the very beginning, whether they're in the medical college or already in the profession, and even the nurses and the frontline health workers in appropriate use, because even as technologies are evolving at a breathtaking pace, unless this training also is provided, we are going to have a lot of problems in terms of the nature of application. So there has to be a co-evolution of both the health system as well as the technologies. One cannot outpace the other, because then there'll be a serious gap in the nature of application, and that can be to the disadvantage of public health. So I believe institutions must resort to training right from undergraduate level, whether it's medical students or nurses or community health workers, and preferably not only as individuals but as teams. And there must be continued training, continued professional development type of education for those who are already working within the system. And this responsibility lies across the board with government institutions as well as with the private institutions.
We are expanding to a level that these people cannot be trained in the colleges. We are looking at an ASHA worker or an A&M worker taking that decision with because the AI is equipping her to take a decision. So that is a training challenge. Some training, good training to the person. Probably Health Parliament need to run a small 1-month course or something like that, or the National Skill Development Council.
No, I'm not only talking about those who are in training, but those who are already positioned in the system.
No, I'm talking of the new community health workers who will come up, which will be doing
Sure.
Sorry.
Thank you. No issues. I think we'll still have time on the high tea that we have after that. So we have to see this. ISE has very strange rules. At 5:15 we have to vacate. So let's try. I think this side, and we have this. Yeah, yours.
We can have ma'am first. Yes.
Yeah. Good evening, distinguished panelists. Thank you so much, Dr. Gupta and Dr. Reddy, for this amazing discussion. My name is Mridula, and I come with the lived experience of 33 years with type 1 diabetes. So being a nanotechnologist turned into a public health professional and working, first of all, I was not eligible to pursue public health in India. So I got full scholarship to study in Israel. And this was very disheartening, because this was more of purpose-driven. Public health is not like just a course to be done. Some people come with lots of passion. Being an engineer turned into a public health professional and working around not just in India but across the world, that is something that I really wanted to point out. So I have an organization, community-led organization for people living with type 1 diabetes and other types. Unfortunately, sir, recently we discussed in the last panel about using Jan Aushadhi Kendra medicines. Doctors don't prescribe those medicines very often. We are left with, as a community, as a not-for-profit, we are left with no choice but to ask for funds from CSR, and that also again counts for very less numbers. What could be done over here where we as a community want to push people and make them comfortable with the generic medicines, but the trust doesn't go with us only. It's always the doctors first. Second, sir, GST reforms recently, Nirmala Sitharaman madam mentioned that the GST from 18% has dropped down to 5%. So you know what happened at the grassroots level? The pharmacists, the pharmacy people, they increase their margins, and still we are receiving the same insulin almost at the same price. Maybe 100 or 200 rupees deduction has been there. So sir, how do we regulate that? For mentioning it that yes, from 18 to 5%, that's a big gap, but at the ground level, at the grassroots level, it doesn't show up. And like Dr. Shiva Ranjani ma'am, mentioned about the ORS issues. So several people, especially children living with type 1 diabetes, and they landed up into diabetes ketoacidosis because they were having
And we'll have to
consuming
cut
such
short.
water.
What we can
So
answer
the-
only one.
yes,
Yeah.
yes, yes, yes.
Dr. you want to
So
answer
just
that?
wanted to mention these.
So I
points
think
and-
one is that there are patient groups like you that do the job. We also have patients union to create awareness about things, and definitely technology will play a key role in democratizing the information for action. But I think it can't be done by the interested parties. You can expect that it will not happen. It will be people like you and me to do that, and we will do all within our ambit to do it.
Yes,
Yeah. Thank you. I'll take the last one because we'll have to now move. We will do at the high tea. We have full time. No one is going to ask us to leave. Yeah, please.
I'm Kadiatu Mansare, student at Northern International University, studying Master of Public Health. I'm from Liberia. Firstly, I want to congratulate all the presenters that presented today on public health transformation. My question here is, to Public Health Transformation Summit 2026, Health Parliament, what are your mission, intention, and that of ambition to this global institution? Second question here is, I'm a public health worker, and sometimes I go choose stress, and in terms of public health or Public Health Transformation Summit, how can I manage my stress in terms of health? Because in my country, I noticed that people live normally, they are not sick at all. But after some days, you just heard that this person passed off, this person died, without them getting sick. Maybe it might lead to stress, because when you are stressed up, sometimes people hide themselves. They don't want for people to see them. Or sometimes they try to do something that is not good for their health. So in terms of public health transformation, how can I manage myself in that situation? Thank you.
Thank you. On the mission, I'll tell you very clear two objectives. One is that we need to get the public health system for the 21st century people, which also includes answering your second part of the question, is that the system should be able to handle that. And the second is to create a pipeline of leadership. As you saw in the entire day of deliberations, we were at loss to find leaders in their 30s and 40s to come and speak. Our goal as Health Parliament, I and Dr. Reddy got together, say, should we not create a pipeline of leaders who will take on the mantle to create the health system of 21st century? So that's what I wanted to do. Thank you.
Thank you.
Yeah.
Thank you so much, everyone. For any further questions, you can always write to us at contact@parliament.health. And all our social media channels are always open, and we're very prompt in replying you all. So do reach out to us on maybe LinkedIn, Instagram, wherever you find Health Parliament. Moving on, as we come to close the Public Health Transformation Summit, I would now like to invite Ms. Mevish P. Vaishnav. Just a second, please do not leave. We are still left with vote of thanks before we close for the high tea. So I would like to invite Ms. Mevish P. Vaishnav, President, Health Parliament, to deliver the vote of thanks. Ms. Vaishnav is a senior healthcare professional with extensive experience across cancer care, health policy, and digital health. She has served as Vice President of a leading cancer care hospital chain, contributed to the development of digital health standards for 2 ministries, and led the Women for Digital Health campaign at Health Parliament. She also has been represented India at the United Nations Commission on the Status of Women. Ms. Vaishnav, over to you.
Good evening, everyone. Thank you for staying with us till so very late. I appreciate your patience to sit through a full day of serious conversations with curiosity, and the conviction to contribute the important discussions. With such committed professionals, we are sure 21st century is being created for public health system. I'm also deeply grateful to the governments and delegations from the 13 countries and to their excellencies who took time to be with us today. We would like to place on record our sincere appreciation for the presence of His Excellency the Ambassador representing the Republic of Benin, His Excellency the High Commissioner representing Jamaica, the Charge d'Affaires representing the Republic of Togo, the Charge d'Affaires representing the Republic of Iraq, the Deputy Head of Mission representing the Republic of Lithuania, the Minister Counselor representing the High Commission of Sri Lanka, the Minister Counselor representing the Republic of Indonesia, the Minister Counselor representing the Republic of Angola, the Counselor for Health and Social Policies representing France, the Counselor representing the State of Palestine, the First Secretary representing the Republic of Chad, the Second Counselor representing the Republic of Guinea, officials from the Embassy of the People's Republic of China, including the First and Third Secretaries. We deeply value your presence. Our summit chair has been very helpful and guiding us. I would like to express our deepest gratitude to our summit chair, Professor K. Srinath Reddy, founding president, PHFI. Sir, your lifelong leadership gives this moment its moral authority and intellectual backbone. Thank you for guiding this summit with clarity, credibility, and conviction. We are honored by the insights on our keynote leaders by Dr. Vinod K. Paul, member Niti Aayog, Government of India. Thank you for reminding us why this moment is pivotal for India's public health future and why action can no longer be delayed. We also sincerely thank Shri Bharat Lal, Secretary General, National Human Rights Commission, for reminding us that public health is inseparable from human rights and dignity. Sir, every time we have reached out and you have always been supportive and accommodative. Thank you for the generosity of spirit. A warm appreciation to our chief guest, Srimati Vijaya Rahatkar ji, Chairperson, National Commission for Women. Ma'am, thank you for bringing the lens of equity, women's health and leadership. My gratitude also goes to a very distinguished speaker, moderator and panelist who brought substance and sincerity to today's dialogue. You did not just speak, you contributed to the direction. I would also like to acknowledge our partners and supporters, Brook India, Dynamic Coalition on Digital Health, NHRC, AFPI, CAHO, MSAI, IBHAS, and AstraZeneca for standing with us and strengthening this summit's impact. And a special thank you to our media partners, Express Pharma and Express Healthcare, for amplifying this conversation beyond this hall into institutions, boardrooms, and the national discourse. To our delegates, policymakers, public health professionals, clinicians, innovators, academia, civil society, and students, thank you for giving us your time to this day, your attention, and your intent. Because this transformation is not built by speeches, it is built by people who show up and then follow through. As we close, I would like to remind with one thought: please don't let today remain a memory, let it become a commitment. Early in 2026, we have taken a collective call to action to make public health fit for the 21st century. This is our responsibility. This event or this summit would not have been possible, and I would like to give a special and heartfelt thank you to our summit co-chair, Dr. Rajin Pratap Gupta, founder and chairman, Health Parliament. Your vision to reimagine public health, bring bold ideas into center of discourse, and translate them into action made this PHTS 2026 possible. I hope you really had a good time. And this would not have been possible without my team. A big thank you to my team. I would like to invite on stage Dr. Manpreet, Akshita, Sakshi, Dr. Sabhya, Palak, Ambika, Hitanshu, Anshita, Eben, Kritika, Dinesh. Sir, we would like you also to join us. This summit would have really not been possible without this team. Thank you.
See, they did the work, I got the claps.
Please join us for the high tea. Thank you.
Anyways, just in case we have any students left, the student certificates are being provided in physical, in person at the registration counter. So all the students, please collect your certificates from the registration desk. To everyone else, your certificates would be mailed to you as a virtual certificate within 15 days. Thank you.